Management of grade 3 compound diaphyseal fractures by the Dr. Vamsi. Please go ahead.
Okay, sir, we are starting the first video of Dr. Vamsi's.
Yeah, you proceed.
Good evening, each and everyone. Today, my topic for paper presentation is role of antibiotic-coated intramedullary rationale in the management of grade 3 compound diaphyseal fractures. Open fracture is a fracture that communicates with the external environment through skin opening. Open fractures usually result from high energy trauma and are characterized by variable degree of soft tissue and skin injury, both of which impair local vascularity. Antibiotic-coated intramedullary rationale is one of the options available for early management of grade 3 compound fractures. We prospectively studied 20 newly admitted cases of grade 3 compound diaphyseal fractures during a time period of 2 years and managed early with antibiotic-coated intramedullary rationale. All the patients were in the age group of 15 to 50 years, out of which 13 were male and 7 were female. A later soft tissue management was done earlier by the use of primary closure or grafting or a flap, and followed up by 6 to 14 weeks for checking bone union and wound healing. The principles of treatment of open injuries have gradually evolved over the centuries and many advances have come. Functional restoration is aided by aggressive wound debridement, early definitive fracture stabilization, early wound closure or cover to achieve bone and soft tissue healing as soon as possible. Functional outcome depends on patient factors, injury factors, and patient's comorbidities. The most commonly used classification system for open fractures is Gustilo-Anderson, which uses the parameters like wound size, magnitude of the energy transfer, degree of contamination, presence or absence of neurovascular deficit. As per Gustilo-Anderson classification, type 1 is a wound with less than 1 centimeter and it is clean. Type 2 is more than 1 centimeter, which is moderately contaminated. Type 3A is usually more than 10 centimeter, highly contaminated, crush injury with a proper soft tissue coverage possible. Grade 3B usually is more than 10 centimeter, highly contaminated, very severe loss of cover with periosteal stripping. Grade 3C is usually more than 10 centimeter, highly contaminated, very severe loss of cover, and vascular injury requiring repair. Treatment protocol followed usually for compound tibia fractures are grade 1 and grade 2 fractures are managed by definitive fixation by interlocking nail tibia. Grade 3A by external fixator or interlocking nail. Grade 3B either by external fixator or antibiotic rationale. Procedure for preparation of intramedullary antibiotic rationale. We need 32 French size chest tube, gentamicin bone cement, 3.5 or 4 mm rationale of length 30 to 38. On the left side, we can see a 32 French size chest tube and a rationale. Gentamicin containing PMMA cement is mixed with monomer until working phase of the cement is achieved. The rationale selected is inserted into a slit chest tube and bone cement is packed in the chest tube. The extra cement is removed and the proximal end of the rationale is left uncovered to facilitate easy removal. The final diameter of the nail we get is 7 to 8 mm, which is inserted into the medullary canal of the tibia by routine intramedullary nailing technique. The antibiotic selected should be broad spectrum and mixed with PMMA cement, must be able to withstand polymerization temperatures up to 90 degrees without any loss of function. In our study, we have selected an available prepared combination of PMMA cement with gentamicin. 40 gram of cement and 1 gram of gentamicin was used. Post-operatively, patient was immobilized with POP slab cast until definitive fixation was done. Here we can see a 30-year-old male after high energy velocity Trauma was sustained and he had grade 3B compound fracture both bone right leg at distal third. Wound photo and X-ray are during the time of presentation. Wound photo and post-operative X-ray on POD5. Definitive nailing was done after 12 weeks and there is a complete wound healing. 6 months post-operative pictures. Here is a case 2 of 40-year-old female with a history of RTA. Pre-op and wound photo are seen. Immediate post-operative X-ray and wound condition post-grafting. Post-operative X-ray after definitive fixation. Here is a case 3, 50-year-old female after a history of RTA presented to emergency. Wound photo and X-ray at the time of presentation are seen. Wound photo and post-operative X-ray on POD5. Wound condition after 8 weeks. Case 4, 50-year-old female with a history of RTA hit by car, preoperative wound picture and X-ray. Postoperative X-ray and wound photo on POD5. Open fractures need skeletal stabilization compared to external fixator. Intramedullary nailing is first choice for lower limb diaphyseal fractures, as this restores the limb of the length of the limb and corrects tension to soft tissue and decrease swelling. It improves circulation, aids venous and lymphatic return. Compared to external fixator, which requires multiple follow-up for the patient, removal of external fixator, healing of pin track sites followed by definitive fixation. But in case of antibiotic-coated rush nail, once the wound heals, we can directly go for early definitive fixation with better rates of union and good range of motion of joints as compared to external fixator. Results. Out of 20 patients, 11 patients showed good wound healing with primary suturing, and remaining 7 patients required additional plastic surgery procedures like grafting, flap, and 2 patients lost follow-up. In all the 18 patients, the rate of infection was very low with good wound healing. These patients were followed up every 4 weeks with ESR, CRP, CBP, and X-ray, and definitive intramedullary nailing was done once infection was controlled. Conclusion. Antibiotic-coated intramedullary nail is one of the better options available for early management of grade 3 compound diaphyseal fractures. For localized infection, high concentrations of antibiotics should be temporarily reached after debridement. This can be achieved safely by having high local antibiotic concentration, minimizing the potential problems associated with systemic administration. It provides a higher concentration of antibiotics locally, which fills the dead space and gives good mechanical stability at fracture site and promotes bone healing. Also, it gives easy access for other procedures like grafting, flap, and regular dressings. Thank you.
Dr. Vamsi, it's a good presentation. And I want to ask one thing. What is a protocol for the wound washing?
Sir, it's always better to treat the patient within the 6 hours after trauma, and we have to use NS. Ideally, for every 1 grade, it is into 3 liters. That is, if we are going for a wash for grade 2 compound fractures, it should be 2 into 3, that is 6 liters. That is ideally 12 NS bottles should be used early during the wash. And after that, we have to make sure that there are no dust particles available. And before even starting the wash, it's always better for we should start triple antibiotic. We should start tetanus immunoglobulin.
Okay. Only what is how many cases you have done simultaneously wound wash and antibiotic rush nailing along with the skin graft out of 20?
Sir, we have gone for 7 cases, sir.
Okay. And what is the segmental fracture tibia, where it will be, in which classification it will be suitable? Which grade?
So it is actually segmental fractures will be coming under grade 3, sir.
Okay, in 3, which were
Actually, they are considered highly comminuted, so we consider them in grade 3B.
grade 3B. Okay, good. So it was in your case, any segmental fracture was there?
No, so actually we did not
Included.
add segmental fracture with comminution, complete grade 3B fractures for antibiotic rush nail.
Okay, why do you choose the 32 chest tube?
Because its inner diameter is almost coming up to 7 to 8 mm, sir, which is ideal for a tibia fixation, tibia intramedullary nail fixation.
Okay, good. Carry on, huh?
Thank you, sir.
Thank you. Thank you. Thank you. Bye. Next. Hello.
Sir, playing Anvesh Gaud video.
Hello. Hello.
Yes, sir. We are playing the next video now. The next video will show
A
shortly.
prospective study on tibial plateau fracture managed by the dual plating by Dr. Anvesh Gaud.
Yes, sir.
Good afternoon, sir. This is Dr. Anvesh from Common Institute of Medical Science, Orthopedics PG, and I'm regarding the paper presentation. My topic for the paper presentation is a prospective study on proximal tibial fractures managed with dual plating. An introduction. The tibial condyle with their articular surface forms a major part in the knee joint, play a major role in weight bearing and transmission of mobility. The proximal tibial fractures accounts for 1% of all fractures. With increasing high velocity traffic accidents and incidence of proximal tibial fracture are also increasing. The goal of treatment, this bicondylar tibial plateau is to bring back the functional mobility and increase the injury status and early possible. Hence, absolute anatomical reduction of the articular surface, anatomical alignment, and maintenance of the mechanical has to be achieved with stable fixation and early mobilization. If these high velocity intra and periarticular fractures are not treated properly, there is a high degree of incidence of malunion, non-union, infections, varus collapse of the medial condyle, especially ligamentous instability, malalignment of the axis, and articular congruity. The advantage of treating a bicondylar proximal tibial fractures with dual plating, the coronal split of the medial condyle can be separately fixed. Better distribution of force, better load sharing, prevent medial collapse, and early mobilization of the knee joint. The main objective of the study is to assess the anatomical reduction of the articular surface, tibial accuracy by operating treatment with internal fixation, to assess the radiological union after internal fixation, to assess the clinical outcome associated with treatment modality, knee range of movements, pain relief, return to normal activities and work at earliest. Material methods, our studies conducted a prospective study conducted in Common Institute of Medical Sciences from August 2019 to December 2020. Inclusion criteria, skeletally mature patient between 20 to 60 years, any depression or displacement of the articular surface more than 2 mm, includes statistical classification of 5 and 6. This is the statistical classification in which 5 and 6 we are considering. Bicondylar and with metaphyseal extension. Exclusion criteria, open fractures, pathological fractures associated with pre-existing joint disease and neurovascular injury and head injury and skeletal immature patients. Results are mainly based on clinical functional radiological assessment done by the Onconen and Yaren criteria. The functional outcome are walking, stair climbing, squatting, jumping, and duck walking. The clinical outcome are extension lag, flexion range, thigh atrophy, and stability. Radiological outcome are plateau tilting, varus and varus, articular step off, condylar widening, and degenerative related narrowing the joint space. Discussion. To achieve the stable painless mobile knee is a tough task and requires expertise. Historically, due to poor techniques of fixation with dual plating, a single midline incision of Mercedes-Benz incision altered the method of fixation with Elizaro fixation, bidirectional fixator, and being employed. Single incision technique had high incidence of wound breakdown and infection. With the advent of isolated lateral plate with locking compression plate, the spectrum has shifted towards locking plate with the medial fragment being stabilized by screw passed through lateral plate. Varus collapse due to inadequate fixation of the posterior medial fragment. A double incision, double plating technique is recommended by associated with osteosynthesis, associated for the study of internal fixation or treatment of complex tibial fractures. Locking plate provides a fixed stability and prevents secondary loss of reduction in alignment. Secondary loss of reduction is a result in osteoarthritis. In our study,
Male outnumber female. There's more activity of lifestyle male or higher chance of road traffic accidents. All 11 patients are road traffic accidents. Distribution of incident sites are nearly equal. 7 patients are statistical 5 and 4 are type 6. Study of Fanconi criteria. The clinical outcome are 81% of excellent and 16.6% good and 2.4 are fair. The functional outcome of 71.3% are excellent, 19.1 are good, 6.7% of fair and 1.9% of poor. The radiological outcome shows 87% of excellent, 12% of good and 1% of fair results. As per the short-term results, the results may vary. In the bone graft are used in 3 patients, like 42%. Of these are the articular evolution depression surface. The mean time for union is 11 to 16 weeks. Knee flexion of 1995, a good patient, physiotherapy is encouraged. Superficial infection of 2 patients, appropriate antibiotics. Conclusion, we conclude that high velocity tibial fractures are excellent to good clinical fracture radiological outcome. Early mobilization of joint provides good range of motion. And the posterior medial plating provides better posterior medial fragment, thereby prevents varus collapse. And these are some of the references which I used. Thank you.
Thank you, Dr. Anvesh. It's nice presentation.
Thank you, sir.
Do you
Anvesh,
have
Anvesh, who was your coach along with you in the hospital?
Dr. Harna, sir.
Okay, okay.
hello?
Yes, sir.
Do you have any case you have went pre-op CT scan?
Yes, sir.
And-
Shartska 6 classification, we went for CT scan, sir. To see the any articular incongruity, we just went for the CT scan, sir.
Okay. Any ligamentous injuries you have observed?
Sir,
MRI,
we didn't find any ligamentous injuries, sir. In most of our cases, like our 11 cases, we didn't see any ligamentous injuries, sir.
In dual plating, which side plate you are preferably you are using?
So for the posterior medial, we are using T buttress or L buttress. Mostly we are using T buttress plates, sir.
Okay. So you want to go first posterior medial.
Yes, sir. First we have fixed the medial, sir, and later we went for the lateral plate.
Any criteria for fix the first posterior medial plate?
Yes, sir. For better stability, we mostly prefer medial plating, sir, first.
Stability or any fracture pattern?
So if there is any severe comminution in the medial condyle, we first fix the medial fragment first, and we'll go for the lateral.
Do you have any idea about single incision plating in the tibial plateau?
Yes, sir. Before they used to give a single incision and they used to fix the, sir. Like from the lateral, they used to keep the locking plate along with the CC screws to fix the medial fragment also, sir, to buttress the medial fragment. With a single incision, they used to do it before, sir.
Any pre-op compartment syndrome you have observed?
No, sir. We didn't have any pre-op compartment syndrome, sir. Only there is some swelling, sir, for the first 3 days, like fracture model. There is no any compartment syndrome in our cases, sir.
When did you plan for surgery if it is scratch type 5 and 6?
Sir, if there is no swelling, once the swelling is reduced, any local, any injury.
Time bound. I am asking time bound.
Sir, it's like below 5 days only we have started, sir, to operate it. Once
Okay.
outside, we have started it, sir.
Okay. Thank you.
Thank you, sir.
Okay, sir. Shall we play the next video?
Yeah, can.
Yes, kindly play
So,
the next video.
So function outline of the fracture lateral third clavicular fracture treated with the clavicular hook plate by Dr. Mahesh Kumar.
Good evening, everyone. Myself, Dr. Mahesh Kumar, postgraduate in orthopedics, Osmania General Hospital. My topic for paper presentation is a study to evaluate functional outcome of lateral third clavicular fractures treated with hook plate. My co-authors are Dr. G. Ramesh, Professor, Department of Orthopedics, Dr. Y. Timareddy, Professor and HOD, Dr. Shekhar, Associate Professor, Dr. Sudhir, Associate Professor, Dr. Satish Chandra, Assistant Professor, Dr. Agnish, Assistant Professor. Clavicle is a horizontally placed S-shaped collarbone that connects upper limb to the trunk. It plays an important role in mobility and anatomic stability to upper limb. Since its subclavian position makes it vulnerable to traumatic injuries. Clavicular fractures account for 2 to 6% of oral fractures. Majority of clavicular fractures occur in the midshaft of bone, accounting for 80 to 85%. Lateral third clavicular fractures are the second most common type, accounting for 15 to 20%. These most commonly occur in the elderly individuals and usually result from a simple fall. Clavicle is a thin bone, widest at its medial and lateral expansion, which articulates with the sternum and acromion respectively. Corpoclavicular ligament is divided into two parts. The medial part, which is the conoid ligament, and the lateral part, which is the trapezoid ligament. It provides primary resistance to the superior displacement of clavicle. Corpoclavicular ligament basically arises from the base of the coracoid. Aim of the study is to study functional outcome of lateral third clavicular fractures treated with hook plate fixation. Materials and methods. It is basically a prospective study with a sample size of 5. Criteria included in the study are age greater than 18 years, closed fractures, NIRF type 2 and type 3 fractures, no medical contraindications to anesthesia. The criteria that are excluded under the study are open fractures, associated neurovascular injury, associated acromioclavicular joint dislocation. Classification of clavicular fractures. Alman basically classified clavicle into three groups. Group 3, which is the medial 1/3 part, Group 1, which is the medial 1/3 part, and Group 2, which is the distal 1/3 part. NIRS divided distal clavicular fractures into 3 subgroups. Type 1 is a distal clavicular fracture with intact corpoclavicular ligaments. Type 2, corpoclavicular ligament detached from the medial fragment with the trapezoidal fragment attached to the distal fragment. Lockwood subdivided type 2 into type 2A and 2B. In 2A, both conoid and trapezoid attached to the distal fragment. In 2B, conoid detached from the distal fragment. Type 3, distal clavicular fracture with extension into acromioclavicular joint. Coming to radiography, a candid posterior view and a 45 degrees cephalic tilt view are sufficient to diagnose clavicular fractures. An abduction lordotic view, an arm abducted to 135 degrees and beam angle 25 degrees cephalad is useful to evaluate internal fixed clavicle. From surgical technique, surgery is usually performed under general or regional anesthesia. Patient is placed in big chair or semi-sitting position. A skin incision is placed directly superiorly over distal clavicle, extending approximately 1 cm past acromioclavicular joint. The skin and substance layer is developed, and the deltotrapezial myofascial layer is incised directly over the distal clavicle and reflected anteriorly and posteriorly, and acromioclavicular joint is identified. The fracture site is identified and cleared of debris and hematoma. The fracture is reduced and held with the K-wire or a lax screw. An entrance is made into the subacromial space with a pair of heavy curved scissors that will create the path to the hook extension of the plate. It is important that this path is made posteriorly so that there will be no impingement in case of tight subacromial space. Once the path has been created, hook plate is placed in it and plate is reduced to the shaft of the clavicle and fixed. Following fixation, wound is thoroughly irrigated and two-layered closure is performed. Post-operatively, the arm is placed in a sling and patient is allowed early active motion in the form of pendulum exercise. At 10 to 14 days post-operatively, sutures are removed and full range of motions are started. These are images showing skin incision in case of clavicle fracture. In the second image, the fracture site is exposed. In this image, it shows the reduction of fracture fragments followed by hook plate fixation in the next image. These are follow-up clinical pictures and X-rays which are taken post-operatively, preoperatively, immediate post-op, and follow-up X-rays. Patients are followed up for a period of 6 months at regular intervals. Patients are evaluated both clinically and radiologically using constant Marley score, disabilities of arm, shoulder, and hand score. In our study, we have prospectively analyzed the outcome of clavicle fractures treated with hook plate. Mean age was calculated to be 40 years and mean duration of union was found to be 10 weeks. In our study, we found that the severely complicated fractures and older patients take more time for union. Range of movements attained at the end of study was calculated to be full and free in 18% of patients. All the patients were further assessed with constant Marley score and disability arm, shoulder, hand score for final outcome and performance in daily and occupational activities. And results were found to be very good. Thank you.
Hello.
Good morning.
Dr. Mahesh, do you have any criteria for selection of patient with the clavicle fracture?
Usually, unless it is a middle third fracture, usually lateral third fracture, you have to go for fixation.
Why do you fix the lateral third clavicle fractures?
Because there are high chances of non-union in case of lateral third fracture because of displacement.
Non-union or anything you want to add? Other than non-union?
There will be
What is ARDS and only non-union? Mainly, what is the involvement of lateral third clavicle? Which joint will be involving?
acromioclavicular joint.
So to avoid that, you have to fix that. Only hook plate or any other than this hook plate you tried?
Actually, we tried only hook plate, sir.
No other procedure you have done. Any cases you have across the brachial plexus injury?
No, sir. In my study, we didn't come across any case of brachial plexus injury.
How many holes plate you have taken? Hook plate?
Sir, 4 holes, sir.
So either side is two screws.
Yes, sir.
Okay, nice. Any other questions, sir?
What was your sample size, Mahesh?
Sir, we took around 5 cases.
5 cases. Okay.
Okay. Nice. Thank you.
Thank you.
Okay, sir. Next video.
Okay. Functional and radiological outcome of closed distal tibial fracture treated with the minimal invasive plate osteosynthesis by Dr. Ravi Teja.
Good afternoon, respected sir. I am Dr. Ravi Teja. I did my DMB from Sunshine Hospital. At present, I am working in South Central Railway. Topic for presentation is functional and radiological outcome of closed distal tibial fractures treated with minimally invasive plate osteosynthesis. Minimally invasive plate osteosynthesis works by principle of biological fixation. It preserves the osteogenic fracture hematoma. It doesn't disturb the blood supply to the fractured fragments. It decreases the chances of infection. It decreases surgical trauma to the fracture and the soft tissue. The aim of my study is to assess the functional radiological outcome and complications of MIPO by locking compression plate. When coming to material and method, study site was done at Sunshine Hospital, Secunderabad. Study population includes patients aged 20 years and above admitted in Sunshine Hospital. It's a prospective observational study. Sample size was 30. Study duration is 2 years. Inclusion criteria: patient aged 20 years and above with fractures coming under AVO classification 4.3 A, B, C are included in the study. Exclusion criteria: patient less than 20 years of age, open fractures, associated neurovascular diseases, pathological fractures, compartment syndromes, and patients who are not willing to be enrolled in the study. Two classifications are commonly used: Dory-Algover and AVO classification. AVO is subdivided in type A, type B, and type C fractures. Preoperative evaluation: careful history for mechanism of injury was noted. Patient was assessed clinically for general condition, and local examination of the injured extremity was done. Anteroposterior and lateral radiographs were taken. Fracture classified according to AVO classification. Color Doppler was done wherever necessary. After thorough blood investigations, written informed consent, and pre-anesthetic checkup, patient was taken off for surgery. This is the anteromedial distal locking plate. This is the anterolateral distal locking plate. This is the general surgical instruments used for the fixation of the tibia and the fibula. Operative procedure: anesthesia used was spinal or combined spinal epidural anesthesia. Patient position supine with affected like elevated over folded sheet. Pneumatic tourniquet was applied. We have used either anteromedial or anterolateral approach. Initially, fracture reduced using bone clamps, manual traction, and K wires. Followed which we have approached the fracture anteromedially or anterolaterally. Anterolateral approach was used in other cases when the skin on the medial side is not moving and when the fracture is in the coronal plane. Post-operative care: 2 days of intravenous antibiotics were given and other supportive medications were given. Physiotherapy started from the day one. Follow-up was done. Second week procedure involved and followed by 6 weeks post-operatively in outpatient clinic. Radiological evaluation, functional evaluation was done at the end of 1 year by using Polaroid and Nylander scoring system. The scoring system gives 9 parameters to a total score of 100 points. Greater than 90 points considered as excellent result. 61 to 90 points is considered as good result. Less than 60 points is considered as fair and poor result, poor outcome. Coming to results and analysis of my study, In my study, 41 to 50 years age group are more commonly involved, which is comparable to other previous studies. Males are more commonly involved in my study. 70% of males are involved. Most of them are due to road traffic accidents. The sex distribution is compared with the other previous studies. There is no side predominance in my study. Coming to fracture pattern, A1, A3, and C1 types are more commonly involved. This is comparable to other studies of Hazarika et al., Gupta RK et al., Collingsi et al. High energy trauma is the most common mechanism of injury in my study, which is comparable to other studies. Coming to fibular fracture, 26 patients had an associated fibular fracture in my study. 23 patients had anteromedial distal locking compression plate, and 7 patients had anterolateral distal locking compression plate in my study. Time taken for radiological event in my study was 18 weeks, which is comparable to other studies. Coming to functional score, in my study, 83% of the patients had a good functional outcome, and 16% had an excellent outcome. This is comparable to other previous studies. Coming to post-operative complications, I had 6 post-operative complications. 2 patients had superficial skin infection. 1 patient had wound exposure. He was treated with back therapy, regular dressings, and culture-sensitive antibiotics, and followed which wound healed without any surgical intervention, without need of skin grafting or flap coverage. 1 patient had delay in wound healing. 2 patients had delay in wound greater than 24 weeks, which subsequently healed without the need of any surgical procedure. These post-operative complications in the study are comparable to other previous studies. Conclusion: locking compression plate in extraarticular and intraarticular fractures of distal tibia applied to MIPO is an effective alternative way of management. It has simple, rapid, and straightforward application, and it decreases the surgical time in distal tibial extraarticular. Although a larger sample of patients and longer follow-up is required to fully evaluate this method of treatment, we strongly encourage its consideration in the treatment of such complex fractures. These are few radiographs and clinical images of my patient. The case 1, this is a functional outcome image. The case 2, the functional outcome image. This is a case 3. The case 4. Thank you so much. Thank you so much.
Sir, any questions? Sir, good morning.
Good morning, sir.
You want to ask any questions? Hello.
Hello. Good morning, sir.
Dr. Ravi Teja.
Sir.
One thing I want to ask. You are taking the distal tibia, only isolated tibia fractures, or it's both bone fracture?
Sir, we have included both distal tibia and fibula fractures, sir.
Okay. In out of your cases,
patients.
how many cases you have treated with fibular plating?
26 cases, sir.
Fibula.
Okay, sir.
So which bone you have fixed first?
Sir, it depends on the fracture pattern of the tibia, sir. Sometimes we fix the tibia first, and few times we fix the fibula first. It actually depends on the fracture pattern and the type of displacement, sir.
So any criteria you know? When we'll first fix the fibula, first fix the tibia. Any criteria you know?
Sir, length alignment is our criteria, sir. If the distal tibia fracture is more comminuted, we used to fix fibula first, sir, to maintain the length.
Okay, very good. Which plate you want to fix with the fibula?
Fibula, 1/3 tubular plate, sir. We have used most of the times 1/3 tubular plate, sir.
Okay. What about a distal tibial locking plate? Which size?
Sir, in majority of my cases, sir, anteromedial distal locking plate we have used, sir. In few cases where medial side skin is not healthy, or when the fracture is in the coronal plane, or we have to, or if any fracture, if you want to fix any fracture fragment from the lateral side, we have used anterolateral distal locking compression plate, sir.
What is the size of the plate? 3.5 mm or 4.5 mm plates you are using?
Sir, 3.5 mm plate, sir.
You didn't use a 4.5 system?
No, sir.
Okay, carry on. Sir, good morning. Anything you want to ask?
No. Very nice. Good
Sir,
job, Ravi Teja.
Thank you, sir. Thank you so much.
The next case you want to tell? Surgical management of distal end the tibia fracture fixed with the anterior lateral plating by MIPO technique by Dr. Nikita.
Good afternoon, everyone. This is Nikita, postgraduate in orthopedics from Ebenar Medical College and Hospital, Sangareddy. My topic is on a study on surgical management of distal end of tibia fractures fixed with anterolateral plating by MIPO technique. Distal tibia fractures with or without fibular fractures, if not treated properly, will result in deformity, ankle joint stiffness. Fracture healing in tibia is not an isolated goal. This approach offers the benefit of improved soft tissue coverage and potential for a lower rate of wound healing complications by avoiding the incision placement over the subcutaneous board of the tibia. Although the fracture pattern dictates specific plate use, anatomically designed anterolateral plates are useful for fixation of common fracture patterns. Aim is to study the surgical and functional outcome of distal end of tibia fractures fixed with anterolateral plating by minimal invasive percutaneous plate osteosynthesis technique. This is a retrospective study conducted at MNR Medical College and Hospitals with a sample size of 10 patients who came to the emergency block in the duration of January 2019 to January 2020. Inclusion criteria: age 18 to 65 years, closed traumatic fractures of tibia with no intra-articular extensions, trauma less than 1 week, patients with distal fibula fractures. Exclusion criteria: open fractures in age less than 18 years and more than 65 years, fractures and dislocations of distal end of tibia, patients with neuroparalytic conditions, pathological fractures, fractures with intra-articular extensions, trauma more than 1 week, ankylosis of ankle, chronic osteomyelitis of tibia, patients treated with surgically by other methods of fixation. Under spinal anesthesia with patient in supine position, approach is by anterolateral approach by MIPO technique, followed up for the minimum period of 1 year, that is at the intervals of 1 month, 3 months, 6 months and 1 year by clinical and radiological evaluation. Preoperative evaluation. Detailed history of all the patients was taken. The preoperative medical evaluations of all the patients were done to evaluate any potential complications that can be life-threatening. Out of 10 patients, 8 patients are associated with fibular fractures. Radiological assessment is by anteroposterior view and lateral view. These are the pre-op X-rays. Operative technique. All patients after thorough pre-op evaluation were taken up for surgery under spinal anesthesia. All patients received 1 gram of ceftriaxone prior to the surgery and tourniquet inflation done. Incisions for fibular fractures were given posterolaterally. After fibular fixation, reduction of distal tibia fractures was checked under CR. Anterolateral distal tibia plating 3.5 mm locking compression plate was done through minimal invasive technique using anterolateral incision. With the superficial peroneal nerve mobilized and retracted, the fascia over the anterior compartment of the distal tibia and extensor retinaculum are sharply incised. The anterior compartment tendons are then retracted medially. Intraoperative pictures, postoperative X-rays with fibula rush nail and distal tibia anterolateral plating. Advantages by MIPO technique are easy surgical exposure, improved soft tissue coverage, lower rate of wound healing complications, no implant prominence, no need for further revision surgeries. Results: out of 10 cases, 8 cases had road traffic accidents, 1 had hit by a vehicle and 1 had history of fall from height. Fractures were classified according to AO classification. Patients were operated after the trauma in mean time of 2 days. All the patients were operated in a single stage. Patients were discharged after 5 days of surgery. Patients were evaluated clinically and radiologically at an interval of 1, 3, 6 months and 1 year in orthopedics OPD. Out of 10 cases, 8 had associated fibular fractures for which all the fibular fractures are fixed with closed reduction and internal fixation. Full weight bearing without any support were allowed in mean of 4 months. Full range of motion at ankle is achieved by 6 months. The movements of the ankle range from 5 to 15 degrees of dorsiflexion and 5 to 35 degrees of plantar flexion. Anatomical alignment was within the acceptable range without anteroposterior angulation for more than 10 degrees and mediolateral angulation for more than 5 degrees in all the patients when compared to normal lower limb. No arthritic changes seen until the final follow-up. None of the cases required implant removal during the time of the study. Conclusion. The anterolateral approach for the fixation of distal end of tibia fractures offers the benefits of improved soft tissue coverage and the lower rate of wound healing complications, implant prominence, and revision surgeries. The anterolateral plating is a safe and useful choice for the treatment of distal tibia fractures. MIPO technique aims to reduce tissue trauma, preserve the periosteal vascular integrity, and aid the fracture reduction. Thank you. Good morning, sir.
You should have given more X-ray pictures in your slides, madam.
Okay, sir.
For us to comment on that in comparison to lower third distal tibial fractures, probably interlocking nailing with a rush pin fixation for a fibular fracture.
Yes,
it would
sir.
have been a better analysis for us as a commentators.
Okay.
Hello.
Hello, sir.
Why do you choose the anterolateral?
Sir,
Any criteria you are taken?
because of the better wound healing, I preferred anterolateral tibia plating, sir.
Only wound healing?
Wound healing and implant prominence, sir. Because of less implant prominence in this approach, we prefer this type of approach, sir.
Okay. When do you mobilize the patient after fixation of 3.5 plate fixation?
We mobilized after 1 month, after 3 weeks, sir. Full weight bearing.
Immediate mobilization is not there?
Immediate we mobilized by 2 weight bearing, sir. After 3 weeks of surgery, we mobilized full weight bearing, sir.
Okay. Nice, Dr. Nikita.
Thank you, sir.
Okay, next.
Good morning, sir. Sir, shall we play the Dr. Srikanth's video?
Yeah, okay. So functional outcome of the tibial condyle fracture with scratch cut type 5 and 6 managed by the surgically by MIPO technique. Dr. Venkat Srikanth.
Good evening, everyone. Today I am going to present my topic on the functional outcome of tibial condylar fractures of Scharzer type 5 and 6 managed surgically with minimally invasive percutaneous plate osteosynthesis. Myself, Dr. Srikanth from Narayan Medical College. While coming to introduction, the fractures which involve proximal tibia and extend into knee joint are known as tibial plateau fractures. Tibial condylar fractures result from direct axial compressive, most commonly from mechanism of injury or indirect and are known to be one of the commonest intra-articular fractures. Lateral condylar fractures are most common, which is around 55 to 70%, and isolated medial condylar fractures are seen in 10 to 23%, while bicondylar fractures are seen in 10 to 30% of cases. While coming to majority of tibial plateau fractures are caused road traffic accidents. However, fall, sport injury, or other less violent trauma can also cause these fractures. Complex fractures of tibia are difficult to reduce, align, and stabilize, and constitute significant bony and soft tissue injuries within and around the knee joint. The surgical treatment aims to restore congruity of tibial condyles, maintaining the mechanical axis, and restore ligamentous stability. This will achieve functional, painless, and good range of motion in knee joint. While coming to the aim of this subject is, this study was conducted to observe the functional outcome of surgical management in Scharzer type 5 and type 6 tibial plateau fractures with proximal locking compressive plate. Patients assessed post-operative complication, duration of union time in 2 subtypes of fractures, and post-operative knee function with modified Romson's criteria is taken. Welcome to Medicine and Methodology. All patients visiting the outpatient department and emergency department of hospital were considered. Patient diagnosed with Schatzzer type 5 and type 6 tibial plateau fractures are taken. While sample size is around 30 cases of Schatzzer type 5 and type 6 tibial plateau fractures are taken for the study, and which is for a period of 6 months, 9 months from September 2020 to May 2021. Study method is prospective study, and post-operative follow-up is 3rd week, 6th week, 3rd month, 6th month, and 9th month. Inclusion criteria: patients above 18 years of age or sex, closed tibial plateau fractures, radiological diagnosis of fractures with classification include Schatzzer type 5 and type 6. Patients who have given consults and open fractures up to Gustula Anderson class 1 and class 2. While coming to exclusion criteria, patients below 18 years, Schatzzer type 1, 2, 3, and 4 fracture types, and patients medically unfit for surgery. Concurrent associated fractures in the same limb and upper extremities, patient with pathological proximal tibial fractures, fractures with compartment syndrome, or impaired circulation. Patients subject to surgery were followed up at regular intervals with clinical and radiological evaluation. Assessment was done based on performa containing all necessary information. This is the tibial plateau classification. And while coming to the X-rays, as you can see, the bicondylar fracture of tibial plateau, which is Schatzzer type 5, and a breach of fracture line into the diaphysis is type 6. Also, surgical procedure, which includes patient is anesthetized and placed in supine position with a small sandbag under the gluteal region. A tourniquet is applied over proximal thigh and inflated. The limb is draped and surgical area is sterilized. An anterolateral or posteromedial incision was made and deep dissection was carried out. Full thickness flaps were raised, consisting of subcutaneous fat up to the fascia. Submeniscal arthrotomy was carried out, preserving the meniscus to visualize the articular surface. Reduction was done and fixed with a K-wise provisionally under CM guidance. Locking plate or buttress plate was placed and 6 mm cancellous screws were applied. Cortical screws were applied in the diaphysis. As you can see, both medial and lateral condyle has been reduced with percutaneous plate with help of cortical cancellous screws and 6.5 mm cortical screws, 6.5 mm of cancellous screws, and cortical cancellous for diaphysis, as you can see in the lateral view also. Post-operative care, splints were removed and mobilization was done from 4th post-operative day. Suture removal was done on 11th day post-operative day. Non-weight bearing mobilization was done for 6 to 8 weeks, depending on the fracture pattern. Later, the patient was advised partial weight bearing after confirmation of fracture reunion. Full weight bearing was allowed depending on the progression and fracture healing pattern. Follow-up was a minimum of 6 months. Follow-up was follow-up, which is around 3rd week, 6th week, 3rd month, 6th month, and 9 months. Both radiological and clinical evaluation was done at every review. The anatomical and functional evaluation was done using the modified Ramsden clinical and radiological criteria. Results are prospective study to observe the functional outcome of surgical management in Schatzzer type 5 and type 6 tibial fractures with proximal locking compression plate. Analysis was done in terms of functional outcome of post-operative knee range of movement after union. Time for fracture union, early and late post-operative complications. Out of 30 patients, 27 patients had closed type of reduction, which is of 90%, while 3 patients had open fractures, which is of 10%. Among the open fractures, 2 patients had a type 2 open fractures, while 1 had type 1 open fracture. Fracture grade Schatzzer classification. Schatzzer classification was used to grade the tibial fractures. It was observed that 16 patients, which is of 53.3%, had a type 5 fracture, and 14 patients of 46.7% had type 6 fractures. Out of 30 study subjects, 17 of them required dual plating, while 13 of them underwent single plating. Cortical clamps bone grafting was performed in 6 patients who had depressed fracture segments. A post-operative infection was seen in 2 patients, which is of 6%, while the rest 28% had no complications and have good outcome. According to time for fracture reunion, the average time for a fracture reunion on our study was calculated to be 17 weeks. In 17 patients, which is of 56%, the patient has fracture reunion occurred by 17 to 20 weeks. Among others, 9 fractures united in 14 to 16 weeks, while 4 fractures united in 21 to 24 weeks. As you can see, which is demonstrated in this slide. Range of knee flexion post-operative was of 18 patients had a knee flexion of greater than 120 degrees, while 8 patients had flexion of 90 to 120 degrees. Only 4 patients had knee flexion of less than 90 degrees. The modified Ramsden clinical and radiological assessment criteria involve pain, range of motion at knee, walking capacity, residual extension lag, and stability. Functional outcome. We were used to evaluate of 30 study subjects post-operatively. It was observed that 17 patients had excellent, 8% had good, and 3% had fair, and 2 patients had poor outcome. As you can see in this diagram, the modified Ramsden radiological and clinical criteria. Conclusion. Welcome to conclusion. Proximal tibial locking plate is good device to stabilize the fractures of tibial plateau, especially when used in conjugation with proper intraoperative handling of soft tissues and active participation of the patients in rehabilitation program. Minimally invasive percutaneous plate osteogenesis minimize the size of the surgical incision and avoids soft tissue injury, which in turn reduces post-operative complication and leads to better wound healing. Surgical treatment lead to proper reconstruction of articular surfaces. There was no statistical difference in assessing the Schazer type 5 and type 6 fracture patterns. Comparable results were achieved in radiological, clinical, and subjective functional outcomes based on modified Ramsden clinical and radiological criteria. These are my references. Thank you.
Thank you, Dr. Venkat Srikanth. Do you have any post-op complication of wound infection and stiffness of knee joint? How many cases you are across that?
We faced around 2 cases, sir, post-operative knee stiffness and 1 case of post-operative infection, sir.
Okay. Any ligament laxity you observed?
No, sir. No ligament. Only 2 cases I have lead to knee stiffness, sir.
Ligament laxity. Extensor
No,
lag.
No, sir. No, sir. Signs of extensor lag, sir.
Okay, good. Carry on. Sir, anything you want to ask? Hello?
Good job, Srikanth.
Thank you, sir.
Next, last one, sir. Okay. Next is a comparative study between the anterior approach and posterior approach for the bipolar hemiarthroplasty in the intracapsular fracture neck of femur by Dr. Joy.
Welcome all. Myself, Dr. Leon Joy, postgraduate from Osmania General Hospital, Hyderabad. My paper is on a comparative study between anterior and posterior approach for bipolar hemiarthroplasty in intracapsular fracture neck of femur. Intracapsular neck of femur fractures constitute a major share of fractures in elderly. The primary goal of treatment is to return the patient to his pre-fracture functional state. Prosthetic replacement is done as non-union and osteonecrosis is common in elderly. It allows immediate weight bearing and return to activity and avoid complications of recumbency and inactivity. Aims and objectives. This study was designed to compare the efficacy of treatment of intracapsular neck of femur fracture operated by anterior and posterior approaches. Coming to materials and methods, it's a prospective study done in patients with intracapsular fracture neck of femur treated with bipolar hemiarthroplasty by anterior or posterior approach. The patients are aged above 65 years. The sample size is 10, consisting of 6 males and 4 females, who were admitted in Osmania General Hospital from May 2020 to May 2021. They were divided into 2 equal groups, and the patients are operated alternatively, one with anterior approach and another with posterior approach. And the functional outcomes were assessed using the Harris Hip score, and the range of movements were assessed clinically. Coming to the inclusion criteria, patients with intracapsular neck of femur fractures aged above 65 years were included. These fractures were closed unilateral, and these patients did not have any neuromuscular disorders. Similarly, those with extracapsular fractures, young patients, compound fractures, bilateral neck of femur fractures or with associated fractures, and patients with neuromuscular disorders were excluded from the study. Coming to investigations, X-rays pelvis with both hips AP with traction and indoor rotation were taken, and major surgical profile of patients were sent. These are the instruments used for the bipolar hemiarthroplasty surgery. To include the bipolar processes, retractors, broche, head gauge, and the image on left shows angled broche, specially used in the anterior approach. Coming to the surgical technique, the anterior approach is also called Smith-Peterson approach. The position of patient is in supine position. The incision is from the anterior half of iliac crest to anterior superior iliac spine. Then it is curved and is run vertically over the shaft of femur. The superficial internervous plane is between sartorius and tensor fasciae latae, and deep plane between rectus femoris and gluteus medius. That is, it's between the femoral nerve and the superior gluteal nerve. The joint capsule is incised and the hip is dislocated by external rotation. The image is showing position and the incision of anterior approach. Coming to posterior approach, it's also called Moore's or southern approach. The patient is in lateral position. The incision is 10 to 15 centimeter curved incision centered on the greater trochanter and is continued along the shaft of femur. There is no internervous plane. The gluteus maximus is split. The short external rotators are detached close to the insertion and is reflected along with the sciatic nerve. The upper part of quadrature femoris is divided and the posterior joint capsule is exposed and is incised, and followed by hip is dislocated by internal rotation. See image showing the position of patient in posterior approach and the skin incision. Coming to Harris hip score, it's used to analyze the functional outcome. It consists of various domains like pain, function, which includes gait, activities, absence of deformities, and range of movements. The total score is 100. Patients with score above 90 has excellent outcome. 80 to 89 has good outcome. 70 to 79 has fair outcome, and below 69 has poor outcome. Coming to the results, 10 patients were studied, which includes 6 males and 4 females. The mean operative time and intraoperative blood loss was more in posterior approach compared to the anterior approach. There were no cases of postoperative infection. One case of hip dislocation was noted in posterior approach patient on 10th postoperative day. There were no cases of abductor weakness, sciatic nerve injury, periprosthetic fracture, aseptic loosening, and deep vein thrombosis. The average Harris hip scores were almost equal between the two groups. These are the intraoperative images showing incision and various procedures in the anterior approach. So pre-op and post-op X-ray in anterior approach. So the clinical photographs demonstrating range of movements in anterior approach at 6 months. These are the intraoperative images for posterior approach showing position, incision, and various steps. These are the pre-op and post-op X-ray of the posterior approach. These are the clinical photographs assessing range of movements in posterior approach. Coming to discussion, the mean operative time in anterior approach was about 65 minutes, while in posterior approach it was about 78 minutes. The intraoperative blood loss was 120 ml in anterior approach compared to 150 ml in posterior approach. The infection rate was 0 in both cases. And the mean preoperative stay was about 6 days in anterior approach compared to 8 days in posterior approach. Coming to functional results, 1 patient from each anterior approach group and posterior approach group had excellent outcome. 2 patients had good outcome and 2 patients had fair outcome in each groups. No cases had poor outcome in both groups. Coming to complications, 1 patient done with posterior approach had hip dislocation. There were no cases of sciatic nerve injury, abductor weakness, periprosthetic fracture, aseptic loosening, or deep vein thrombosis. Comparing anterior and posterior approach, anterior approach has less blood loss, less duration of surgery, lesser post-operative stay, and less hip dislocation rate compared to posterior approach, even though it requires specialized instrumentation and operating table, while posterior approach can be done with regular instrumentation and operating table. Now, concluding, the anterior approach for hip hemiarthroplasty in elderly population with intracapsular femoral neck fracture provided significant benefit in early postoperative period when compared to the posterior approach in terms of duration of surgery, intraoperative blood loss, time of recovery, hip dislocation rate, even though it requires a different instrumentation and acquaintance to the surgeon, as it is a relatively newer approach. These are the references taken. Thank you.
Nice presentation, Dr. Joy. Do you have any criteria for the selection of the patient?
No, sir. We selected alternatively. Patients are aged above 65 years, and only closed fractures we selected, sir. And patients are operative alternatively, one with anterior and one posterior.
You mobilized immediately after post-op?
Yeah, like by 4th to 5th day, we'll mobilize them with walker, sir.
Okay, and squatting and cross-legging?
That we will advise after like 3 weeks. They will come to follow up after 3 weeks, sir. Once
but
that
on your pics, you have shown the cross-legging.
That is assessment after 6 months, sir.
6 months.
Range of movements assessed after 6 months.
Okay. This paper is overlapped, Doctor.
Actually, my assistant professor also was doing, sir.
Same paper you are presented both.
Yeah, sir.
Okay. Sorry, anything you want to proceed?
Joy.
Thank you, sir.
Over, sir, actually. 7 papers
Okay.
completed, sir.
Yeah, congrats to all the participants. You've done a really good job. We congratulate you and welcome to our club of the consultants in the near future. Thank you.
Thank you, sir.
Okay. Thank you very much to the Dr. Rakesh and Dr. Bansilal for conducting this session. We would now like to introduce Dr. A.V. Guruva Reddy and Dr. Uday Krishna Maineni to commence the session on knee arthroplasty.
Thank you, sir. Thank you for giving opportunity to chair the session.
Thank you, sir.
Thank you very much.
Thank you,
Thank
sir.
you, Rakesh, sir.
Shall we start the second session?
Yes, we can start the second session.
Good morning. Can you hear me? Good morning.
Hello, sir.
Yeah, good morning, everyone. Can you hear me? Just cross check before starting.
I'm sharing Dr. Udai's video.
Yeah, good morning. Before that, starting the video, I would like to welcome all the delegates and my faculty colleagues, Dr. Chandrasekhar and Dr. Jagan Mohan. There will be participation in the discussion. The whole idea of this knee arthroplasty is about getting it right, patient and implant selection. That is very, very key in outcome and functional outcome of the patient. So I would like to start with the opening batsman myself with a patient and implant selection in the knee total knee replacement. So I request the admin to start with my video so that we can be on time.
Okay, sir, we are starting your video.
Yeah.
Thank you.
Yeah, good morning, everyone. I really thank organizing chairman Dr. Guruva Reddy sir for giving me the opportunity. I thank TOSA organizers, especially Dr. GVS Murthy sir and my senior colleague Dr. Timareddy sir for giving me this opportunity to talk about this patient selection and implant selection in TK. It's a very important topic, and every surgeon, young surgeons who are practicing, that has to be taken care. Why? Because we have a rise in total hip and total knee surgery as an important implication for healthcare cost. If you don't select a patient rightly, or you don't optimize the cases in the right time, what happens is there is an increase in healthcare cost, because there is a large heterogeneity exists in patients' disease severity at the time of surgery. Some prefer active lifestyles and others only for activities of daily living. The positive attitude of the surgeon towards the procedure. Some may have seen the radiology findings and rightly may suggest a surgery. The positive attitude towards the procedure has been increasing from the young orthopedic surgeons. Thereby, the number of complications has been on rise. The appropriateness for the arthroplasty showed 20 to 45% of uncertain whether the patient or the surgeon, whether to go or not, especially the patient. They're in a lot of confusion state. So that this result in highly unsatisfied knee replacement up to 10 to 30%. The outcomes are less than the expected, but the expectations are very high. So I suggest always to optimize the patient, and some of the modifying risk factors like the joint disease, like apart from the knee, the hip, knee, ankle, and the spine should be examined to see is patient is a mobility or wheelchair bound or bedridden. So according to that, we can optimize the patient and plan for surgery. Mental health condition. Recently, since 5 years, I've been assessing with a lot of patients with depressed patients. Where I operated for the depressed patient, they have a very poor outcome. Cardiac disease, especially, there has to be fitness should be taken. Similarly, respiratory disease. Diabetes is a modifiable risk factors. Anything above 7, better to withhold the surgery until it's corrected. Obesity, again, since number of cases has been increasing, mainly in a younger population, is because of the issues with obesity. So, better the BMI, anything more than 35, that should be withheld, and the obesity should be corrected, maybe a conservative trial, then later you can go for knee replacement. So, peripheral vascular disease, again, is high risk for DVT and poor wound healing complications, better to be addressed earlier, similar to smoking. See, I'll come with a couple of cases where you have a clear idea what we are discussing. This patient is around 60 years. She's walking independently, but if look her gait, it's completely difficult in walking, where right hip is knee and ankle are very, very stiff. She's unable to do her routine activities, and if you see on the right leg, there is a lot of thrust on the lateral side. It lurks you that better to investigate not only the knee and hip. My book always involves and tell my registrars to have all these 3 X-rays, very, very important. One is standing X-rays and scanogram, and doubtful you go for spine X-rays. If anything is there, if the spine related issue is there, just address the spine, later come back to TKR. Otherwise, the patient have a good relief on the knee, but she'll be crying with hip pain or spine pain. So that has to be addressed earlier and dealt accordingly. So we have 2 designs. It depends upon the seniority of the surgeon and preference of the implants. Both the implants, CR, cruciate retaining, and PS, it works really wonders well. CR has its own advantages, that like a femoral rollback, because of the retention of the PCL, it rollbacks nicely completely, and it has its own proprioception, easy restoration of joint line, and stability against stabilization. The disadvantages is it has sometimes tight PCL, sometimes the balance may not be right, or lacks PCL. Sometimes we release the PCL to a little bit to have the balance of the gaps. You may adequately release later the poly may fail. I'm a PS surgeon, so for me it's very easy to improve. It gets good stability on table, easy for me for flexion extension gaps. Flexion contracture, especially in rheumatoid or in a deformed knees or valgus deformity knees. For me, the PS is a first choice, and definitely I know that it has its own disadvantages, especially high contact stresses and patellar clunk, and some implants have a more bone resection. The case 2, this is a patient, you've seen the first case where she's walking independently. This requires some amount of resistance unless she can't walk. The preoperative mobility or functional scores or knee scores is equal to your postoperative functional outcome. She has a poor of knee scores and expected to be a poor outcome for the functional scores. Here she underwent the spine surgery that has to be addressed. Is there any spine problems? You have to always check for the power of the muscles. Otherwise, you'll land in trouble with the routine implants. You need to have something like VVC, valgus constraint implants, to have a better stability. The third patient is she's a bedridden rheumatoid lady. If you see the hand is a completely rheumatoid hand, and the legs, where the legs are completely discolorized, maybe existing DVT or cellulitis, or she's almost bedridden. Now, the most important thing is examination clinically. What we examine? The most important thing is power of the knee. Whether she's able to examine or flex the knee actively or passively. In this case, she's only to do only passively. If you see on the right side of the picture, this 8 years post-op, where I've done 8 years back, total hip on the left side, is apparently doing well. Later, after 1 year, she underwent the left knee, with the CR knee, it came out very well. Now, she came with this after 8 years follow-up. She has done a lot of DMRD drugs, steroids, and discolorization of the skin here. And you need to take confidence of the patient as a whole, as a family. High risk for wound healing problems, implant issues are there. and you need to plan because a lot of FFT on the right side, you can't go with the routine implants. So you need to have rightly design where either PS will works well or some sort of VVC type of implants like varus valgus constraint implants, which have certain indications for choosing. Valgus deformity with incompetent MCL, that is the main indication. With other indications are bone defects, severe flexion deformity, and varus valgus laxity more than 5 mm, extraarticular deformities, uncontrollable flexion extension imbalance, especially rheumatoid arthritis, sequelae of polio, and neuropathic joints. So before that, you have to examine the patient clinically and see whether which is a need for the patients. Post-trauma scenario, this is very commonly seen. Age is irrespective, but sometimes they come with this type of picture. In the back of your mind, it looks like an infection that has to be rolled out, and you keep your revision set ready. Most important thing is the role of hinges is definitely useful, but it should be restricted to selected indication, mainly for elderly patients who are not much life expectancy, especially in patients with collateral ligament insufficiency, massive bone loss, hyperlaxity, severe varus valgus more than 20 degrees, and severe rheumatoid arthritis. Selection of implants always it comes with 3 different criteria. One is your manual selections. These have been doing, everyone has done this, and it has excellent sizing of the implants under safe hands of the senior surgeons, where nearly 85% will come into accurate. But the sometimes what happens is you may medial overhang or posterior will be offset is less, or the lateral overhang. That issues can occur with a conventional thing. That can be overcome with your navigation, CAS, computer-assisted navigation or robotics. It has the accuracy of placing the implants, and the outcome is nearly 95% success rate. Then finally, the take-home message is patients struggle in making decision for TKR. The patients should be make a decision for what they want, either activities of daily living or for keeping the lifestyle free. So symptomatically, severity and psychological readiness is key from the patient side. From the surgical point of view, surgeon point of view, clinical and radiological diagnosis both should be combined to give approximately 85% of appropriateness for surgery. That is very, very important. Outpatient arthroplasty only for selected patients who are mentally fit, or all the comorbidities that has to be optimized to be discharged within 24 hours. Any implant design works wonders if ligament balance and alignment is achieved. CAS has proved better functional outcome than conventional because the placement of the femoral component or the rotation of the tibia excellently can be placed near normal anatomical. I think in future the robotics will take over, and we are coming with the robotics as well, where it follows the same accuracy pattern as computer-assisted navigation. Primary complex and severe vargus knees requires higher constraints on table. Otherwise, you will be on trouble in the patients. Thank you.
Yeah, good morning, Dr. Chandrasekhar and Dr. Jagan Mohan. Nice to see you all.
Morning. Good morning, Uday.
Yeah, morning, Chandrasekhar. I think your topic is getting it right in bilateral total knee is one of my favorite topic, and I hope you got it right. We'll start with Dr. Chandrasekhar sir video. Edwin, please start the video.
Kindly start the video on getting it right in bilateral total knee arthroplasty.
Good morning, everyone. I'm Dr. Chandrasekhar, orthopedic consultant at Medicover Hospital, High Tech City. My topic for today is on how to get things right in bilateral total knee arthroplasty. Though bilateral total knee arthroplasty appears to be an attractive option for both the surgeon and the patient because of less operative cost, avoiding multiple anesthetics and multiple hospitalization, and quicker rehabilitation, there are some potential challenges and risks associated with a bilateral procedure, right from choosing the correct patient to having adequate infrastructure to having surgical expertise. All these things are quite challenging, and there can be issues with pain management and rehabilitation. Ideally, it should be done in a high volume center. It can be technically demanding, and there's a potential risk of cross-contamination while performing a simultaneous procedure as well. Apart from this, there are several published reports of increased complications and mortality with simultaneous bilateral TKA, like this paper from Sweden, and also the Javed Parvizi group, which has shown increased risk of pulmonary embolism, cardiac complications, and mortality with simultaneous procedure. There can be other generalized complications like associated with GI system, as well as slightly higher infection risk. However, there are several reports on the contrary which have shown higher satisfaction rate with good success stories, less operating time, less use of pain medication, quicker mobilization, less overall treatment costs, and no increase in complications. However, these reports are from good high volume centers where they do this regularly. So if you see somebody with significant bilateral varus deformity like this, or a significant bilateral valgus deformity, or significant bilateral flexion contracture, this kind of patients, if you do a unilateral procedure, they will still have persistent deformity on the unoperated side. And the patient may have difficulty with mobilization if you do a unilateral procedure. This kind of patients are ideal for a simultaneous procedure. So the key factor for the success of simultaneous bilateral TKA is a proper patient selection. An ideal indication would be somebody with severe flexion contracture or severe bilateral angular deformity, and somebody who can't afford to have multiple anesthetics, like somebody with ankylosing spondylitis, etc. Relative indications if there are any financial constraints, or if the patient can't afford to have multiple hospital visits or can't afford to have multiple days off work, would be suitable for a bilateral TKA procedure. However, while selecting a patient, make sure that patient does not have any comorbidities, especially any cardiac history, ideal an ASA 1 or 2, and make sure that the patient has good pain threshold on preoperative assessment. Inform the patient properly about the pros and cons, and make sure that they understand the implications of the bilateral TKA, and make sure that the patient will also comply with the rehabilitation postoperatively. Preferably avoid bilateral TKA in somebody who is elderly and with any cardiac history, and ASA grade more than 2 is a definite no for a simultaneous procedure. If you feel that patient has low pain threshold and reluctant and unlikely to comply with rehabilitation, you have to sort of choose them properly and discourage them from having a bilateral TKA. And at the same time, you should make sure that you have adequate infrastructure, ideally a high volume center is the best place to have a simultaneous TKA procedure. And somebody who is a beginner should not be contemplating a simultaneous procedure because of increased operative time. And make sure that you have an expert anesthetist and a safe theater environment with experienced nursing staff who can take care of the patient post-operatively. Perioperatively, make sure that the patient has a safe anesthetic, ideally done under an epidural anesthesia, because general anesthesia can increase the overall operating time and the anesthetic time. Make sure that you have adequate protocols to avoid blood loss, like IV tranexamic acid and tourniquet control. There should be backup from the blood transfusion. Make sure that the fluid management is appropriate postoperatively, and make sure that you have a good cardiac backup if you are contemplating a bilateral TKA. Though it can be done either sequentially or simultaneously, I feel a sequential procedure is technically easier and less chance of cross-contamination. Both limbs should be prepped and draped simultaneously. More symptomatic side should be operated on first, because if there are any anesthetic problems intraoperatively, at least the more symptomatic side would have been operated on. Administer 1 gram of cephalosporin as the first dose before tourniquet inflation, and even after inserting the first component, deflate the tourniquet and administer the second dose of 500 mg cephalosporin antibiotic. And after closure of the capsule of the first side, start the second side, and after inserting the second component, administer the third dose of IV antibiotic, 500 mg cephalosporin. The key steps are to minimize the surgical time and avoiding mixing the instruments and contamination. Use small standardized incisions. Don't experiment with newer implants, and avoid drains to reduce blood loss. Use compression bandage and ice packs, and robust pain management protocols like local infiltration methods, and peripheral nerve blockade using adductor canal blockage and postoperative local anesthetic infiltrations, and avoid any opioids in these patients. Patients should be monitored carefully postoperatively for any cardiac issues, and thromboprophylaxis with any of these agents is a must, along with mechanical devices, and early mobilization and rehabilitation is the key. In conclusion, simultaneous bilateral TKA can be done safely in somebody who does not have comorbidities, ideally patients less than 70 years with significant bilateral problem, in a place where there is good backup for postoperative care, and standardized protocol for anesthesia, pain management, and rehabilitation are in place. Thank you.
Thank you, Dr. Chandrasekhar. A very nice presentation. Please be available for the discussion in another 5-10 minutes. We'd like to invite Dr. Jagan Mohan Reddy for a patient selection of preoperative evaluation of unilateral knee replacement. So I would request admin to start the video of Dr. Jagan Mohan Reddy on UK.
Good morning. Welcome to TOSACON virtual conference, orthoplasty session. My name is Jagan. I am presenting one interesting topic on patient selection, preoperative evaluation for unicompartmental knee replacement. This is brief about myself. I trained in initial part of my training was in Usmania Medical College General Hospital. I was a former assistant professor in Usmania Medical College. Went to abroad, went to UK, trained in UK for 14 years. I was an ex-consultant from Royal Preston Hospital, Chorley Hospital. I did a few research projects with Oxford University and Warwick University. Did fellowships in hip and knee and trauma. So indications for unicompartmental knee replacements, general indications are similar to the primary total knee replacement. But in unicompartmental knee replacement, it's entirely different. It got its own preoperative evaluation, it got its own indications. The pain on standing, severe on walking. And if it is on sitting, there's no pain, or lying down, there's no pain. So the pre-op assessment, the pain mostly on the medial side. It may be on the anterior, it may be posterior, it may be lateral. So the localization of the pain is not important. So no pain on sitting because of intact posterior articular surface. Lying down, no pain because of unloading. Severe pain on walking, limitation of their daily activities. So what are the criteria for unicompartmental knee replacement? Should be 9 to medial osteoarthritis, intact ACL, ligament should be intact, and full thickness cartilage on the opposite side, and correctable varus deformity and fixed flexion deformity should be less than 15 degrees. The physical signs, the varus deformity should be 5 to 15. If the varus is more than 15, there is a possibility of ACL rupture, and it is more subluxation, and it is a contraindicated for uni knees. Lateral thrust is often seen even in minor varus deformities or up to 15 degrees. You can see the lateral thrust. It is not a contraindicated for uni knees. Fixed flexion deformity, it should be less than 15. More than fixed flexion deformity of 15 degrees, it is contraindicated due to posterior capsule shortening and osteophytes. Range of motion also important. Should be more than 100. If it is less than 100, it's difficult to expose and it is contraindicated. The moderate effusion and synovial swelling is quite common. It's not a contraindicated. Pivot shift test, joint stress, latchment test, these all should be reserved for traumatic conditions, not for the degenerative knees. In degenerative knees, if you want to test for ACL, if you do this test, you will get either pseudo-positive or pseudo-negative because of articular deficiencies or because of the osteophytes, you will get it. So the preoperative planning is very, very important in unicompartmental knee replacement. As you're aware that NJR, the data shows, natural joint registry shows, the maximum revision rate is for the unicompartmental knee. Why? Because of poor selection of the patient. So the preoperative planning, preoperative selection of the patient is very essential in unicompartmental knee replacement. Proper X-rays are mandatory. Patient selection and planning of unicompartmental knee replacement. So X-ray should be ordered, AP views in standing, full extension, standing and flexion, lateral views, patellofemoral views, long leg views, supine stress views These are all essential in unicompartmental knee replacement. Radiology plays a key role in unicompartmental knee replacement. Radiographs is the most useful adjunct to the physical science. So anterior-posterior view, weight-bearing in full extension, weight-bearing in flexion, non-weight-bearing varus valgus stress. Valgus stress X-rays are very important, non-weight-bearing. It demonstrates the opening of the medial side. That shows that intra-articular deformity has corrected, and medial side should be having at least 5 mm. That means MCL is intact. Lateral side, you should see the gap minimum 5 mm. That is an articular cartilage gap. So varus stress also very important. That shows the medial bone-to-bone contact. So, and lateral views are also important. It shows that any osteophytes and the posterior part of the tibial plateau and posterior femoral condyles, they should be intact if you are planning for unicompartmental knee replacement. And you always see in the varus deformity some mediolateral subluxation. That should be corrected by the valgus stress. If it is not corrected, mediolateral subluxation, it is a contraindicated. And intraoperative observations. When you are planning for unicompartmental knee replacement, you always take a concern that I am going to do uni on table after opening of the joint. If it is not suitable, I will convert to the total knee replacement. So you should order the total knee replacement also on standby. Intraoperative, you check again ACL, you check the lateral compartment, check for the patellofemoral joint. And there are some dilemmas whether it is indicated or not. One is age. It is not a contraindicated. Young age you can do because they do a lot of activities. Unicompartmental knee replacement will withstand the physical activities. Old age, easy to do, easy recovery, less hospital stay, less blood transfusion, and good recovery. Activity level, there is no evidence connection between the outcome of the UKA and the activity levels. Weight, previously they thought high BMI is a contraindicated, but it is not a contraindicated. But only thing is bit technically challenging, difficult to expose the joint, difficult to do. Patellofemoral arthritis, a little bit controversial subject. If it is a full thickness bone loss, don't do it. If it is a mild fibrillations on the medial facet, can do the unicompartmental knee replacement. And degenerative lateral meniscus is absolute contraindication for UKA. So you can do a pre-op arthroscopy. Some surgeons prefer to do pre-op arthroscopy or MRI before going for UKA. And chondrocalcinosis, it is a controversial subject. Some authors said if it is a mild chondrocalcinosis, you can do, but it is an inflammatory condition, better to avoid. And spontaneous osteonecrosis of the knee is not a contraindicated, but only thing is some bone defect will be there. We have to pack with the bone cement. And failed upper tibial osteotomy is a contraindicated for unicompartmental knee replacement. Post-traumatic arthritis, again a controversial subject. If it is isolated arthritis on one compartment, all ligaments intact, if fits the criteria, you can do the unicompartmental knee replacement in post-traumatic osteoarthritis. Contraindications, one is inflammatory arthritis like rheumatoid arthritis, gout, ankylosing spondylitis, or any inflammatory arthritis, it's a contraindicated. So general contraindications are applicable for this uni also, like vascular insufficiencies, neurological deficit, loss of sensations, inflammatory arthritis, ACL deficit knee, no bone-to-bone contact on the medial side, intra-articular varus deformity is not correctable fully, mediolateral subluxation is not correctable fully with the valgus strain, flexion deformity more than 15 degrees, flexion range is less than 100, thinning or erosion of the central cartilage of the lateral compartment, and previous valgus tibial osteotomy, bone loss or complete bone loss on the patellofemoral joint. In summary, unicompartmental knee replacement is a good operation, but patient selection is very, very important. The pain is severe enough to go for surgery, FFT should be less than 15, range of flexion should be more than 100, varus should be less than 15, ACL should be intact. A full thickness loss on the medial side, full thickness cartilage should be preserved on the lateral side, intra-articular surface back of the tibial plateau should be intact, intra-articular deformity should be corrected manually. On the intraoperative, ACL should be intact, lateral compartment should be intact. Thank you. Thank you for patient listening. Thank you very much.
Yeah. Thank you, Dr. Jagan Mohan. My request, Dr. Jagan Mohan, to be online. And I request Dr. Chandrasekhar also be a part of our discussion. Dr. Jagan Mohan, are you there? Dr. Jagan Mohan. Meanwhile, before joining with Jagan Mohan, I would like to have a question with Dr. Chandrasekhar. Are you there, Chandu?
Yes, Uday.
Yeah, morning. No, very good presentation, Chandrasekhar. And your institute, of course, have a bigger setup for bilateral knee. But what is your take on stage versus sometimes we do 3 days, 4 days, the other leg. Primary we do 1 day, and after 3 days we do the other leg. Do you prefer that one, or to you directly go for bilateral one stage?
See, first of all, most of the patients who have bilateral problem have one side which is more symptomatic. I personally am not a big fan of bilateral total knee arthroplasty.
Yes.
Okay? One, it's because of the high risk of complications which has been reported, especially any cardiac history is a definite no. So as I was explaining in my talk, proper preoperative evaluation and make sure that patient does not have any cardiac history. Okay, so we have done stage procedures with a 3-day gap, but my personal preference would be to wait for at least six to 8 weeks before contemplating a second site, unless there is a compelling reason from the patient side, maybe financial reasons, or patient can't take time off work, or it's a personal choice. And more often, if the patient understands the risks associated with that, I feel doing in the 3rd day or the 4th day is also a slightly risky factor, because that's when the inflammatory process is high and slightly higher chance of DVT, pulmonary embolism.
Your take-home message was that to do a bilateral at a single day, or otherwise postpone maybe over 6 weeks, not to do it 3 or 4 days. Yeah, well taken point, because the HSS study also showing that high rate of complications if you do at a 3rd or 4th stage, where you have high risk of complications, are especially pulmonary embolism, where patient has all the catabolic effects starting, and high rate of blood transfusion as well. So what is your the other question is your take on the tranexamic acid. You mentioned tranexamic acid. Are you preferring the intra-articular tranexamic as well on table?
I mean, I personally don't use intra-articular.
Okay.
It's a parenteral tranexamic acid which we administer just before the start of procedure.
Okay. Thank you. Well discussion of Chandrasekhar, and it's a critically complicated topic. Bilateral is always my number have been a lot decreased because we had pulmonary issues. Patient went to ventilation. We don't want patients for routine electric cases to go into ventilation because of the bilateral. So
I think one bad case is enough to spoil the reputation.
Yeah, spoil the entire thing. Yeah,
absolutely.
Yeah. Dr. Jagan Mohan, are you there? Jagan Mohan, yeah, he's not there. Yeah. Are you comfortable, Chandra? Like, can we discuss knee in 1 or 2 questions so that we can wrap up this session?
Sure.
Yeah. Do you prefer preoperative MRI for uni knee? Because Dr. Jagan mentioned that some surgeons might prefer preoperative MRI. Because more of you're using robots anyway. You use MRI preoperatively. Some are preoperative MRI. Some do robots may not do preoperative MRI. So what is your take on MRI preoperative for uni?
I don't think a routine MRI is necessary for doing a uni unless you have a suspicion about the ACL intactness. Because that's one of the biggest more essential criteria for doing a uni. You need to have intact ligaments, ACL. So clinically, if you're suspecting there is a possibility of ACL injury, or if the ACL is not healthy enough, then yes, you can do an MRI for assessing the ligament. And at the same time, if you're suspecting a Sonk lesion or any other pathology, if you're suspecting inflammatory pathology to exclude any synovitis clinically, then yes. Otherwise, I don't think routine MRI is necessary for doing it.
Yeah, Dr. Jagan, good morning. Dr. Jagan, good morning. Good morning. You have to unmute.
Yes, done.
You're driving.
It's okay. Yes.
It's a bit risky, and especially your new car, and a bit risky. Be careful. Don't see
No
me.
problem,
Yes. A couple of quick questions, and I'll wrap up this.
Yes.
The most important thing is, in your talk, you mentioned about National Joint Registry. As the registry shows, because especially in the England and Wales, the revision rate is very high, 3.2 times compared to your routine
primary knees.
Yeah, primary knees. So, do you follow the literature, or it all depends upon the experience of surgeons or number of surgeries who do? Because on the safer side, it's a surgeon or the numbers it matters. What do you suggest?
Yes, the maximum revision rate is done in surgeons who has low volume surgeons. They have done 1 or 2 cases in a year.
Okay.
And other thing is they thought the primary uni knee is easy to convert into the total knee replacement. If the patient comes for any other pain, they won't investigate further.
Yes.
So they think that it is because of other compartment involvement or PFJ involvement.
Okay.
They will easily revision will be done. But the thing is, if we take the NJR registry,
yes,
the maximum revision rate is for the unicompartmental knee replacement. Why?
Okay.
Because the surgeons who do very low volume, 1 or 2 cases per year,
yes,
they have high revision rate. Second thing is, they won't investigate. They won't further investigate further. What is the reason for painful unicompartmental knee?
Yes.
They think revision is easy, so they will revise it.
Yes. Regarding the second question, you were very specific about your indications, your stress views or other views.
Yes.
Yeah,
correct.
but you said that the BMI is not a much
contraindicated.
Yeah, it's not a contraindicated. What are the other extended indications? Because initially BMI was contraindicated for uni knee. What are the other extended indications you want to suggest for younger surgeons? See that.
Yes. Previously, the high BMI, they thought if high BMI, it can't withstand the unicompartmental knee.
Yeah.
But the BMI is not contraindicated as per the Oxford data.
Yeah.
Even if it is a very high BMI, you can still do the unicompartmental knee. But for the beginner, it is very difficult to do uni in especially high BMIs. If it's big thighs, big legs, it is very difficult to expose. We are giving a mini orthotomy.
Yes.
Access is very difficult.
Yes.
So putting a component in a right direction and right alignment is very difficult in high BMI patients.
Okay. I will leave you there, Dr. Jagan. If possible, you can participate in the thing because
definitely.
I really fear of driving and talking.
No, it's fine. It's fine. Don't worry.
But be careful and
happy
journey for new vehicle. Dr. Chandrasekhar, always good, and thanks for joining, Chandrasekhar. I'll see you later. Huh?
Thank you.
Now we'll go with the second session of talks. We are 10 minutes delayed, as the admin was saying. We'll go to the other talks. I request faculty, Dr. Neelam Ramana Reddy, Dr. Rammohan Reddy, and Pradeep Reddy, and Dr. Uday Prakash to be ready. And we'll start with the video presentation. Getting it right, surgical techniques. And these are mostly some amount of videos. So I request admin to start soft tissue balancing in varus knee by Neelam Ramana Reddy.
Sir, shall we start, Doctor?
Yes. Yeah, please start. Soft tissue balancing in varus deformities.
Kindly start the next video.
Morning. I'd like to thank Dr. Guruvareddy sir, Dr. Timareddy and the organizers for giving me opportunity to present this talk. Soft tissue balancing and varus deformity is a very common deformity and is the most common deformity we see while doing knee replacement. Here we're able to see the X-ray on the left, where they have the medial femoral osteophytes, tibial osteophytes, tightening of the medial structures, and laxity of the lateral collateral ligament. The classification system of varus deformity was proposed by T. Point and Pervez in Journal of Arthroplasty 2015. There's intra-articular deformity, metaphyseal and diphyseal. Intra-articular deformity is classified further into reducible with anteromedial osteoarthritis with intact ACL and posteromedial osteoarthritis with deficient ACL, and a fixed deformity without lateral instability and with lateral instability. Next, we come to a metaphyseal deformity, which is within 5 centimeters of the joint line, femoral or tibial, where extending to the metaphyseal region changes in the joint line obliquity and metaphyseal anatomy. The diphyseal is more than 5 centimeters from the joint line, maybe a tibial level, femoral deformity, or combined deformity. The varus deformities are basically of two types: a fixed varus or a correctable varus that we can quite often see in our OPD itself when we are clinically examining the patient. A fixed varus deformity patient will require extensive ligament release and balancing because there's lateral elongation and laxity of the lateral collateral ligament. In a correctable varus deformity, the ligaments are normal, there's no medial tightness, only there's an intra-articular bony defect, and it's manageable by appropriate bony resections with minimal soft tissue release. Now, in a varicity, what approach we commonly do, either the medial parapatellar or the vastus, subvastus, or mid-vastus approach. Any approach that you do, it's very important to do a sequential soft tissue release according to what the protocol which is acceptable. And what we normally do is first is expose the tibia, anteromedial soft tissue exposure, progressively go to the posteromedial release, remove the osteophytes from the femur and the tibia, release the deep MCL, posteromedial corner, the attachments of the semimembranous as we progress. Once we have done this and you still feel tightness is there, then we release the superficial MCL and avoid complete release. Though in certain cases we have also done complete release of the superficial MCL also. And in between, whenever we require, we probably release the PCL. So the decision to do a CR knee or a PS knee is based on the surgeon, and your PCL release will be based on that. This is the anatomy of the showing the origin and insertions of the ligaments that are involved in the medial varus release. You have on the top is attachment for the superficial medial collateral. This is the posterior fibers. This is anterior fibers. We see the insertion down. The anterior fibers are a little longer, inserted with the medial tibia anteriorly, and the posterior fibers are posteriorly. This is the deep MCL originating from the femur and down into the proximal tibia. This is a semimembranosus insertion into the posteromedial part of the proximal tibia. And this is the insertion of the PES group on the anteromedial border of the upper tibia. Now, this is the deep MCL that you're able to see in a cadaver section, origin from the femur, insertion into the proximal tibia. You're able to see this. This is the deep MCL. Next is the superficial MCL, which comes in two bands, the anterior and the posterior band, and this is the PES. We're able to see this this is a superficial MCL, anterior fiber, superficial MCL, posterior fibers. This is the PES, which is inserted. Semimembranous is inserted into the proximal posteromedial part of the tibia. This is the thing, inserting into the proximal tibia. The PES, which we rarely release, but we have to come across the anatomy regularly, we're able to see it. This is the superficial collateral in the two bands, and the PES crosses it to go insert into the anteromedial tibia in the upper part. Now, the releases of the varus knees are graduated, sequential, and has to be progressed depending on the severity of deformity from mild to severe. In a mild deformity, what we'll do is a medial capsular release, a deep MCL release, and remove all the osteophytes. With this, we can expect an opening of about 2 millimeters on the medial side. You're able to see the release of the medial MCL. We can either use a periosteal elevator or with the cautery also. It results in opening of 0 to 2 millimeters and is adequate release for mild deformities. As the deformity progresses, next we have to go to release further structures. After removing the osteophytes, we release the semimembranosus and the posteromedial corner. You're able to see as we turn the leg, we'll show you in the future video and in the pictures also how we release the semimembranosus and the posteromedial corner and take out the posteromedial osteophytes. This is the semimembranosus. So in moderate deformities, we get an opening of around 2 to 4 millimeters with this kind of release, and that's adequate for some of the cases. As the deformity progresses and you have tightness in extension and flexion, Now, the previous what I said about semimembranosus, it affects more of the extension tightness. Now, when the tightness is in both flexion and extension and the deformity is moderate, then we have to release the superficial MCL. We can do that with a periosteal elevator. The anterior fibers or the posterior fibers, often pretty difficult to do it selectively, but if you have an extension tightness, you're supposed to release the posterior fibers, and if you have a flexion tightness, you're supposed to release the anterior fibers of the superficial MCL, and the opening can be around 4 to 6 millimeters with a partial release of these. You're able to see it with a Cobb's elevator or a periosteal. We can release the posterior fibers and the anterior fibers in this image. Now, this is releasing the semimembranosus with the. Once we can do a partial release or a complete release also. When we have marked tightness in both flexion and extension and the severe varus deformity of long duration, the MCL is often very, very tight, and we have to release it as a continuous periosteal sleeve from the proximal tibia. And this will obviously cause a little more opening up, and that can be sometimes more severe also. So we have to be careful while doing this. So superficial MCL, anterior fibers, posterior fibers, and the semimembranes all released subperiosteally and completely. Soft tissue stabilized involved in a varus knee can be divided into static stabilizers and dynamic stabilizers. The static stabilizers are the collateral ligaments and the posterior oblique ligament. The dynamic stabilizers involved in the varus knee are the semimembranosus. It's important to understand these structures and understand which ones are released in which deformity, and when both are tight, how do you release them? So this is a photograph of the initial valve release. As we open the knee, we are releasing the anteromedial tibia going across to the midline. At this point, we take out whichever osteophytes are there on the femur and the tibia and see how much of an opening there is. If we find the opening is adequate here, then we stop releases here, or otherwise we go progressively and go to the posteromedial corner. Here we release the posterior oblique ligaments and the semimembranosus here and take out all the osteophytes from the femur, from the tibia here and the posterior medial corner. When this also is not adequate and we find tightness both in extension or flexion, and depending on what it is, we do the release of the superficial medial collateral. We can go up from the proximal tibia up to 3 to 4 centimeters down, taking care to prevent damage to the pes ancillaris, which I'm showing you with the arrow here. This is a short video about how we are doing our releases and structures on the posteromedial tibia. It's very important. I often do not use a periosteal elevator. I use a quantity releases, but I find it more reliable and easier to do. Going right across the semimembranosus and all the way till the posteromedial corner. Here you're able to see osteophyte and the medial osteophytes that have to be removed also. Once we take out these osteophytes, we are able to relax the medial MCL also. Posteromedial osteophyte. Very, very important to take out all the osteophytes. Right, when we can feel it, and when all is done, that's pretty adequate. So once we take out all these, even in certain cases when there's still tightness, surgeons have proposed reduction osteotomy where we actually downsize the tibia as in relation to the femur and take out the posteromedial bone again. This also will relax the MCL and prevent any tightness that is occurring there. You're able to see how an osteophyte which we leave behind can cause a stretching of the MCL. You're seeing both the tibial and the femoral osteophytes. What we have started in the recent time is pie crusting. I don't know how many of you do it, but I find it pretty useful and I do it in quite a lot of cases where we actually put a laminar spreader, check the knee in extension and in flexion. And if you do fine medial tightness, we put a laminar spreader inside and release the MCL. Now this is the MCL held, the posterior fibers and the anterior fibers. We can either do this with an 11 number blade, which I have not used. I usually do it with an 18 gauge needle. The posterior fibers are released of the MCL when we have tightness and extension only, and the anterior fibers are released when there's a tightness and flexion. If there is both releases, then we can make multiple stab incisions of 3 to 4 stabs with a needle and get graduated release and keep on checking it as we are releasing it. Papers have been published in Journal Arthroplasty by multiple people, even in 2019 and 20, with selective release of the medial MCL with pie crusting, which I find it very useful. Varus knee is a very common deformity, particularly soft tissue balancing in a stepwise approach, and should be carried out only after osteophyte removal. In conclusion, varus knee is a highly effective TKA in a varus knee is a highly effective surgery with good results and patient satisfaction. If an adequate soft tissue balance, stability and alignment and fixation are obtained, the results are excellent. Thank you.
Yeah. Thank you, Dr. Ramna. Very good presentation and illustration. I would request Dr. Ramon Reddy for a soft tissue balancing in valgus deformities. Admin, please start it. The valgus deformities, soft tissue balancing. It's a very important topic. The young surgeons should start their surgeries only after first varus knees, followed by valgus. I request to start the soft tissue balancing in valgus knees videos.
Good morning. I'm presenting the topic on soft tissue release and balancing in knee replacement for valgus deformities. Clinical assessment of a valgus knee is very important. There are 3 grades: less than 10 degrees valgus, 10 to 20 degrees, and more than 20 degrees. Our clinical practice often see type 1 and type 2 cases, whereas type 3 is very rare. Type 3 is a severe form, degree of deformity, where the MCL is not functioning and the lateral structures are not correctable. Radiological assessment is equally important. We need to know whether there's any deformity of the distal femur or the proximal tibia. We also need to know whether the patellar tracking is good or whether it is dislocated or mal-tracking. At the end of the day, clinical and radiological assessment help us to know whether the valgus knee is flexible or rigid and what kind of releases we need to consider. Soft tissue release in valgus knee starts with the approach, whether you do medial parapatellar or lateral parapatellar. The tissues we need to consider are the posterior cruciate ligament, iliotibial band, popliteus, posterolateral capsule, lateral retinaculum, lateral collateral ligament, and the lateral head of gastrocnemius. We should also not forget about the medial collateral ligament, which is stretched or elongated on the medial side, and whether we should deal with it by tightening it. As I said before, there are 2 approaches, lateral and medial parapatellar. Which one is good? The advantages with lateral parapatellar approaches are lateral retinacular release is part of the procedure. Access to the lateral soft tissue is easier with this approach, and the blood supply to the patella is not compromised. As you can see in the right down picture, the tissues on the lateral side are easier to access if a lateral parapatellar approach is done. However, the picture actually shows a medial parapatellar arthrotomy. The disadvantage with lateral parapatellar approaches are it can be confusing to the surgeon. The orientation is totally different and difficult because we do them rarely. The closure of the retinaculum is often tricky and difficult. Accessing the medial structures is not easy. We all use a medial parapatellar approach for routine knee replacements. This is usually enough for type 1 and type 2 deformities. Patellar dislocation and accessing the joint is easy. The disadvantages are the surgeon can unknowingly do excessive medial release. Blood supply to the patella is compromised if it is combined with lateral retinacular release. Accessing the lateral soft tissues is a bit difficult. Sometimes we have to combine it with a bony procedure, tibial tubercle osteotomy. This is how I do a lateral retinacular release. The brown line from the superior pole of the patella to the inferior pole. If we go a bit high, as seen by the thick black line, then we can injure the superlateral genicular vessel. And if we go too low, which is usually unnecessary, sometimes closure of the retinaculum can be difficult. Posterior cruciate ligament is often tight and contracted in the valgus knee. So make it a routine to release it from the femur. Avoid cruciate retaining knee replacement. It is easy to release it from the femur than from the tibia. Iliotibial band is inserted into the Gerdy's tubercle, which is superior posterolaterally to the patellar tendon insertion. We can release it by doing multiple stab incisions, which is called pie crusting, or by releasing it from its insertion either partially or completely at the Gerdy's tubercle. Popliteus tendon is an intra-articular structure. It is easily seen while doing a knee replacement. It is located posterolaterally and easy to release it without injuring other structures. This is a controversial topic, whether we should release the popliteus tendon or not. We will come to it later. Posterolateral capsular structures located between the posterior border of the iliotibial band and the popliteus. These structures can be released by pie crusting using multiple stab incisions with a number 15 blade. Ranawat et al. Advocated the use of electrodiathermy and releasing this posterolateral structure at the level of the tibial articular surface. The risk is injury to the lateral collateral ligament and the common peroneal nerve. It's very important that we know our anatomy before doing such releases. I find this instrument very useful, laminar spreaders with flat plates. It helps to assess the gap balance on the medial and lateral side, and also helps to open up the structures on the posterolateral corner, which we can access easily. As the deformity gets more rigid and severe, consider releasing the lateral collateral ligament. We can release it from the femur insertion, as seen in these pictures. Or we can do lateral collateral ligament osteotomy and distalize it so that the lateral gap opens up. The question is, will the knee be stable after lateral collateral ligament is released? We'll come to that later. And finally, the lateral head of gastrocnemius, where there is a flexion contracture with severe valgus deformity, consider releasing the lateral head of gastrocnemius. It is difficult to access this muscle through the surgical approach. It is easier to use a separate posterolateral incision, identify the biceps femoris and common peroneal nerve, and then get hold of the gastrocnemius lateral head and release it from the femur. Now, there are certain controversies regarding the sequence of releases of these soft tissues. One standard rule is do all the releases in extension. Now, what are the controversies? As according to Krakow et al., iliotibial band and lateral collateral ligament should be released first. If necessary, then popliteus and posterolateral corner should be released. Ranawat et al. Were of the opinion that posterior cruciate ligament should be released first, then assess. If needed, release posterolateral corner, iliotibial band, and lateral collateral ligament in a sequential manner. Ranawat et al. Suggested that popliteus tendon should be preserved and should not be sacrificed. Much more controversy comes. According to Favorito et al., it is the lateral collateral ligament which is the culprit in valgus knees, so it should be released first. And then assess. If needed, release popliteus followed by posterolateral corner and the lateral head of gastrocnemius. Finally, release the iliotibial band if necessary. As we can see, none of the senior surgeons or academicians with so many years of experience don't agree to a standard sequence of releases. Everyone has got their own theory and experience. Much more controversy follows. Whiteside et al. They said that the soft tissue release for every knee should not be the same. The soft tissue should be assessed in extension and flexion. As per Whiteside et al., if the knee valgus deformity is tight in extension, then we should release iliotibial band and posterolateral corner structures which are away from the femoral epicondyle. If the knee valgus deformity is tight in flexion, then the lateral collateral ligament and the popliteus tendons should be released, and these are attached very close to the femoral epicondyle. In summary, a flexible valgus deformity can be corrected and a knee replacement can be done with a medial parapatellar approach. The tissues that are released in sequence are PCL, ITB, popliteus, posterolateral capsule, and lateral release, if necessary. If the deformities are rigid and severe, one can consider lateral collateral ligament release or osteotomy and lateral head gastrocnemius release. Remember, you should have your components valgus varus, constrained knee, as well as hinge knee on the shelf before we go into the theater. If excessive lateral release is done to balance the lateral and medial gaps, then there will be a big extension and flexion gap, which will necessitate a thick insert. Common peroneal nerve palsy is very common, with a very large gap. Sometimes it is better to do a less release, tighten up the medial structures, and do a hinge knee replacement. My practice has been very standard. I always use a medial parapatellar approach. Always start off with the posterior cruciate ligament release as advocated by Ranawat et al. I don't use a cruciate retaining knee for valgus knees. Always a PS knee. And then the sequence of releases is ITB, either partial or complete from its insertion. I don't routinely do stab incisions or bicrusting. Popliteus release is done in most of the cases. And then I use the laminar spreaders, see the gap balance, and if necessary, then I do bicrusting of the posterolateral corner. I don't use the electrodiathermy procedure as advocated by Ranawat et al. So far, I have not done lateral collateral ligament release in my practice, and I find it easier to do a hinge knee replacement if the deformity is so severe. Some examples of the cases, you can see there's a distal femur articular deformity, but the tibial plateau is normal. In this case, I used a standard posterior cruciate ligament sacrificing knee replacement. Another case of valgus knee due to malunited lateral tibial plateau fracture. In this case, I used a posterior cruciate stabilizing knee with a stem. If the deformity is very severe in malunited fractures, then valgus varus constrained knee with high tibia post and stems can be very useful, as seen in these X-rays. And finally, this is a 65-year-old male where there is a valgus deformity and a genu recurvatum. There is no significant distal femur deformity. There is no significant tibial plateau deformity or bone loss. So what should be the implant of choice? I did a total hinge knee replacement for this patient. Now, why should we do a hinge knee replacement in such cases where there is no significant bony deformity? The answer lies here. A thorough physical assessment will decide what kind of implant we need to use. This patient had neuromuscular disease. He had severe valgus and genu recurvatum, which cannot be seen on bony deformity, on plain x-rays. So the plain x-rays can be misleading. Don't jump into it and do a simple posterior cruciate retaining or posterior stabilizing knee. They will fail. They will dislocate. So a clinical and radiological assessment is very important, as I said in the first few slides, before we decide how much soft tissues to release and then implant the knee components. Thank you for listening.
Yeah, well, thank you, sir, for good illustration. The last case was really good. Now I'd like Dr. Pradeep Reddy videos, fixed flexion contracture and recurvatum knees. Some of the exercises might be seen with the recurvatum knees. He's an expert in this. I would like Edmund to start Dr. Pradeep Reddy's videos. Edmund, start please.
Okay, sir, starting.
Everyone, I thank the TOSACON organizing committee for giving me this opportunity to present about the flexion and recurvatum deformities in total knee arthroplasties. As we all know, the flexion deformity is one of the commonest deformity we deal with. We need to quantify and classify it, optimally counsel the patient about the need of the post-operative rehabilitation, and be ready with additional armamentarium in cases of severe deformities where we may need higher constrained implants. And there's no significant role of any preoperative bracing or deformity correction, as most of it is done intraoperatively. And when we're dealing with inflammatory arthritis and the hips are involved, we know what to operate first. The pathophysiology is about tight posterior structures and the lax anterior structures, and sometimes with bone loss, and in severe cases with fragile tissues and osteoporotic bone. A flexion contracture of greater than 15 degrees led to mechanical overloads, giving adverse outcomes. So it is very important for us to correct the deformity as much as possible. There's another paper showing that a fully corrected knee, while during the surgery, can develop a fixed flexion deformity again after 2 years, especially in patients who have had preoperative flexion deformity, and it was more common in males and patients of a higher age group. Lombardi et al. Has given us a classification of grade 1, 2, 3 of less than 15 degrees, 15 to 30, and 30 or more. The first grade, that is less than 15 degrees, is most often a soft tissue procedure where we need to debride all the posterior tenting osteophytes and release the posterior capsule and balance the PCL. And in grade 2, probably excise the PCL and take an additional 2 millimeters of distal femoral cut, which can give us about 10 to 15 degrees of correction. Grade 3, we need to be more aggressive in terms of releases or the bone cuts. At the same time, when we are more aggressive, we need to be ready with higher constraint implants like a hinge. At the end of the surgery, before implanting and while trialing, we do this Laskin test where a fully straightened knee, while the foot is dorsiflexed and the actual pressure is applied, if there is sudden flexion, then there is a residual flexion deformity. And if there is no bending of the knee, then it suggests that adequate correction has been achieved. This is the stability matrix, which we are all aware of. This is the area we are dealing with when we are dealing with a fixed flexion deformity. We generally do not have problem with the flexion. So in order to match the tight extension, we can afford to use a higher size or a bigger size femur to compensate for the loose flexion. Post-operative management, the patients are encouraged to do quadriceps. Sometimes we use night splints, and definitely there is no role of any CPM. Rather, a well-motivated patient is more important than having things like CPM. Recurvatum. It's unusual, but then yes, about 1% or less of patients requiring TKA have recurvatum, and generally due to quadriceps weakness or sometimes even paralysis, which is seen in polio. Again, in recurvatum, we have lax capsule, excessive bone loss, large gaps needing large inserts, need of constraint type of implant, and possibility of a neuropathic joint should be always ruled out. And sometimes we need to be aware of any previous HTO or trauma to the knee, which has led to the recurvatum knee. Not to get into the pathophysiology much, how to intraoperatively correct is basic is about under resection of the bone ends with use of thicker components and tightening of the extension gap, which which can prevent the recurvatum. All these techniques rely on the integrity of the retained collateral ligaments. This is very important, which also determines about the need of any higher constraints. Although the posterior plication and the posterior and proximal transfer of collateral ligaments is theoretical, what I believe is about under resection and overstuffing of the joint is the rule. This is another paper which says that the knee that does not hyperextend at the conclusion of the surgery would not develop any recurvatum unless in the patients who have lax muscles. And this is another paper showing in absence of any neuromuscular disease, hyperextension deformities tend not to recur after total knee replacement. So there's another paper which also says that alternative solution is to use a rotating hinge in cases of need of higher constraint. And it is always better to err on the side of fixed flexion deformity while dealing a recurvatum deformity if the neutral alignment cannot be achieved. Well, the message is that the neuromuscular disease, recurvatum, is a neuromuscular disease and great care should be taken, even small degrees of collateral instability. Although the etiology of hyperextension deformity should be evaluated thoroughly before the surgery, the presence of genu recurvatum does not preclude a well-functioning total knee arthroplasty. And definitely that goes to say that genu recurvatum is not a contraindication in total knee arthroplasty. How I do it is first remove everything that is not needed, that is the osteophytes, and then proximal tibial first, posterior releases, and distal femoral cut next, and determine your extension gap first. No matter we're dealing with any kind of a deformity, this is my protocol. First, I determine my extension gap, and then I match that with my flexion gap, and that solves the problem. Take home message, friends. In flexion deformity, it is preserve the tibia, control posterior release, sacrifice the distal femur, and plus or minus use of a larger femoral component may bail you out of the situation. Whereas in the recurvatum deformity, the undercutting and the overstuffing principle really helps. Thank you for your patient listening.
Yeah, thank you, Dr. Pradeep. Excellent presentation. Now, quickly, we'll go to the next topic. We'd like to hear from the master how to get a unicondylar replacement right. Dr. Uday Prakash. Admin, please start the video.
Hi, this is Uday Prakash. Thank you for inviting me to TOSACON 2021. Today, I'm going to talk about unicondylar knee replacement and how to get it right. As you can understand, patient selection is very important, and we're going to be talking about medial unicompartmental knee replacement here. Similarly, it is very important for a patient to choose a surgeon carefully. The surgeon has to be reasonably well experienced in this procedure and should ideally have been brought up in an environment with a culture of performing unicondylar knee replacements. Patient selection is very important. The patient should have anteromedial or medial pain and should be suffering from osteoarthritis and not inflammatory arthritis. The patient should have an intact ACL as well. There should be no medial-lateral subluxation on an AP X-ray. This signifies an absent or a degenerative ACL. The lateral compartment should be well preserved. And if you are in doubt, do a stress X-ray. I personally have very low thresholds for performing unicondylar knee replacements in the elderly and those with significant comorbidity. The patient should have a passively correctable varus deformity, a limited fixed flexion deformity of 10 degrees or less, and should flex to at least 110 degrees. So here we're going to show how to do a unicondylar knee replacement. I normally do Oxford unis and using the latest microplasty instrumentation. The incision is essentially from the supermedial corner of the patella, distally along the medial femoral condyle. You remove any excess fat and reflect periosteum from the anterior part of the medial tibial plateau. Do not release any medial ligament. Check the status of ACL. If the ACL is not intact, then go on to a total knee replacement. Remove the superior and the medial osteophytes carefully using a small osteotome and gentle taps with a mallet. Sometimes you may have to remove the patella osteophytes and the notch osteophytes. Removing the osteophytes helps balance the knee at a later stage. You then move on to sizing the femur and attach this jig to the tibial jig, which is placed pretty much like you do in a total knee replacement. You couple these two jigs using the G-clamp, and this aids in removing just the right amount of the medial tibial plateau. The sagittal tibial cut is made along the medial tibial spine, making sure you point it towards the anterior superior iliac spine. Horizontal cut is done, making sure you protect the medial collateral ligament. The tibial cut is then carefully removed, hopefully in one piece. It can be sized using the opposite tibial trial on its undersurface. At this stage, the flexion gap should be at least 6 millimeters. And you make sure that the trial spacer is thumb tight at least. You then drill the hole for the intramedullary guide, which is placed a centimeter above the attachment of the PCL. Mark the center of the femoral condyle.
Too good.
This device helps in drilling holes in the center of the medial femoral condyle for placement of the anterior tibial cutting jig. While you cut the posterior condyle, protect the medial collateral ligament with a spike or a Homans. You use a 0 millimeter spigot to create, before that, you remove the medial meniscus. Once you've created the flexion gap, measure the flexion gap, which should be at least 3 millimeters. Extension gap is then checked. In this case, even the 1 millimeter spacer was extremely tight in 30 degrees of flexion. So I used a 3 millimeter spigot to create a 3 millimeter extension gap, which matches the 3 millimeter flexion gap. Remove any excess bone. The mill creates a perfect sphere. This jig allows you to remove any posterior osteophytes. And it creates a groove for the twin peg femoral component. You then finish the preparation of the tibia, create a keel slot, and make sure that you do not blow out the posterior cortex. Place the trial components carefully. The trial allows us to check the alignment and stability of the spacer through a full range of movement of the knee. As you can see, this is a team effort to make this operation go smoothly and efficiently. So in this trial, you can see the tibial spacer is stable in a full range of movement. Irrigate the compartment thoroughly and dry it. Cement the tibial component first by compressing some cement into the tibial plateau for good interlocking. Use finger pressure to press down on the tibial component and remove any excess cement. You cement the femoral component. Make sure that you put some cement into the large drill hole. Compress it with your thumb. Remove any excess cement. You then put the trial poly until the cement sets, and then you move on to putting your final spacer. So that's my technique. There's a lot more to say, and we should be able to talk about this in our discussion. Thank you very much for listening.
Yeah, thank you very much, Dr. Day. Really a pleasure to be having you today. May I request the other panel members to be online? Dr. Neelam, Dr. Pradeep, Dr. Ram, and Dr. Day. As we're heading 10-15 minutes late, we'll wrap up with only a few questions. Starting with Dr. Neelam. Are you there?
Hi,
Good morning. Yeah, good morning. Always active and progressive. Your surgical things, are you a PS or a CR? You're a PS surgeon?
I mainly do CR, but
okay.
In difficult cases, I don't have no hesitation to do a PS.
Yeah. In your presentation, you did mention that you sometimes have to release a complete superficial MCL release. Do you do after the medial condyle osteotomy, or you release first and later do osteotomy if it's more tightness?
No, see, once I really take out all the osteophytes and prepare everything, and then find that even after sizing the tibia, still it is tight, then I would not hesitate. I would decide whether to do a pie crusting or a MCL release. If I think the tightness is fairly severe, I would not go with a pie crusting. I would directly go and take out the MCL from the tibia, if it's both tight inflection and extension.
Yeah, Ranawat has popularized especially for the IT band pie casting, but the middle pie casting, of course, you have good numbers, good volume. In your hands is very safe. For the younger surgeons, in the younger surgeons, what do you suggest on table? Doing a pie casting with the needle and suddenly pop up or opening? What is the technique there?
No, see, the journal, some people have used a 11 number blade, but I've never used it. I don't use a laminar spreader also. I put in the implants, keep it in extension, see where it is tight. If it's in flexion tight, I would do the pie crusting in flexion. If it is an extension tight, I would do the pie crusting and extension with the 18 or 20 needle defense. And it doesn't really, with a little pressure, it doesn't really open up too much. 2, 3 needle, 4 needle bites, it doesn't really, two times, thrice it will open up by itself.
Yes.
So the aspect is to hold it in tension, and I find it much better and more easier than doing a release itself.
So you always have a backup, suppose inadvertent release of this tight MCLs, you should have always a backup of constrained implants, isn't it?
I don't think it's happened. It's never happened. It's
Very
not,
good.
You're using a small one, and obviously, what I find difficult is differentiate between the anterior and posterior fibers is certainly difficult in our smaller MCLs, but we have to be careful. Most of the ladies and the men, we can do a back resting and get away with it.
Thank you, Ramna. Very nice presentation. Next, Dr. Ramo Reddy sir, you had a good video or slides you have shown releases. What is your take of sequence of release? Are you go with routine Ranawat or white side, where depending upon the flexion or extension tightness on table you decide?
Yeah, good morning, Dr. Uday. Every patient is different, and I follow what Whiteside has suggested. You have to assess and then decide your sequence of releases always.
Yes.
Now, the main assessment is whether it is flexible or rigid. That is where you start your thinking process and what releases should do. Okay. I always take out the PCL first and then assess, and then required ITP, popliteus, posterolateral corner. That is my standard sequence of events always.
Yes. So how often sometimes you convert your valgus knee into some more constrained? Of course, as you mentioned, your PS man. I think PS should have versatility, more stability. Any conversion, you have shown only one case with already pre-op recurvatum. You went to the hinge. Any other routine valgus? Sometimes you use constraint on this.
If the deformity is more than 20 degrees, one should have the hinge and constraint knee on standby. The PS knee might not be enough.
Okay. Okay, sir. And thank you so much. Very difficult topic and very well illustrated. Yeah, Dr. Pradeep, are you there?
Yes, I'm there. Good morning.
Yeah. We have been disturbing on Sunday for your bike rides. You're available. Thank you so much.
Thank you.
Yeah, only a couple of questions, Pradeep. Because flexion FFD or extension contracture is a very difficult topic, and I know what is your take on extension? Like on table, if you find FFD, do you leave some amount of FFD with on table and come out, or you want to release completely and come out of the operation theater?
It's a very good question, Uday. Which I deliberately didn't include that in the topic because I wanted to talk about it. See, in primary OA, it's very important to get the complete FFD corrected on the table. And when it is inflammatory and inflammatory arthritis, I would probably leave about 5 degrees or less to correct it later. But not, I wouldn't really get the full correction on table. And especially male gender in males and in primary OAs, it is very, very important that we correct the FFD completely on table. There's no scope of post-operative correction. Whereas in inflammatory, we can wait. That's what I mean.
Yeah, because as we know that FFD is not well tolerated by the patient rather than decrease in range of motion. Because FFD, it requires high amount of energy to walk and a lot of pain. One of the paper you mentioned that maybe within 1 year, if the patient has recurrence with with a flexion contracture, what could be the reason? You have released everything on table; it's very good, but post op they come with the FFD. What could be the reason?
The reason says that poor compliance is one. Even if you get full correction on table, and if the patient is not compliant about the post-operative rehabilitation, and that should be a continuous process for at least, that paper says you should be vigilant at least for a couple of years. So if the patient is doing well, I mean, on the table under anesthesia, complete correction doesn't always mean the patient will behave the same way post-operatively. So that's the reason we should be educating the patients about the importance of the recurring deformity if they don't comply well with the physiotherapy.
Yeah. Yeah. Thank you, Pradeep. Very nice presentation. Dr. Day, morning. Can you hear me?
Good morning. Yes.
Yeah. I hope you're at home or you're not driving.
I am driving, but a ball phone.
Oh, okay. Be safe. Be safe. Only a couple of questions.
I think Uday, I think we have got Teslas in our.
All the unicondylar replacement surgeons are on, driving today. Or even the Ramon was Jaganmohan was driving in the morning with the new vehicle. Be safe. I hope you're okay to take a couple of questions.
It's a Tesla.
Sure.
Yeah. The two things is you are an experienced surgeon in a unicondylar, placement of the implants and your alignment, whatever it is there, accurate alignment. The NJR there shows a lot of revisions, merely more than 3.2 compared to our arthroplasties. But when the younger surgeons are coming up with navigation robotics, the learning curve of knee kinematics or assessment, alignment, or the placement of the components, do you think the revision rates will come down?
I think if in my case, and I think many people who do Oxford knees regularly, malalignment is totally acceptable, particularly when it comes to the femur. I think the tibia has to be well aligned. And if you follow the basic principles and set the jig correctly, and with the latest microplasty instrumentation, you're not really far off from being pretty good. Of course, the robotics is the future, and I think definitely time will show us that the implants will last longer if you follow the basic surgical principles and do your arthroplasty well. And but it doesn't really replace learning in a good unit and under good hands. And I definitely feel it's a much more challenging operation to do. And but it's not a difficult operation. It's just you need to be around people who do them regularly, and you pick it up. Registrars do them regularly now, and they're very, very good. So it's just a matter of training, really. I think robotics is the future, and I sincerely hope the results are much better.
Yeah. As you mentioned rightly, in your fellows, compared to fellows working under us, your main arthroplasty units where number of units are more, maybe 20%, 30%, or 50% of your total knees. So what is your percentage of conversion? The person comes for total knee and suddenly you opt for uni.
Percentage of converting a total knee into a uni in the clinic?
Yeah.
So we've done our work, and almost 40 to 45% of my knee arthroplasty is now uni.
Very good.
A bit of a disappointment for the total supplier for us, but I have a very low threshold for doing a uni because the recovery is so much more better and pain is less. You're walking within no time, and the movement is good, and honestly, the proprioception, the overall function is so much better than that.
Very good. One last question. This is the same question I asked to Dr. Jaganmohan. Your extended indications, obesity is not contraindicated now?
Not at all.
Yeah. Okay. What is your cutoff BMI for uni knee? Is there any cutoff?
You've got to be sensible here. You've got to use your clinical judgment. I obviously don't operate on pathologically obese, whether even a TKR, I would be very careful, when I offer this. But we've operated on people who are 120, 130 kilos, but not, I've done a uni in a person who was not particularly well. So we did a TKR on one side and uni on the other side, and 2 years down the line, she's absolutely fine. But rarely, not. You've got to use your clinical judgment.
Thank you so much, Dr. Day, and drive safe and be careful. And
all the best.
All the best. Thank you. And I also thank Dr. Pradeep Reddy, Dr. Uday, Dr. Ramon Reddy, and my friend Dr. Neelam to be safe. And thank you so much in the participation. Thank you.
Thank you.
Take care. Thank you. Take care. Now we're running at least 15 minutes late. We'd like to invite the next session. how not to get it wrong. That is very, very important. Two speakers, two faculties. Dr. Mithinachi is my friend, and Dr. Sharan Patil from Bangalore will be joining us live. Please don't miss these topics because it's a very, very important topics. Both are very, very important upcoming topics. Be careful. And I would like to request admin to start preoperative optimization by Dr. Mithinachi video, please.
Yeah, good morning. I'm Dr. Mithinachi. I thank Dr. Guru Reddy sir and Dr. Kimar Reddy sir for giving me the opportunity to talk on preoperative optimization in total knee replacement. It's very important to preoperatively optimize because our goal is a happy patient. We have to reduce the risk. We have to plan every step, and we have to be prepared for the unexpected because this is an elective procedure. We can't leave anything to chance. These are the various steps I'll go through in detail. History-wise, it's very important to understand what is the complaint, what is the duration and severity of the complaint, whether any presence of night pain is there, which will indicate pain in an advanced joint-related wear and tear. What are the activities of daily living the patient is able to do, any previous surgeries and any complications therein of those surgeries, which will give us an idea of how this patient is going to respond to TKR, and the mental makeup of the patient, because psychological wellness is the most important factor which actually gives us an idea of post-operative result. Examination, obviously we have to know what is the deformity, disability that is there in the patient, what is the gender of the patient, because we've seen that males actually do better to major surgeries when compared to women because of physiology maybe. Any active skin lesions, a dermatologist has to be involved, or else chance of infection is there. Preoperative range of motion is one of the most important factors that I've seen, which can give us an understanding of how the patient is going to respond to a well-done TKR, and also how he's going to have a mental or psychological response to such a major surgery. Vascularity, any patients with diabetes, obviously we have to check for distal peripheral vascular pulses and go ahead accordingly. And any problems in the surrounding joints also can give rise to issues. We know the classification. I tell my registrars, my assistants, that it's always important to operate in stage 3 advanced or stage 4. Anything before, we are actually going to increase the pain of the patient, and the patient is not going to be happy. I tell them that you have a 20% problem, we operate, it becomes 25%. Then the surgery is a failure. But if you have a 80% problem, we operate and it becomes 10%, then the surgery is a success. So staging of the procedure is very important, and staging of the osteoarthritis is very important, and the procedure will give you a better result when you delay the surgery to really required patients. Scoring, we all know about the Knee Society score and the WOMAC score, which can help in predicting our response. Implant selections, there are different implants, right from all poly to gold knee. Every implant is good in the experienced hands which do those implants on a regular basis. However, we have to talk to patient about the expectations they have from the surgery and realistic expectations. I tell patients it's better not Tirumala Konda trekking Kandi. That's what I said. Don't climb up and go. Don't play tennis on a regular basis. It's going to wear and tear fast. And also the financial implications are important. We have to make them understand that there are different joints and different financial requirements, and all of them are good, but it all depends on what the patient wants and from his surgery is something that we also have to counsel him about. Counseling, patients have a lot of expectations. We have to talk about the advantages, possible complications. And I always make sure that my patients go and meet, my preoperative patients go and meet some patient that I've already operated, so that they have a chit chat and they understand what is at store. They might have some misgivings which might be easily solved by a patient that has already undergone the procedure, rather than as a doctor me trying to counsel them. So that has actually worked very well in my career. Medically, important thing to know is about diabetes. 6.7 HbA1c or less is something I prefer. But if it is 6.7 to 8, there's a moderate risk involved post-operative result. Anything above 8, I don't operate. I make sure that they control the sugars and then only go ahead with the surgical process. Obesity more than 40 BMI, I involve the bariatric surgeon. and make the patient undergo bariatric surgery, only go ahead with joint replacement of 6 months. Cardiovascular stenting, obviously drug-eluting stent, I wait for 6 months of dual antiplatelet therapy, and then only go for surgery. Clopidogrel and ecosprin I stop 1 week before. And in patients who have got ECG changes in angina, I always take a DSA. Blood transfusion, I try to keep it at a minimum. I usually do single joints and never do bilateral on a regular basis, so requirement for blood transfusion is less. If patient has got any anemia, I try to address it by giving iron supplements, same too with malnutrition. Alcohol and cigarettes is something that I ask the patients to avoid totally. And any renal related problems, we have to see high incidence. We are actually seeing high incidence and post-operative complications. So I always involve the nephrologist and see that we work in tandem. DVT prophylaxis is important. I always give prophylaxis after surgery, low molecular weight heparin and mechanical compression device. There is an increased risk in patients who have had this problem before, and I keep a watch in those patients on a more regular basis. Anesthesia is always spinal, which is preferred for me. General and local blocks are rare. I always give epidural in staged procedures. Post-op rehab is something that I always communicate to the patients at the time of surgery and preoperatively, which helps us in understanding in mapping the result. So Lord Buddha said happiness comes when our work and words are beneficial to us and to others. So preoperative optimization also works in the same principle. If you follow the protocols, if you take care of all the small things, then definitely you are going to have a happy patient. Thank you so much.
Thank you, Dr. Mithun. Excellent presentation. The future is the results and the complications all depends upon the preoperative optimization. Now, may I invite Dr. Sharan Patil sir, from Bangalore. Just avoiding intraoperative complications during totally arthroplasty tips and tricks. Thank you, sir.
Yeah, thank you. Thank you so much for giving this opportunity to share my thoughts. Obviously, special situations, special circumstances. Is my screen visible?
Yeah, I can see you, sir. Please go ahead.
Is it a full screen or?
No, sir. You have to enlarge your screen.
Yeah.
Just
1 second. Yeah, there it is. Yeah. Right. The topic given to me is intraop complications in TKR, how to avoid them and how to deal with them. It's always nice to define what we mean by this, because it's always good to understand by definition. The Delphi study clearly defined any deviation from the ideal intraoperative course occurring between skin incision to skin closure. So the entire operation itself, we're talking about intraoperative complications. We can broadly divide them into bony, ligamentous, and vascular. And let's talk about the bony problems which we might face in this very commonly performed surgical procedure in most hospitals today. Elderly osteoporotic females who have smaller bones are the most vulnerable ones where we can have this problem. Rheumatoid, of course. And whenever we're using posterior stabilized knee systems, the box can be quite large, especially in small sizes, and that can give us some problem. And if while you're doing your preparation and component positioning, there again, the bone can give away. We'll talk about it in a little bit. So, as you can see, intraoperative fractures in primary knees, the incidence is not absolutely rare. You do get these problems, and one needs to be aware and know how to deal with them. As I said, these are the possibilities, and that's the prevalence is 0.6%. When does this happen? Especially the femur fractures. Let's divide them into what happens on the femoral side and the tibial side. You're doing improper trialing. If you're not able to fit your trials in proper position and put unusual stresses on the bone, which is osteoporotic, there you can go wrong. If the box placement, if you're doing a constraint, if you're doing a posterior stabilized knee and you have not placed your jig properly, if it is slightly lateralized or something like that, and you're doing the box cut, you can go very close to the edge of the cortex and you can cause a damage. Like I said before, a large box cut in some designs, especially in smaller sizes, can be a problem. Notching, in my view, notching in the proper sense of notching, in the sense when you almost get into the medullary canal, that's when you get into problems. As long as you skim the surface, and even if you have taken off a part of the cortex, is not so bad. But notching is definitely not to be done, and if notching happens, then that's also a potential area to fracture. Medial lateral mismatch, when most of the systems do not allow different configurations. So when you have a very anteroposterior diameter of the distal femur is less than the side to side, then you end up putting an implant which is covering only a small part of it, and there is a lot of bone beyond the implant, which has always got the potential to crack and fracture. On the tibial side, in my own personal experience, even though the literature doesn't say this much, we do a lot of reduction osteotomies to fit the tibial component, and we are doing that. You're doing a reduction osteotomy, and if you're using an osteotome on a sclerosed bone, when you're trying to knock that off, you can pretty much crack the tibia in the middle. So one needs to be careful about it. And I always use a saw. It does that kind of damage much less. Overstuffing the tibial side with the cement. And if you're over jealously hammering in your zeal to impact the whole thing going in, and there again, you can bust the tibia. Some examples, this is one patient in whom I clearly remember we did use all the jigs, and then we found part of that was sclerotic, and we could not place the wings deep inside and had to use an osteotome to make it better. When you're doing that, you're likely to crack, and this one cracked anteroposteriorly. That had to use a screw end of it. It was okay, but that's a potential problem. So don't use excessive force, don't use osteotomes inappropriately, and the best way to do it, use it with power instruments. That will always help you. And that was how it was, and that is the crack I had. This is another one. When you have a valgus knee, or when you have a very tight reduction, you've done your complete release and you have a tight reduction. As you can see in this case, trying to maneuver and close it, you can get pretty much a crack on the medial side. The bone has got such thin cortices, when it cracks up, invariably you'll have to support with your fixation. And that was the defect which was covered, and then we had to fix that. So multiple options available when you have a problem like this, and one needs to be judicious. Fundamental principles remain the same. You need to get very good interface between the implant and the bone, and you need to have a good stable platform for the implants to be put in. And to achieve that final objective, you have to use the armamentarium within your means to do that. To summarize, exposing the joint adequately is very important, and correct mediolateral placement of the trial and final implants. What I do is I always use a CR knee to see where my femoral component is placed and mark it, and then use a PS one to cut the box. So that gives me perfect centralization and does not place the jig in the wrong place to cause the fracture. Trialing, of course, has to be gentle, and one needs to be careful, especially in osteoporotic bone. Coming to the ligaments, MCL, of course, is the most dreaded one. Patellar tendon avulsion can happen. Popliteus injury, not even if it happens, it's not such a disaster, but one needs to be careful not to do it. Intraop MCL injuries, iatrogenic injuries usually occur due to avulsion from the tibial insertion or direct transaction at the level of the tibial osteotomy. These are the two major areas. That's what the studies show. So one needs to, there are three situations: a bony avulsion of MCL from the femoral side. I won't talk about it. It's similar to having a fracture and you fix it back. Mid-substance tear of the MCL is the one which is really the one to avoid, and how to avoid it. And this is a real major disaster, because most of the time we do not have backup implants, constraints to deal with it. So one needs to be extremely careful and paranoid about MCL and protect it while you're operating. Of course, soft tissue detachments, usually tibial side, heal conservatively as long as you immobilize them for a certain length of time post-operatively. These are the areas when you can do the damage to the MCL, and the best way is to protect it. And you can protect it by using your bone levers, retractors. When you're sawing, your bone lever is protecting you. And if you have well-rehearsed assistants, that will do a world of good. That is the other time when you're using the 4-in-1 jig and doing the posterior condylar cuts. That's again, you can sway outside, especially if you're using the more modern ones where there's no lateral constraint on these jigs. You can go right across if you're just a little careless. So when you have a mid-substance tear, that's what we are talking about, is a difficult situation. And obviously, this is not every time possible, but if the ends are reasonably in good shape, then a primary repair augmented with some kind of a augmentation with either a hamstring or whatever your skill sets are with a modified Kessler stitch. And sometimes even downsizing the insert can help you to relax this whole repair. And they are one of the ways. Using more constrained implants, of course, is possible, provided you have them on the shelf. And doing that in a combination is one of the ways of bailing yourself out in difficult situations. But this is more easily said than done unless you are a center where all these are available off the shelf. To summarize, excise the medial tenting osteophytes before subluxing the tibia, and that will help you to stay clear. Protect the MCL, like I said many times, with your retractors, and saw it carefully. Don't be afraid to take a little time on this. Go 2 times to complete the cut, but don't rush it. Patellar tendon rupture, this is something which can happen only when there's an extremely stiff knee. If there's a stiff knee, anticipate the problem and do a quadriceps snip. This is the simplest thing to do. It doesn't change anything post-operatively. So you can always stitch it back and have a normal post-op. If it is even worse, a tibial tubercle osteotomy is an option. But one simple rule when you're doing revisions especially is to keep the foot externally rotated throughout the procedure so that the patellar tendon is kept away and so that you don't damage it. In case you damage it, we are in big trouble, but end-to-end repair and keeping it protected for a very length of time will give you reasonably good results. Vascular injury. That's where it is. You can see it in the picture how close it is. So one needs to be really careful through the procedure. Avoid jealous retraction. Posterior clearance has to be reasonable, but don't go overboard. And always try to be as close to the periosteum as possible. And if you breach it in your tibia or anywhere else, one needs to go extra careful. And when you're subluxing the tibia, these are the maneuvers where you can really, especially if it's atherosclerotic, you can do the damage. What happens is sometimes it causes thrombus and laceration, which post-operatively you'll discover something is wrong. You have to know whether it's arterial or venous and see how you can identify and quickly treat them. But one last thing I would like to say is in case of vascular damage, vascular repair is not always necessary. Of course, you panic. Of course, you have the vascular people around. Quite often there are sufficient collaterals to perfuse the leg. So any vascular damage does not equal to a vascular surgeon doing a vascular repair. One needs to assess the perfusion of the leg and take it carefully. And if they have got vascular surgeon on hand, they will be of great help. And in a multi-specialty hospital, that's easily possible. Thank you again for this opportunity to talk to all of you. Thank you.
Thank you, sir. It was an excellent presentation, and we are always happy to be with you, sir, and learn a lot of things. Yeah, we have only 5 or 10 minutes of discussion, sir. Dr. Miten, good morning. How are you?
Morning, Uday. Good morning. I'm fine. How are you?
Yeah, good. Yeah, see, our day starts with preoperative optimization because in Indian scenario, we operate knee replacement as an emergency procedures. So when the patient comes here, immediately we take them, next day we post them. That has to be changed. Would you accept that one?
Yeah, definitely. So because this is the most important part of the connect with the patient that we have. Pardon me, but I wanted to share one of the incidents I had when I was a registrar with Guru Reddy sir. And he used to be very surprised. He used to tell me, why are you participating more in the OPD? Why don't you go and participate in the operation theater? And I used to tell him, sir, 90% of your success is how you deal with your pre-operative assessment, how you take care of your patients. And so that is very, very important. The youngsters have to learn that TCAR is not an emergency surgery. You have to really follow up the patient. You have to understand what is the type of patient that we are trying to go ahead with this joint replacement. And this is going to, because we are all decent surgeons, it's not like extremely experts and all that. We are all decent surgeons, but how we deal with the patient, how we know what is the type of patient that we are approaching is very important.
Yeah, your presentation shows like all the factors, risk factors like diabetes or cellulitis, whatever it has to be optimized. What about the preoperative counseling of the patient for exercise, knee ROM or quadricep strengthening, so that post-op it will be easy for that? Do you involve in your optimization program, or only you will see the risk factors to optimize?
Usually, obviously, we know a good quadriceps ensures a good result. So we have a physiotherapy team who actually take part. We have a knee clinic, and we have the physiotherapy team that follows up the patient. They assess the strength of the quadriceps and the flexion extension. And once they are happy with the result, before surgery, we again take a call and then we go ahead. Preoperative physiotherapy is very, very important. Unless and until the patient is extremely confident and has got a good ROM, I always involve the physiotherapist.
Yeah, good. Lastly, because what happens is the 90-day readmissions, what we call as the 90-day readmissions, initial papers are showing very high. If you don't optimize, like a patient with diabetes, your cutoff is around 6.5 to 7. And high risk for 90-day admission is 2 reasons. One is your DVT, and other is any cardiac related. That should be keep in mind and purely optimized. So for younger surgeons, you should always be careful for doing early discharge of the patient. You should be careful to optimize the patient properly and assess. Okay. Thank you, Mithun. Just one more question. Yeah, one more question, Dr. Sharan Patil, sir. We have been always happy to be with you, sir. We are all ROC faculty, and you have honestly shown that your complications. What about your on table? Suppose some BMI is about 30, 35. Do you evert the patella or not while doing a TKR? Sometimes what happens is if you're not able to do it, the complication, whatever you're placing the tibial implant, it's very difficult to place the implant. What is your take on that?
Now, in general, I don't evert the patella all through my routine surgeries. It's extremely rare that I'll have to evert the patella. If one is doing that, you have to be obviously careful and do enough releases before you do that. And if you do that, I don't find the need to do that most of the time if you get your dissection right. But if you have to do that, it's not just the first time when you are flexing and extending, but every time you are flexing and extending and everting, one needs to be cautious about it. And like I said, keeping the foot externally rotated through the procedure for me is the biggest take home, because when you do that, you're keeping the patella clear and you're exposing the whole tibial plateau quite nicely. Yeah.
Yeah, that is Ransel maneuver, sir. Ransel maneuver. Are you saying Ransel maneuver? The sometimes very rarely, sometimes we notch the femurs. Are you worried about the extent of notching, or
Yeah, certainly. I mean, like I said, for me, having a good patellofemoral tension is important. I'm always more towards the side of notching. We did present a big paper on that. We have not had any major complications with grade 1 and even up to grade 2 notching. Only when you are almost breaching the cortex and you start seeing the medullary canal juice coming out from there, that's when you really get worried. And it's not easy to change into the stem extension at that stage because you've done all your cuts. It becomes a little difficult. But in general, I'm quite okay to notch the lateral side quite comfortably, lateral part of the femur. But I would like that less patellofemoral tension rather than overstuffing the patellofemoral joint.
Yeah, good. One final question to you, sir. Like you mentioned a valid point for the younger arthroplasty surgeons, like patient with a long-standing cellulitis or who has been treated with the DVT. Post-op, sometimes we may overlook. Pre-op, we may not feel the pulses, but post-op also, after the surgery, we don't feel the pulses because of the good collaterals.
Yeah.
So there's nothing to be worried of. That's what your point of valid. Like post-op, immediately there's no need to rush to the vascular intervention because the collaterals are well established.
Absolutely. No, I can't emphasize on that enough because as orthopedic surgeons, we hate the sight of
vascular intervention,
vascular bleeding and intervention. So one don't have to panic to that level. The older the patient, the less the need to do a vascular intervention because there are collaterals nicely established. If you control the bleeding through your joint, and also there's some very interesting work being done on trying to do revascularization, even if vascular intervention is done through the anterior side itself. Put a laminar spreader. The picture I showed you is one of them where you take a little extra cuts, but of course within the limit of your implants, accommodating that so that you can expose the vessel from the front itself and do it. Because especially if they're obese, especially if you get into a situation where you have to make them prone and then expose and do it, invariably post-operatively they do very poorly. Firstly, all of them don't need it. There is a possibility that we can do it from the front if your vascular surgeon is well versed with the technique. So those two things be kept in mind.
Yeah, thank you, sir. Thank you for valuable input. And one question from the faculty itself, from Dr. Pradeep Reddy to Mithin. Dr. Pradeep, can you go ahead with your question?
Yeah, hi. Can you hear me with this?
Yeah, I can hear you.
Yeah, it's actually not a question. I really appreciate the way Mithin has portrayed the importance of the pre-op optimization. Especially for the juniors, what advice I give is we need to, the physician, the anesthetist, and the cardiologist, the PAC kind of things is well taken care of. That is the medical side. But here it is very imperative for an orthopedic surgeon or a joint replacement surgeon to play a role of a psychiatrist or a psychologist. So the mental fitness is what we need to gauge in the preoperative time. If you feel that you are trying to force the surgery or the patient is being forced into the surgery, I think that is where we need to have a red flag that this patient is not a good candidate for surgery.
Yes. Yeah. Thank you, Dr. Pradeep. Anything you want to add, sir? Dr. Patel, sir?
No. It was a nice talk. I think Guru already wanted Mithin to be in the OT because he didn't want to learn the tricks of the trade. And Guru already needs to reach 10,000 joints soon. So Mithin, you're competing with him, huh?
God's grace.
Thank you so much, both of you, and really happy to be the part of the TOSA program. And I'm transferring the to revision topics. Dr. Suhas will take over. Good morning, Suhas.
Good morning, sir.
Yeah, good morning.
You can hear me well?
Yeah. You can hear me well. Yeah. You can go ahead with the topics.
Sure. I'm Dr. Suhas Maslamani from Sunshine Hospital. Right now, I'm filling in for Dr. Guru Reddy, who couldn't be here to moderate the session because of a commitment he had made overseas. So without any further ado, because we're already late by half an hour, we'll get on with our talk. The next session is getting it right in revision knee arthroplasty. We have three speakers in this. To start off with, deciding the level of constraint in revision TK by Dr. Kushal Hippalgaonkar from Sunshine Hospital. I request the admin to play the video, please.
From Sunshine Hospitals. I'll be talking about deciding level of constraint in revision. From Sunshine Hospitals. I'll be talking about deciding level of constraint in revision TK. This is the overview. First, we'll talk about definition of constraint, then instability post TK and the need for using constraints, type of constraint implants, treatment options for instability post TK, deciding the level, and then case scenarios to close. Constraint is the effect of elements of the knee implant design that provide the stability needed in the presence of a deficient soft tissue envelope. Instability may be the result of a generalized soft tissue laxity, inadequate flexion extension gap balancing, improper component position or alignment, ligamentous insufficiency. Now, to address this, we have implants of varying degree of constraint, from low constraint to a high constraint. As the amount of constraint is increased, stress transmitted to the modular implant host surface also increases. Now, these heightened stresses may result in increased backside polywear and result in early implant loosening and ultimately failure. Therefore, the most important statement of this talk is it is recommended to use the least amount of implant constraint necessary to achieve a satisfactory result. Now, an overview of the types of constraint implants. You have the lowest, that is PCL retaining, then PCL substituting, and then varus valgus constraint implants or the linked hinge. This is the nice picture showing a least constraint to highest constraint. These two are your CR with the lipped here, and then anterior stabilized, getting a more curve anteriorly. posterior stabilized having the tibial post, and then the varus valgus constrained with a thicker post. Now, the CR, the PCL retaining, that's the CR, it's the minimally constrained, and it depends on the intact PCL to limit posterior translation of the tibia. You have PCL substituting, which may either be posterior stabilized, having a post and cam, or anterior stabilized, that is the deep dish or ultra congruent designs, where it's the highly conforming tibial inserts are used to increase the stability. The varus valgus constrained implants have a tall tibial post and a deep femoral box. They provide more inherent coronal plane stability than PS. So there's no axle connecting the tibial and femoral components. Therefore, it's an unlinked. The TC3 and Zimmer LCCK next gen are examples. This is the principal difference between a PS and a VVC. Here in the PS, you can see there is no engagement of the post to the box, so it doesn't contribute to mediolateral stability. While in the VVC, there is a complete engagement here, so helping in mediolateral stability. Finally, you have the linked hinge, and we're going to talk about the modular rotating because the fixed hinges are no more in vogue. Highly constrained devices, the tibial and femoral components are linked with an axle, this one. Now, to decrease the overall amount of constraint, these components permit rotation of the tibial bearing around the yoke on the tibial platform. So what are our options to address instability post-TK? The first one is the simplest, isolated poly exchange, not used very often, but still has its indications. So proper alignment and stable fixation of both components is the prerequisite. When do you use it? When you have instability in flexion and extension, you can just put a thicker poly and get away with it. Then if you have a PCL insufficiency in a PCL retaining knee, then you can just put a deep dish poly and get away. Then you can either also do a single component revision where you still need a proper alignment and stable fixation of the other modular component. So the indications here are PCL insufficiency in PCL retaining knee. So the femur is revised to a PS design, isolated MCL incompetence where the femoral component is revised to a VVC implant, or early isolated either femoral or tibial loosening also. Now full component revisions where in prerequisite is that collaterals are not completely disrupted. So the indications are malaligned or unstable components and inadequate constraint options in existing implant. Finally, you're hinged. The indications are completely disrupted collaterals, severe bone loss, severe flexion extension gap mismatch. Now, how do you decide this level of constraint in revisions? You have your PCL retaining. Now, this is a paper from SICOT. PCL retaining, where you need intact ligaments and a type 1 AORI defects. It's rarely used, as I said in the previous slide. PCL substituting ones, again, the intact ligaments are needed for this and a type 1 defects only. The varus valgus constraint are used if the ligaments are insufficient, so not completely disrupted, but insufficient in type 2 defects, and hinged, where either even if the ligaments are absent, you can still go ahead and use it. So some case scenarios, this is a 1 year post TK. You can see the loosening here on the tibial side. What was done was intra-op assessment. You can see that the PCL here is intact and the femur is stable and the bone loss is not much. It's a type 1 bone loss. So a single component revision was done with ultra congruent poly, this one. So the femur was not revised. This is a 70-year-old male, 4 years post-op. You can see the loosening on the femoral side and the tibial side also. So intra-op, what was our finding? We could notice that the MCL is present, but it's an insufficient MCL and bone loss is moderate, that is type 2A bone loss. We could get a stability with a varus valgus constrained implant. The next is a 69-year-old female for which TKA was done, and then 6 months post-op, there was a fall at home. Now looking at this picture, is our MCLs insufficient or completely disrupted? We don't exactly know. You can see the grade 2-3 opening on the valgus strain. So what was our intra finding? We had our armamentarium of things ready. The instability persisted with the TC3. You can see the gap here. It's a valgus force being given. You can see the gap here. And this then was converted to a hinged prosthesis where now that gap has closed, the medial gap has closed and stability was achieved with a hinge. This is the post-op X-ray of the same patient. This is just to show a primary, even in a primary setting. Now with this level of a opening on the medial side and a severe hyperextension, 40 to 50 degrees hyperextension, we had all our implants ready. Right from your PS to VVC to hinge, everything was ready, but just have a look with minimal cuts and a size 10 poly. This is just a PS implant in there. There was no need of a varus valgus constraint, no need of any hinge. We really thought pre-op that this may require a hinge, but it didn't. It was stable in extension, and even in flexion, there was a good stability that was achieved. So the point being that this is the post-op. The final decision regarding level of constraint is definitely intra-op. Pre-op will give you an indication, but it's the intra-op stability that needs to be assessed before deciding the level. Thank you.
Dr. Kushal, thank you so much for your talk and driving home the point that the least amount of constraint which can give you stability is the one that you should choose. The next talk is by Dr. Akhil Dadi. He could not be here today, but he was gracious enough to send us his talk. The talk is Restoring Joint Line and Achieving Balance in a Revision Total Knee Arthroplasty. I request the admin to start playing the video, please.
Sir. Hello, everybody. Thank you, Dr. Guruvadi sir and TOSACON for giving me this opportunity. So, joint line restoration in the primary and revision. It's very obvious that joint line, let us first take its definition, which is a tangent composed of a straight line connecting the most distal points of the medial and lateral femoral condyles. There's another definition of anatomic joint line, which has as the line of the meniscus, but we'll not deal with that. So a change in joint line definitely affects your balancing. If there is an elevation of joint line, when your distal cut of the femur is higher, your MCL will be unstable in extension and tight in flexion. And the opposite, when you are lowering your joint line, the ligaments would be tighter in extension, whereas they'll be unstable in flexion. And all throughout the range of movement, the superficial MCL, which behaves as an isometric ligament. So if the joint line goes up or down, it affects even this isometric ligament and is major reason for a mid-flexion instability. So this is one of the figures where the joint line is, what happens when the joint line is elevated. So in mid-flexion, it becomes lax and there is instability. Now, so once the joint line is elevated, you will have an elevation of up to 10 mm has been seen to increase forces of body weight during stair climbing by 60% and 30% while normal walking. So that's a huge pressure on the joint. There's a reduced joint range of motion. There's a mid-flexion instability. There's a quadriceps weakness, patellar tendon impingement, and accelerated wear and early failure due to the same. So obviously, this knee is not going to do well. So how are we going to ensure that and determine where the joint line is, and how do we ensure that you get the correct balancing, the correct knee replacement done? So of the numerous instead of taking too many landmarks and doing too many calculations, there's one adductor tubercle ratio method, which is a very simple thing to restore your joint line, where the width of the femur is taken, and exactly half of this, if you take from the adductor tubercle, half of this is what represents the joint line. It is so easy to do, and every time you can keep replicating it. So this is one of the methods where from the adductor tubercle, it is half of this femoral width. So this femoral width was 6 centimeters or 8 centimeters. You took from the adductor tubercle 4 centimeters to get to the joint line. This is an extension. Similarly, in flexion, you want to get the posterior condylar offside right. you would take from the same femoral width from the medial epicondyle 34% of your femoral width, or from the lateral epicondyle 29% to restore the posterior condylar offset, or get the joint line inflection right, in other words. Another way of getting the joint line is that you take from the tibial tube, you take the anteroposterior tibial dimension, and half of it from the tibial tubercle is also where you can construct your joint line. Fine. So obviously, once we know where the joint line has to be, we would know what augments and how do you fill those defects in the revision and use of augments. For example, here in this case, we saw that the femoral width was 6, and we got from the adductor tubercle down to 3 centimeters, we got the joint line, and we built it with femoral augments, and on the tibial side also we built it with an augment. We built it with femoral augments, and on the tibial side we built augments. So we wanted to get the joint line here 3 centimeters from the adductor tubercle, 3 centimeters from the adductor tubercle, which is half the femoral width of 6 centimeters. So summarizing, joint line elevation of above 8 mm has always been associated with unfavorable results. Most of the results are good if it is within 4 mm of joint line elevation or depression. And in order to measure where the joint line is, you have to use the adductor tubercle ratio and the tibial tubercle ratio. For extension and inflection, you can use the ratios with the medial epicondyle and the lateral epicondyle. Thank you very much.
I thank Dr. Akildari for his talk. Let us move on to the next topic, which is periprosthetic fractures around the knee and its management. The talk is by Dr. Sai Lakshman from KIMS. Can the admin play the video, please?
Very good morning. Today I'm going to talk about periprosthetic fractures around the knee joint. In fact, they form the third most commonest cause for revisions. I'm Dr. Sai Lakshman. I work at KIMS Hospital, Kondapur. I thank Dr. Guruvar Reddy sir for giving me this opportunity. Periprosthetic fractures are defined as fractures of the femur and tibia within 15 centimeters from the joint line, or if there's an intramedullary rod, about 5 centimeters from tip of the intramedullary rod, and in presence of a TKR, if there is a patellar fracture, whether resurfaced or unresurfaced. If you look at the literature, supracondylar fractures are the commonest periprosthetic fractures. There can be many factors which lead to the fractures, usually high trauma, high level of activity, age more than 70 years, osteoporosis. These are the usual causes for periprosthetic fractures. The treatment complication rates of periprosthetic fracture are as high as 41%, and about 29% of these treated fractures need to be revised. So going on to the supracondylar fractures. Supracondylar fractures are classified by Rohrabeck and Taylor. It's one of the simplest classification. It can be usually combined with OTA classification to get an algorithm for treatment. In type 1, simple displacement, less than 5 millimeters of displacement, less than 5 degrees of angulation. We usually, though it can be managed conservatively, try to fix it so that the patient can be mobilized early. Non-operative treatment, they go on to heal well, but there will be some amount of mobilization, immobility, and complication in elderly patients. So the ideal is to fix them so that you can mobilize them and at least partial weight bearing immediately. In type 2, the stable implants are stable, but the fracture fragments are displaced. Then you have the option of an internal fixation with either in a closed reduction or in an open reduction form with plates and nails. This is an example where a nail has been used to fix the type 2 fracture. Retrograde nailing, the length of the nail has to be adequate to cross the isthmus so that you get a better grip. The distal locking has to be performed first, and then you remove the jig. And once you extend the knee and then do the proximal locking so that the rotation of the femur is optimized. So this is an example where a retrograde nailing has been done. And coming to plate and screws, usually if you can get about 8 cortices in metaphyseal and iliofascial area, it should be good. But if that is not possible, then you can combine with the combination of circulage wires, cables, or interfragmentary screws. Monoaxial plate provides you high primary stability, but if there is an intramedullary stem, probably a polyaxial plate would be more helpful. This is an example where periprosthetic fracture has happened at the tip of the intramedullary stem. So this reduction has been achieved and held with two circlage wires, but we still put a plate as a neutralizing device so that they can start putting weight immediately. Another example where a LIS technique with fluoroscopy has been used. This has got successful outcomes. Another example of plate and screws. In type 3, there is a fracture of the supracondylar area where the implant is loose. If you are able to achieve a stable fixation of the stem in the center of the femur, probably you should be revising it. Or if you cannot do that, you can sacrifice the distal femur and do an endoprosthetic replacement. This is an example where revision has been done for type 3 fracture. Another example where distal femur has been shattered, so we had to do an endoprosthetic replacement. And then in cases of failed fixation also, we have to go for endoprosthetic replacement of the distal femur. So algorithm, if you look at the processes, if it is loose, then you have no other option but to replace it by doing a revision DKR. But if the process is well fixed, and then you look at it, if it is a minimally displaced, probably you can think of a conservative treatment. But also all sorts of conservative treatment nowadays are being pushed towards operative treatment, so that we can mobilize them by at least by partial weighting immediately. And of course, in substantial bone fragment displacement, you have no other option but to operate them. If the bone stock is good, you can choose one of the techniques described, either by a plate or a nail. And in case the bone stock is poor, or osteoporosis, or a very low fracture, probably you should be looking at an endoprosthetic replacement or a revision TKR. And now going on to the tibial side. On the tibial side, Felix has classified the tibial fractures into 4 types. Type 1 is partial fracture of the head. Type 2 is the entire head is fractured. Type 3 is below the implant. And type 4, where isolated tibial tuberosity is fractured. And all of them can be combined with a suffix like stable process, loose process, and an intraoperative fracture. So this is an example of periprosthetic fracture of the tibia, where the TKR is quite stable. So we went on and did a plating of the fracture, and it went to heal well, and patient is doing well. Tibial fractures are classified into intraoperative and postoperative. If they are recognized intraoperative and the fracture is stable, then you do a protected weight bearing. If it is unstable, probably you do an internal fixation. In the postoperative period, there we look at where the implants are. If the implant is well fixed and TKR is not moved, then probably you should be either looking at open reduction or a cast and brace. If the implant is loose, there is no other option but to go and fix it. Coming to the patellar fractures, very prosthetic. Because of the lack of time, I'm directly moving to the algorithm treatment for that. It is divided into 3 types. The type 1 is stable implant with intact extensor mechanism. Type 2 is disrupted extensor mechanism with a loose or stable implant. And type 3 is a loose implant with intact extensor mechanism. In type 1, the treatment is, of course, non-operative. In type 2, it has to be operated at any cost, and you have to repair the extensor mechanism. And based on the condition of the patella, you can do either complete patellectomy or do an internal fixation. In type 3, if the bone stock is good, you revise the patellar component, or if it is not possible, you do a resection arthroplasty. In type 3B, and when there is, of course, poor bone quality, the removal of the patella is mandatory, and you do a total patellectomy and repair the quadriceps mechanism. Thank you.
Thank you, Dr. Sai Lakshman, for that wonderful talk. Dr. Lakshman and Dr. Kushal can come online. A few questions. To start with, Dr. Sai Lakshman, sir, you very well laid out when to fix and when to replace in case of a periprosthetic fracture. But looking at the patient dynamics, body habitus of the patient, do you resist the temptation of not trying to do a distal femur replacement in some patients in order to make them walk quicker and rehabilitate them earlier?
Yeah, we have to take it on a case-to-case basis. Am I audible, Dr. Suhas?
Yes, yes.
We have to take this on a case-to-case basis. If the patient is very morbid, and then if you're looking at a very stable fracture, and then after 2 to 3 days fixing the fracture, and if you have any problem, or if the patient has a bilateral sort of fractures in a car crash, in a car crash. So in these sort of fractures where you think that keeping them bedridden for a couple of months is going to lead to complications, probably there I would like to do a periprosthetic fracture managed with a replacement and start them going up and about. But majority of the times, if you get a good fixation in a one-sided knee, if the bone stock is good, probably you should allow them partial weight bearing.
Great. So another question that I had was, when you're doing a primary, we do certain times do realize that they might be prone for periprosthetic fractures, and we have a very low threshold of putting a stem on the tibial side. But I want to ask you on the femoral side, do you have a low threshold for even that? Because most surgeons would stem the tibia, but very few stem the femur.
Based on the implants you choose as well. If you're already using some kind of company which doesn't provide you with the extension stem for the femurs in a primary scenario, so probably those are the surgeons who wouldn't think of it. But in an osteoporotic patient, osteoporosis is there on either side of the joint. Ideal to be putting rods on both the sides.
Because most fractures usually on the femoral side, and very few surgeons stem it. And we always stem the tibia, probably because of which the incidence is less.
Yes. The stemming should be done in very sclerotic bone on the tibia where you don't get a primary purchase.
Yes.
And the second other option is probably a very morbidly obese patient.
Yes.
But if you're thinking of osteoporosis, it has to be stemmed on both.
Yeah, so our indications right now are anybody who's obese and more than 35 BMI. We usually use a short stubby stem, fully cemented. And then the other indication is when they are osteoporotic and the implant can sink. So we've moved away from long stems to short stubby stems which are fully cemented, which tend to survive better than long stems. Thank you so much, sir. Dr. Kushal, you can hear me?
Yes, Dr. Suhas.
Yeah, great talk. One question more for the younger surgeons who begin. Whenever you're doing a revision, the constant question you have in mind is what should be the level of constraint. So based on the classifications, of course, there are laid out criteria, but between ligament integrity versus bone loss, which is your go-to pick in terms of deciding the level of constraint?
So both of them affect the decision making, but definitely if you have to pick one, it is the ligament strength that is going to guide your constraint selection. The bone, yes, they both go hand in glove, because imagine a type 2B or a type 3 defect on the medial tibial side. Your part of your MCL will also get compromised. Part of the medial soft tissue envelope will also get compromised. So if you just reconstruct that medial defect, it's not that you have re-established the soft tissue envelope on the medial side. So for that reason, the classification that I mentioned, that they have combined the two. It's not a strict, you don't have to adhere to it strictly, but it's a broad algorithm which helps in decision making.
Yeah, that's where the confusion comes, because there's mention of both the ligament integrity as well as bone loss.
Correct.
But the best way to understand is bone loss you can make up.
Correct.
By putting screws, or you can use a bone graft, and you can use an augment, so many ways.
Yes.
But ligament tension is something that you cannot recreate. And
Absolutely.
the level of constraint has to be decided based on what ligaments are telling you to draw. Yeah, thank you so much, Dr. Kushal and Dr. Sai Lakshmi, for your time.
Thank you.
Let's move on to the next session. Dr. KJ Reddy, sir, is online.
Video playing or?
Yeah, good morning.
Great. Good morning, Dr. KJ Reddy, sir.
I think I've sent you the...
Yes, sir. It's great pleasure to have you online. And let us go on to his talk, which is recent advances in prosthetic joint infection.
Yeah.
Can the video be played?
Yeah, yeah, sure. So there's a disturbance. Is it from my computer or your computer, or everyone is getting disturbance?
Right now, I'm unable to hear anything, so it's pretty clear.
Clear,
no disturbance.
No problem. Go on, you can play.
Admin team, can you start playing the video, please?
Shall we go to the next video? Dr.
Yes.
Kiran Kirani.
No, it is Dr. KJ Reddy, recent advances in PGI.
Sir, we didn't have Dr. KG Reddy's video.
Okay, I'll do it. I'll just play it from my screen. Not a problem.
You want me to play? I think I have on my computer.
We'll
Otherwise, I can talk.
We'll just let them sort it out, sir. I think apologies from our side.
No problem.
This is my girl.
I think that's a good talks. I was listening now to a couple of talks. I think excellent discussion also good.
Yeah. Sir, meanwhile, they load the talk. You have a special place for prostate joint infection and its management. Can you just let us know how this interest developed and how it has evolved over the years?
Yeah. Just coming up. I think what happens is every surgeon's nightmare is infection, and we should, I think, we should able to treat infections when we do the operations. I think video is coming.
Yes.
So it's important because I've done a lot of these things when I came back from the UK, and we published about 10 years ago. Okay, go on.
Yeah, great. Let's start the video, please. We cannot hear any audio. Edmund, let us do this. Let us move on to Dr. Krishnakaran's talk while you sort out Dr. KJ Reddy's video so that we can make up for some time. Great. So sir is going to talk about 10 commandments.
This is the correct person to talk about 10 commandments of how to build a successful arthroplasty practice for the young arthroplasty surgeon. However, let me make a try. How can you define success? Is it more numbers, better quality surgery? And what about balance in life? Orthopedics is not the only part of our life. It is only a part of our life. So we must not forget this when we are trying to build our arthroplasty practice. Why arthroplasty? We all know that knee replacement is a relatively common operation, and we do have a significant proportion of orthopedic patients who do come with a hip ailment needing a replacement. And less often we have requirement for a shoulder, elbow, or an ankle arthroplasty. Although trauma is the mainstay of practice, 40% of practice is arthroplasty. It is lucrative and there are increasing numbers in the world. If you look at registry data from ISHKS, from 66,500 joint replacements in 2014, today we have nearly 1 lakh joint replacements which have been documented. And I'm sure there will be much more cases being performed but not documented in our country. Now, you can have subspecialization in knee, hip, other joints, or you can do all arthroplasty together. Primary arthroplasty is now a fairly common surgery. It's not a subspecialty anymore. And the first commandment is training. So it has been shown very clearly that fellowship trained surgeons have got good outcomes as compared to the non-fellowship trained surgeons. At least a year of fellowship following your completion of residency is where you should look to begin. And that is the minimum training which is needed for you to start your arthroplasty practice. Where is the optimum place to train? A high volume center where there is supervised hands-on training like Sunshine Hospital is probably a very good place to train. And there are other institutes which offer fellowship programs, although may not be hands-on, but if there is a larger volume and speciality which is catering to arthroplasty, these significantly improve the quality of surgical training. And there are multiple studies to support this. How do we start practice? Is it a standalone practice or is it a group practice? And are we subspecializing in something, UKR, revision, reverse shoulder, or are we doing technology-assisted joint replacement surgery? For young surgeons just starting, please stick to standard indications, practice evidence-based medicine, choose your implant from the ODEP rating, which is available online free of cost, and don't do any implant which is presented to you. Do implants which have got a good track record, good success rates, otherwise you'll be in for trouble. And it's also not a good idea to keep changing multiple implants. Visualize where you want to be in 15 years, set strong goals and develop an action plan. Choose an appropriate location to begin your practice. Know how you will fit into the practice and community, and rely on a support network. It's not an overnight thing. It's a 30, 40-year plan, so it must be built on strong foundation. It is important to hone your skills constantly. Learn to make good clinical decisions. Mirror the best qualities of your mentor. Don't be afraid to ask questions. Work within solid indications. Refer complex cases to more experienced surgeons or involve them in the decision-making and treatment. And always exercise humility. When we set up our office and clinical setup, we must have a good secretary who is willing to take the calls and be responsive to the patient's requirements with respect to setting up the appointments, scheduling their admission, discharge process, everything. We must have a good patient counselor to allow the patient to understand and know what to expect during the hospitalization. We must have good ancillary staff who are courteous, efficient, and knowledgeable, like the physiotherapist. And we must have a good hospital billing system which is transparent and ethical in order to be able to set up some sort of confidence in the patient that these people will take care of me. Never make the patient wait for long periods of time. Be very courteous and good to them, and take care of your general surroundings. And it is always important to keep the patient's interest on the highest pedestal and priority. How do we build a patient base? We must be available, make ourselves known, have relationship with referring physicians, and provide outstanding patient care. Patients will come from various sources, but the most important source is patient-to-patient referral. The old patient who has become well will send you at least 10 to 15 patients in the coming years. Although networking, marketing, advertising, social media, and referral physicians constitute some sort of a referral base, it is eventually the patient who's been happy who will send you more patients. For building practice, attend CMEs, clinics, develop a solid referral base, and get contacts within the credit organizations who can refer you some patients in the starting part of your career. Incorporate novel practices which are evidence-based and proven to improve the patient outcomes, like surgical approaches, use of computer-assisted or robotic surgery, and make efforts to manage the pain well so that there is fast-track recovery. So that is how the patients must be smiling and be able to do good quality post-op rehab. And this is a patient with post-surgery who's able to walk immediately. Incorporate new technologies. Patients have good experience and good functional outcome. As numbers increase, you must be able to manage your outpatients, inpatients, and surgeries better. Be transparent when you're managing complications, recognize the problem early, and be the first one to communicate this to the patient. Seek help if needed to manage the problem. Also, data document and research and giving back to the orthopedic community through publishing of your work, conducting CMEs, training younger colleagues is important, and this helps you leave a legacy. Thank you.
Needless to say, it was a great talk by Dr. Krishna Kiran. There are only two people I can envision giving this talk to us. One is Dr. Krishna Kiran and the second is Dr. Guruva Reddy. Thank you, sir, for your pearls of wisdom for our young surgeons. Hopefully, we are ready with Dr. KJ Reddy's talk.
Yes, sir, we are ready, sir. I'm just starting. Yes, sir.
We still haven't got the audio yet. So would you like to go on live and present your talk?
That's great. Share screen.
Let's see, probably we're third time lucky.
Welcome to TOSACON 2021.
Great.
I must congratulate Dr. Thimareddy and his team for excellent meeting, and also thank him for giving PJI in orthoplasty, which is a dreaded complication of any orthoplasty surgeon. About 600,000 joints are done in US every year, and about 27,000 revisions are done for PJI. This is in 2013. So it's a big burden on the healthcare system. Long time back, Sir John Chonley predicted sepsis would be a big problem in orthoplasty. And you can see the revision for infections is going up as the number of primaries are going up. And it's a big burden, costing about more than $1 billion. And the biggest problem is methicillin resistant organism. The biggest challenges would be to treat this methicillin resistant Staphylococcus aureus. And it's also associated with high morbidity. As you can see, they can lose the leg and could be sometimes disabling. And it is compared with some of the cancers. That means some of the cancer prognosis better than PJI. I had opportunity to share the dais on several occasions with a great man, Parveji. He has written a lot of articles on periprosthetic joint infection, its prevention, management, and everybody should read some of his articles, especially his book on PJI. And the difficult problem is there's no absolute test for diagnosis, no standard definition or criteria for PJI, but he formulated with collaboration of the team across the world. The culture is a gold standard. The advantages being it's inexpensive. Results can be used for further testing. The biggest disadvantage is polymicrobial polymicrobial results. Time limitations are there. False positives can come. False negatives can be there because of the biofilms or prior antibiotic treatment, and some organisms are difficult to isolate. And one of the other biggest problem is intracellular Staph aureus in the periprosthetic tissue, which would be difficult to isolate. This is a new algorithm for the management of PJI. It's complicated, but I'll go through in a simple manner. So the new definition is, if a sinus tract communicating with the processes, it's infection. If two positive cultures are isolated from the same joint, or any of the four following criteria out of 6 are positive, then you are dealing with infection. The criteria are increased ESR-CRP, synovial leukocyte count increase, purulence in the affected joint, positive culture of periprosthetic tissue or fluid, more than 5 neutrophils per high power field. Now it is the era of biomarkers, and there's a lot of research going on molecular diagnosis of periprosthetic joint infection. And strip tests are available to identify the leukocyte esterase, which will diagnose PJI. So many molecular markers have been isolated, but still They are in experimental and expensive and only available in a few centers. Human neutrophil protein also a marker for identification of PGI. So molecular identification of pathogens is the future. Presently, it has got a limited role. There are tests like a microbe detector, rapid detect test, like a patch test, which will detect diagnosis in a very short time. The biggest problem would be dealing with culture negative joints, where you are not able to isolate the organism. The successful treatment of any periprosthetic joint infection is isolation of the organism. New antibiotics have been tried, which are target sensors similar to cancer therapy, and they are attached to the receptors like cancer drugs. Biofilm disruption technology have been employed. Vancomycin tethered implants have been used to prevent the infection. Pre-op cultures is important how you do it. Stop antibiotics for 7 to 10 days. Joint aspiration, preferably joint synovial biopsy, where you can take the tissues and send it for culture. If intra-op diagnosis is something like this, gross pus, draining sinus, and you can do frozen sections, send for intra-op cultures. And it's very, very important. You must select 5 sites: suprapatellar pouch, medial, lateral, tibial side, femoral side, and posterior aspect of the joint, like this. Otherwise, difficult to isolate the organism. And send cultures for anaerobic, aerobic, fungal, mycobacterium, and most important thing is, do not leave the sample in the OT. Send it immediately. Send them immediately. In our series about 41 cases, we used 6 weeks of antibiotics before second stage. TB was isolated. In some cases, especially atypical mycobacteria. Candida was isolated. Staph epidermis is the most common organism. And the results were similar to most of the studies. Some examples: the 60-year-old lady, 1 year post-op, pain and stiffness, raised ESR CRP, X-rays like this. There is a significant periarticular erosion. When you open up the joint, you can see there's not a lot of pus, but there's a significant bone destruction. And the material we got was like this. And after debridement, there's significant loss of bone. As you can see, interdistal femur is damaged. So it was treated with 2-stage revision. As you can see, these are articulated handmade cement spacer, where you can get some degree of range of movements. That's X-ray. And to my surprise, Candida was isolated from this joint. And this is a post-op. After 6 weeks of treatment with the antifungal, planned for second stage surgery, you can see healthy tissues, and of course sent for culture again, and joint was replaced. This is the X-ray. As you can see, augments were used, stems were used for the bone loss, and we published fungal infection in IJOA 2013. That's the clinical picture. You can see good range of movements. Another case where 59-year-old, 2 months post-op, you can see pus pouring out once opened up, lot of necrotic tissue. You can see. And underneath the implant, and you must understand, there is no way you can save this joint, and no point in trying repeated debridements for this kind of infection. And also, it would be difficult to do a single stage revision for this kind of cases. You can see pus everywhere. So 2 months later, ESR CRP reduced to normal, and it's revised to revision implants. So there are cases where you can do single stage exchange. Recently, I started doing it, where you know the organisms and their sensitivity, and you know the appropriate antibiotics, which are not very toxic, and you can use antibiotic loaded cement, non-immunocompromised patients. Soft tissue should be healthy. There should not be significant bone loss. You must use IV antibiotics minimum of 5 to 7 days, and 6 weeks of antibiotics should be used. Sometimes may be continued up to 3 months. In a single stage revision, you must remove all the implants, redrape and new instruments. So you must understand single stage revision is 2 operations under same anesthesia. So you do the first operation, come out and de-scrub, de-drape the patient and redrape again and use a new set of instruments along with all the team who are scrubbed up again. So processes, consider antibiotic loaded cement with local antibiotics, and is about 90% success rate. If you have selected right patients, there is no significant difference about eradication, whether you do single stage or 2 stage. The take home message is prevention is the best way. Patient selection is important. Introp, care, theater discipline in a primary joint replacement surgery. You must use appropriate antibiotics prophylactically. Early diagnosis, as we keep saying, infection is like pregnancy. Yes or no. There's nothing in between. You can do debridement and retention of the implants in some cases where you can diagnose early, especially immediate post-op. And implant should be well fixed. You can retain partially, or you can do a single stage in a selective circumstances, as I mentioned earlier, but you should know the organism, which is very important. 2 stage, you have an opportunity for to see the response for the antibiotics, and you also have the time to plan any bony reconstruction, especially in complex cases. The important message is, if you cannot isolate the organism, you cannot do single stage. You must do 2 stage revision. So it is important to prevent and treat PJI effectively. Otherwise, morbidity, mortality is very high. Thank you very much for your patient listening.
Yeah, thank you, Dr. KJ Reddy, sir, for that wonderful talk. You've covered everything right from diagnosis to management. I do want to acknowledge that we've also at Sunshine started doing single stage revisions, and our experience is less than 10 cases, but it has been quite fruitful. So in terms of distinct advantage, 2 stage versus single stage, where do you see us scoring over 2 stage revision?
Can you repeat what do you want? Single stage, the role of single stage, you mean to say?
The advantages of doing a single stage revision over a 2 stage revision.
Yeah, if it's done properly, if patient selection is correct, there is no difference. The results are the same, provided you have the patient criteria. As I said, the antibiotic sensitivity should be known, and you should meet the patient should be fit, and you should follow all the protocols for a single stage.
Yeah.
Single stage is nothing but doing 2 operations same time. So it is the same time. Majority of the centers, because what happens is 2 stage is expensive. In between, morbidity will be there. That's why most of the people in Europe and America started doing single stage. Last year, I think Parvezi, when I met him, most of the cases were suitable. I mean, wounds pouring pus cannot be done. The cases which I've shown cannot be done. But the basic thing is patient should be fit, organism should be known, and patient should be fit. And you can do single stage. I think that's a way future. Probably you can do single stage. We've done. We started doing it. Now our series is about more than 90 cases. Probably may be able to publish single stage sometime in future.
Yeah, we've done close to 10 cases with very good results. And point well taken that you decrease the morbidity for the patient in doing both at the same time. I do want to ask you about one particular aspect of PGI treatment, which is the literature has plethora of recommendations. The duration of antibiotics after the second stage. You hear everything from 2 weeks to long-term suppression with antibiotics. What is your take on that?
Yeah, I think that it's very clear. There is no confusion. When you're doing second stage, it's like a primary. So you follow the protocol like primary. Do not extend more than 48 hours. When you're doing a second stage, that means you're doing a clean operation. In a 2-stage revision, the second stage is like a primary. So do not extend for 1 week, 2 weeks. That means you're treating infection. Your second stage, you're only giving prophylactic antibiotics.
So do you take
so I think the message, you should read that because I appreciate Parvezi very much. He's written the preventive measures, especially to stage 1. I think there is extensive work. Previously in the past, even I used to give antibiotics for 2 weeks following second stage, but stopped doing it because it is like a primary. And you believe that everything is cured during this 6 weeks or 2 months period. So you should treat it as a primary. No point in extending antibiotics.
Do you take samples again and send them for
cultures? Yeah, routinely we take it, but very unlikely they come positive. If you're doubtful, I think whenever you open, what happens sometimes you may not be complete and the organism may be resistant. So when you go in second time, you see, assess clinical assessment. If you're suspicious, I do second debridement and close it. Do not replace it. 1% of doubt, I do not do it. But what happens is with the current, what happens is with single stage, you can treat it as a single stage revision for the second if you suspect infection. But send it for microbiology, microscopy, involve your microbiologist and infection team. I think, should be treated effectively.
Great. We do have Dr. Praharsha, who's my colleague from Sunshine, who has.
Hi, Praharsha, you're doing a great job.
Thank you.
You're after me for recorded this one. I
Sorry,
almost missed it.
Yeah, no,
Great work.
thanks a lot, sir.
And
Thanks a lot.
Aravind as well. I think great work. I think we need people like you. We are almost retired. Me and Guru are almost retired. So they're putting people like you in the front line.
Sir,
That's
if
what
I
I
could,
told Guru. I think we should not be on the podium. We should be in the back seat from now on. That's what we were doing it.
No, but experience before anything, sir. So if I could just add a point on what we just discussed, I think very, very valid point which you had put forth about duration of antibiotics. Like you said, what Parvezi and the international consensus meeting, they all concluded that prolonged antibiotic use after the second stage is not required. But what I've been noticing in recent publications, even in the Bone and Joint Journal from Craig Delavalle and his team, they had said prolonged use of oral antibiotics after the second stage, up to even 2 months, they found that the revision or re-revision rate for a recurrent infection is actually reduced. But like you said, these are all very sporadic reports. And
now,
they're not...
scientific evidence says second stage, if you're doing a 2-stage, you have to treat like a primary.
Correct.
If you are doubtful, you extend antibiotics. You see, single stage, sometimes you extend up to 3 months, provided there is no toxicity. But if 2-stage, where second stage is clean, there is no scientific evidence to extend antibiotics more than 2 doses, 3 doses. It's like a clean operation. And there's no confusion. You should not pass on the message that some incident, but there is no confusion about the antibiotic prophylaxis. First, for a primary, do not give more than 2 to 3 doses. Second is uninfected primary knee replacement, a joint replacement. Because that is what happened. I see majority of the patients coming back, they are treated 2 weeks, 3 weeks. Antibiotics for primary replacement, which is unethical. So we should stop that practice. We are treating ourselves, not the patients. And the second stage also, I think convinced very much, and there's a good evidence that when you treat as a clean joint for second stage revision, do not extend antibiotics. There's no point. You're treating yourself, not the patient.
Because a very astonishing thing which I had come across just in the last one day, actually, when we were just generally looking at social media, because ACUS is very active on social media. They had actually put out a poll about dental infections and how long would you want to do an antibiotic prophylaxis. And there are actually a good number of US surgeons who are saying they would even prefer to do a lifetime prophylaxis, and some of them saying they'll give antibiotics for as long as 2 years, which is ridiculously aggressive. To manage.
That is only suppressive. If you cannot cure, cannot cure the infection, if you're doubtful, probably can suppressive therapy. That can be.
I think one area where there is no consensus is what antibiotics to give and how. Dr. Prasha, can you enlighten us between stage 1 and stage 2 when you don't know the organism? what kind of antibiotics are you giving? And can you tell us which antibiotics have good bone penetration? Because I see a lot of surgeons might do a stage 1 and then send the patient to a higher center.
So very important, because the use of empirical antibiotics will eventually determine how good our bacterial yield is even in the future cultures that we do. So a lot of misconceptions are there about how you define a broad spectrum antibiotic and using a very broad spectrum antibiotic to try to avoid an infection or to treat an infection. So I think broad spectrum antibiotics are those which cover both gram positive, gram negative, and to some extent something like an anaerobe. But there are few which fall in this category. Third generation, fourth generation cephalosporins are one option, IV to be used. So in our experience, we have found that 2 weeks of IV use of these third, fourth generation cephalosporins, following an oral equivalent after that for 4 weeks, usually does a good job. A class of antibiotics which are less discussed but which are very, very effective in treating infections from a broad spectrum point of view are tetracyclines. So something like doxycycline, which probably is just a oral medication which does not need to be having multiple doses, just 100 milligrams twice a day. It actually covers against even the atypical organisms which are not covered by cephalosporins or penicillin group. So tetracyclines like doxycycline or minocycline can be considered. And the third aspect is those infections which are very virulent, where you have a lot of pus in the joint, which seems to be like an acute inflammation or an infection. It's ideal to hit them with something like a carbapenem group, which may include meropenem, etc., which again cover for both gram positive and negative, but more for gram negative organisms.
Yeah, I think that's very good, sir. But Praharsh always involve microbiologists and know your hospital environment, which is sensitive.
We closely work with Dr. Yaldandi, who is an infectious disease specialist.
Yeah,
and then every case we do refer to him.
I just want to share 28th August, there is a consensus meeting. I think we're being with the American Academy, AOS, and Indian surgeons, both in joints and trauma. Last 6 months, we are having a repeated series of meetings, consensus of opinion and prophylactic antibiotics. And the treatment. There will be a book, consensus of opinion book, very soon. 20th August, there's a webinar on that. So probably some of you can log on and get
Thank you,
information.
Dr. KJ Reddy and Dr. Praharsha, for such a fruitful discussion. Now let's move on to the last session of arthroplasty, which is on a hot topic right now, robotics in total knee arthroplasty and UKA. We have the good fortune of having Dr. Sean Toomey with us, who is based in Seattle, Washington. He has a wealth of experience in robotics, and he's been operating for the past 21 years. He's a thought leader and one of the early adopters of the Mako robot way back in 2010-11 when they started doing UKR. He's one of the first surgeons to have done a Mako TKR in the region of Seattle. His association with Sunshine has been great. He's been our proctor, our trainer. We've had a lot of brainstorming sessions with him regarding various research topics. Dr. Toomey, are you online? Great. Your audio is a little off. Can you try to reconnect? If we're having trouble hearing you. Probably you could re-log in.
Or use an earphone, sir.
Okay. So can we start the video of Dr. Toomey?
Let us sort out Dr. Toomey's audio. Meanwhile, let us have the talk on navigation versus robotic by Dr. Adarsh Reddy. Dr. Toomey, one recommendation is to use headphones if you can.
Okay, can you hear me now?
Oh, great. I can hear you now.
Okay.
Yeah. Dr. Toomey, we apologize for all the confusion. He had to literally scamper across the city to come and join this live. We are eternally grateful for your commitment and for your enthusiasm in addressing this today. So we can probably right away go to Dr. Sean Toomey's talk on robotics in knee arthroplasty. Has it arrived?
Thanks for including me. It's my pleasure to be with you today.
Thank you so much, sir. Let us play Dr. Sean Toomey's video. Can't help but admire your library behind you, Dr. Sean Toomey.
Oh, thank you. I apologize. I wasn't able to get the correct screen on because I thought this was 12 hours later, but anyways, thank you. I read them all, believe it or not.
Admin team, are we ready with the video?
Yeah, we're just starting to play that now.
Great.
Yeah, well, they're queuing it up. Some people thought it was like
from
a
Seattle,
screensaver.
Washington.
Oh, here we
I'm
go.
honored to present to TOSACON on the topic of adoption of robotics and joint replacement. Thank you all in advance for your time and attention today, and a special thank.
Yeah, minimize the screen so that we can see. Probably they'll try to redo that again. Dr. Toomey, I think we are in a very early stage in terms of adoption of robotics here in India. And then our own experience has been great. And a large part of it is because of the mentorship and the help we've had from surgeons like you. So I would like to formally thank you for that. Can we play the video now?
Good morning. I'm
While
Dr.
they're
Sean
queuing it
Toomey
up.
from Seattle,
Yeah.
Washington, and I'm honored to present to TOSACON on the topic of adoption of robotics and joint replacement. Thank you all in advance for your time and attention today, and a special thanks to the meeting organizers and the other surgeon faculty. When we look back, there have been several technologies introduced to the market to assist with the preoperative planning and intraoperative execution of hip and knee replacement. These products have ranged from X-ray planning templates and universal knee instrument sets to more sophisticated technologies such as optical navigation. More recently, orthopedic device manufacturers have invested in the development of robotic-assisted joint replacement surgery. In fact, robotics started to have a presence in the world of orthopedics as far back as the early 1990s. One of the first platforms released for clinical use was a RoboDoc platform, which was designed to plan and prepare the bone for hip replacement. From that point forward, several orthopedic device manufacturers have released products to assist with spine and joint replacement procedures. However, if we focus on the robotic platforms that have made significant impacts on joint replacement patients, the story becomes a bit more straightforward, and it's clear that it's centered to some extent around the Mako platform. In addition to focusing on robotic applications that can solve relevant clinical issues, it is also critical to recognize that it is not all about the robotic platform. There are many other elements that are needed to create a successful robotics intervention into our industry. It's important that the platform and its applications are evidence-based, which requires significant investments in clinical research. It also is important that the implant systems that are matched to this need to be clinically successful. Us surgeons in our surgical teams need to have the appropriate clinical support to unlock the full potential of robotic technologies. And we'll need a means of measuring the impact of these robotic programs, having metrics like OR efficiencies and local patient outcomes. Last but not least, we need to be able to provide an opportunity to collaborate on the education of potential patients and future surgeons. So together, this recipe was applied first by Mako Surgical Corporation and then by Stryker to introduce and support the adoption of several Mako applications over the last 15 plus years, starting with the Mako partial knee application in 2006, followed by the hip application in 2010, and the total knee system in 2017. Let's take a closer look at the adoption of the Mako platform over this same time period. The linear line represents the total number of Mako systems worldwide. And the bars below that are color-coded illustrate the number of procedures performed utilizing each of the Mako applications. Some key milestones to highlight include in 2013, just over 10,000 procedures were performed using the partial knee system. Stryker acquired Mako in December of 2013. From there, you can see that Mako realized accelerated growth driven in no small part by the launch of the total knee application. Today, there are over 1,200 Mako systems in 30 countries around the world. At the same time, other major orthopedic device manufacturers have been entering the market with their own robotics platforms, many of these of which you are very familiar with. But some may ask, what is the difference between the different platforms? First, let's talk about how the surgeon interacts with the technology and then how the technology interacts with the patient. You can see the autonomous system represented on the left, where a pre-programmed plan is then executed by a robotic platform under close surgeon supervision. Compared to the telesurgical systems, such as the Da Vinci robot, where the surgeon is in complete control of the motions of the machine in a remote command station. Then there's the collaborative robotics, which allow both the surgeon and robot to simultaneously control motions. It's also important to acknowledge or recognize how the systems recognize the patient's anatomy, including landmarks and boundaries that are critical to plan and execute the procedure. There are two main methods used by robotics platforms on the market today: image-based and image-less. Image-based relies on the patient's anatomy, critical landmarks, and planning parameters are entered into the robotic system using a form of advanced imaging, such as CT. The imageless, the software relies on points and landmarks collected during the procedure via bone registration process. The software then creates a three-dimensional model to estimate the patient's anatomy for intraoperative planning to locate the cutting guide and/or guide bone preparation. It's important to note that the Mako system utilizes the three-dimensional CT-based planning to create a unique plan for each individual patient. That same CT data then helps to develop boundaries utilized by the Mako's haptics for safe and effective and accurate bone cuts. These key features together enable the patient outcomes reported in over 200 clinical publications associated with this technology, demonstrating clinical value in the form of better patient outcomes for each of the three applications. We've seen this across the partial knee, total hip, and total knee as well, which we've spoken to in the past. It goes further to see that this body of evidence supporting improvements in patient outcomes validates Mako CT-based applications and AccuStop haptic bone preparation. In addition to the growth of the global install base, the volume of Mako procedures and clinical publications we just talked about, the Mako technology is further validated by its presence in teaching institutes around the world, not just in the United States that are represented on this slide here, but also in Australia and in Europe. So it's just remember, this is just the beginning for robotics and orthopedics. It's just the beginning. This statement applies in many ways to the adoption, improved outcomes, and future applications that are forthcoming. And the continued adoption of robotic technology will enable future innovation in joint replacement surgery, using a combination of image analytics, additive manufacturing, robotics, and digital ecosystems. And in this fashion, I'd like to conclude that robotics and joint replacement is here to stay. Thank you very much for your time and attention.
Thank you, Dr. Toomey, for such a wonderful, enlightening talk. We do request you to stay back for 2 more talks so that we can have a discussion regarding the robotic session. Thank you so much. Next, we have Dr. Adarsh Anapareddy, who will talk to us about navigation versus robotic. This is a very natural question. A lot of surgeons ask us, how do you differentiate navigation from robotics? So it's a very relevant talk. And I would just request the admin team to play the video. Navigation versus robotic, Dr. Adarsh Anapareddy.
Hello, sir. Can we go to the next video?
Yes, yes. Dr. Adarsh Anapareddy, navigation versus robotics.
Hi, I'm Dr. Adarsh Anapareddy. I'd like to thank TOSACON for this opportunity of speaking today. Today I'll be speaking on navigation versus robotics, which is better. So what's the agenda? What I want to try to get across in this talk is the robot actually worth every penny? You have to remember that cost and worth are relative terms. Price and value are completely different. The true debate actually is whether robotics is truly a step above navigation, as the robotic surgeons are claiming today. Right? So first I want to get out of the way that not all robotic systems are the same. Literature of one cannot be extrapolated to the other. So I will be speaking specifically about the Stryker Mako robot, not about the Zimmer Rosa or the Navio robot. I'm speaking about the Mako robot, and all the literature I show today is regarding the Stryker Mako robot. Just quickly, a brief glimpse of the Stryker Mako versus other robotic systems. The Mako robot has a robotic arm. It's the only robot with FDA clearance for partial knee, and total hip replacement. It's the only system which has a 3D CT scan and creates a 3D virtual model. It's the only one which has a haptic control with a robotic arm. And it achieves ABC, that is accurate alignment, perfect balance, and 100% precise bone cuts. So which steps of the robot differs from navigation? Now, this is a brief workflow of the robotic system, the Mako robotic system. The pre-op planning, the OR setup, then goes to array placement, patient landmarks and bone registration. Then we go for intraoperative adjustments and ligament balancing, then bone dissection, finally a trial reduction, and a final bone preparation. Now, if you take all these 8 steps, these 4 are completely unique to the Mako robot, and these 4 are in common with the navigation. So that is the pre-op planning, OR setup, intra-op adjustments and ligament balancing, and the bone resection. These are all completely unique for the Mako robot as compared to the navigation. Right. So where is robotics superior to navigation? So as I said, the Mako total knee is completely divided into 3 main segments. That is enhanced planning, dynamic joint balancing, and the robotic arm assisted bone preparation. And all 3 core features show superiority over the navigation. I'll be starting off with the enhanced planning part. So enhanced planning, with any computer assisted surgery, we need to teach the system where are the anatomical bony landmarks like the hip center and the medial and lateral malleoli. And then we need to do bone registration. This information comes from the image-based or imageless, depending on which system you have. Image-based basically relies on the CT scan, MRI, or fluoroscopy, and imageless relies on the intraoperative input by the surgeon. The Mako, which I'm talking about today, is a CT image-based robot. So what are the advantages with the enhanced planning? There are 3-fold advantages. One is 3D CT gives us an image base. Basically, it gives us accuracy of bone registration and the landmarks. It helps us to understand the pathology, location of osteophytes, any bone defects, metaphyseal cysts, etc., and also the quality of the bone. Pre-planning, it helps in giving accurate sizing, accurate implant positioning, and for the first time ever, we can actually match the femur and also get the sagittal planning with the posterior condylar offset. Others, we can also have a well-defined haptic boundary, which is done beforehand itself. And this is taken from big data from lakhs of CT scans all over the world. In the navigation, the surgeon has to physically locate these landmarks on the patient's anatomy, and it is prone to error, which is well documented in literature as compared to the CT-based, which I have on the left. These are multiple papers which are showing that there are registration errors in imageless navigation. And Dr. Martin Roche's paper is very well quoted in literature. Next, the bone registration part. In the robot, the system already has a true 3D CT scan of the patient. So we just have to validate 40 points on the femur and on the tibia, and we have a very high accuracy of less than 0.5 millimeters. But when you go to navigation, you have to do the surface mapping of the bone, and it's approximation software. You're not actually locating exactly what has been, because there's no input preoperatively. And this creates inadequate access to the posterior aspect, because you have to actually try to get to the back of the femur as well. You don't need to do that in imaged CT scan based robots. Next, if you compare the Mako versus the Navio versus mechanical TKR, the accuracy of the sizing of the implants, if you see the green line, it's very nicely, very accurate. This is the Mako. The Navio is slightly less accurate, it's all over the place. And of course, the mechanical is all over the place. So the femur and tibia sizing is definitely inaccurate compared to the robot. Next, in the enhanced planning is better understanding of the pathology, the location of the osteophytes, and the bone defects. As you know beforehand, before we go into the case itself, this particular ghastly X-ray, we can know beforehand where are the posterior osteophytes, where are the huge defects, whether I need to use any augments, any extensions, or any bone grafts. We know all this stuff beforehand itself. Next, we can go for shape matching in the femur. You can match the trochlear groove over here. You can match the posterior condylar offset. You can check for the mediolateral fit and the transepicondylar axis rotation. And the sagittal plane, we know the slope of the tibia beforehand and the flexion of the femoral compound, how much it has to be. And we get the overall combined flexion as well. 3 plus 3, you get 6 degrees. This is all done beforehand. Next, as I said, both components can be moved in 6 degrees of freedom. Okay, in the coronal plane, the axial plane, and the sagittal plane, you can move it in 6 degrees of freedom. We can adjust our implants according to what we need. This is all before incision itself. What about the disadvantages, you may ask, like radiation from the CT scan and the cost of the CT scan? Well, if you see all the papers, they have found that the radiation is up to 2.7 MSV, which is less than even a CT chest. And about cost, it's just a few thousand more. When the patient is willing to shell out on a robotic or a navigation, he's definitely going to be okay with spending a few thousand on a CT scan. Next, on the overall scheme of things, we go to the dynamic joint balancing part. Now, this is a very, very important part of robotics, especially the Mako robot. What we do is we stress the joint in extension as well as in flexion, if you can see over here. And we get the extension and flexion gaps. In laterally, you have extension 20 mm and in flexion 19 mm. Medially, you have 17 mm and 16 mm gaps. We can titrate the position of the implants in order to balance these gaps. And basically, this gives rise to functional alignment. So we have to, we see all the literature between mechanical versus functional versus kinematic. And we have to choose, if you want to go for functional, we can titrate our implant positioning. Just to give you a brief example, this particular case, if you see the gaps, extension laterally 20, medial 17, flexion gaps were 19 and 16. We do a little bit of titration here. We pin the tibia laterally and give 1 degree of varus and see how it has changed over here. From 2017, 19, 16, it's become 2018, 2018, just by giving 1 degree on the varus, on the tibia. Then what I can do is pin it medially and give another degree of varus. Now my boxes come even closer, 19, 18, 19, 18. Finally, you just anchor the laterally on the femur and give another degree of varus. You are 19, 19, 19, 18. Even that 1 mm of 18 can also be changed by anchoring on the femur and giving an external rotation 1 degree, and you have now all 19 gaps. So from 2017, 19, 16, we've come to 19, 19, 19, 19, just by giving 2 degrees varus on the tibia, 1 degree varus on the femur, and 1 degree external rotation on the femur. Now, if you talk about navigation, the most commonly used one is the brain nav one. Each cutting block has to be physically placed by the surgeon in the position he desires. The challenge is to achieve optimum position 3-dimensionally. A manual saw is still being used, and only after the cuts we can verify if they made according to the plan or not. This depends on the dexterity and experience of the surgeon. So this is simple adjustment preoperatively, and here in the navigation you're actually having to put everything manually, and it depends on the surgeon's experience. Finally, the robotic arm assisted bone preparation is the main differentiating factor. The robotic arm comes with a haptic feedback, okay, and you have auditory and visual feedback as well. And if you can see, while operating, while sawing, it's not going to allow us to go outside the predetermined haptic boundaries. So the soft tissues outside the haptic field are protected, and you have sub-millimeter cut precision. Recuts are very, very easy in case we really need to do it. This is definitely not there in navigation. This is the most striking difference between the two. Okay. Other reasons why robotics is superior: unicondylar for AMOA. We know that unicondylar is a better option for AMOA, and it has much more accuracy with robotics. ACL preserving surgeries like medial unicondylar, lateral unicondylar, bicompartmental, and patellofemoral arthritis arthroplasty. Of course, total hip replacement, which I've given another talk. The cup placement and the spinopelvic relationship can be definitely better met. Of course, as I said, you can have any of the few medial, lateral, patellofemoral, or even bicompartmental arthroplasty. And robotic hip arthroplasty tells you the cup placement and even tells you the sizing of your stem. Literature, just briefly run through the literature. It shows that robotics has reduced post-op pain, better range of motion, reduced post-op analgesia. And this paper by Faris Haddad shows the MASTI score, where there's a reduced bone and periarteric plus soft tissue injury, leading to reduced pain in robotic surgery. 1 year patient outcomes show wonderful WOMAC scores and pain scores. If you go for robotic versus computer-assisted navigation, robotic TKR showed less operating time, better alignment, and less hospitalization. Navigation versus conventional, if you try to conventional versus navigation, they show that no difference in clinical outcomes and survivorship. So if you want to summarize, navigation is just a planning tool, just like a map. You're on your own. It does not tell you where if you're going in the wrong direction, and you only know after reaching the destination if you're right or wrong. But robotic is planning plus execution tool. The GPS with a turn-by-turn, and it tells you the speed, the weather, it prompts whether to make a turn, next petrol station. You're reaching the target is definitely certain. So it gives you accuracy as well as consistency. Thank you.
Yeah, really thank Dr. Adarsh for such a great talk, trying to differentiate robotic versus navigation. The last talk for this session is being given by me, and this talk is based on a lot of discussion that we've had between surgeons from India as well as abroad about the utility of robotics in gross deformities. And we were placed in a much better position in order to see whether this technology is worthwhile and has utility in robotics, especially with reference to gross deformities. So I request them to play the next video, Robotic TK in Severe Varus Deformities by Dr. Suhas Maslamani. Good morning, everyone. I'm Dr. A.B. Suhas Maslamani, Program Director, Division of Robotic Joint Replacement at Sunshine Hospital. And today I'm going to discuss about robotic TK and gross deformities of the knee. In many of our forum discussions, the question on everybody's mind is, does robotic help in gross deformities of the knee, which we so commonly see in Indian setting? If you look at the journey of Mako at Sunshine Hospital, we launched on February 1st, 2020. And in the first 3 months, we were able to finish more than 200 surgeries, which was a global benchmark and officially acknowledged by Stryker. Fast forward to August 2021, we've done over 800 of these surgeries. And if you look at our degree of coronal plane deformity, 60% of our patients have a coronal deformity of more than 10 degrees, and 15% of our patients have a deformity of more than 20 degrees. This set the stage for us to test this technology in these gross deformities and establish its utility. If you look at the Mako workflow, the core features can be divided into 3: enhanced planning, dynamic joint balancing, and robotic arm-assisted bone preparation. Case in point is a 63-year-old male with bilateral osteoarthritis varus deformity. If you look at the knee, there is not much deformity on the X-ray, but if you look at the clinical picture, there's significant amount of varus. Enhanced planning is a process where 3D reconstruction of the knee is done, and the implants are superimposed on this 3D model, and tibial size, femoral size can be accurately measured. But with particular reference to gross deformities, you will be able to see the amount of uncoverage of bone. You will know the quality of the bone you're working with, the presence of these cysts, occult fractures, and more importantly, the location and the size of the osteophytes, which are so important in these gross deformity corrections. The aim of dynamic joint balancing, which is the second feature, is pre-balancing the knee. Pre-balancing the knee is nothing but the ability to move the implant position to achieve balance before the definitive bone cuts are made. There are two workflows presently described to achieve pre-balance, the pre-resection workflow and the mid-resection workflow. In pre-resection workflow, here you can see that in extension and flexion, the gaps of this patient are 23, 20, 24, 20. The target for us is to achieve 18 mm gaps so that it can fit a 9 mm poly. Now I'm going to play this video and show you how easy it is to pre-balance a knee like this. 2 degrees varus in the tibia and 2 degrees varus in the femur will convert the 2320 gap to 2020. And similarly, once this is done, the knee is flexed and 2 degrees of external rotation is given on the femoral side so that the lateral gap is closed. Once all gaps have come down to 20, the tibia is raised by 2 mm so that the gap it comes down to 18 mm, and this gives us a 9 mm thickness poly, and all the cuts are made simultaneously. Unfortunately, not all knees are so easy to balance, so we move on to mid-resection workflow where pre-balance is achieved after 2 cuts, the distal femur as well as the proximal tibia. Once these cuts are made, you get access to the posterior side of the tibia so that you can do some releases in order to balance the extension gap. So here you're not simultaneously balancing the gap, the extension gap is balanced first. Once this is done, the knee is flexed, the same steps are repeated so that flexion gap is balanced to extension gap. To summarize, in robotic TKA, you have the ability to plan, assess the gaps, dynamically balance that gap, and then move on to bone cuts. As contrast to a manual TKA where you're forced to make the cuts first, after which the gap is assessed, and then you do soft tissue releases in order to balance the knee. Mid-resection workflow did not achieve pre-balance in all our patients. In gross deformities, it was very obvious that the posterior osteophytes and the tight posterior capsule on the femoral side were the guilty structures, but at this point they were inaccessible, and we were wondering, can we achieve pre-balance even in these gross deformities? The main feature of Mako robot is the precise bone cuts. We took advantage of this feature and decided why not make a provisional posteromedial cut, which would give us access to remove these osteophytes and do the posteromedial release. Lo and behold, in almost all our patients, we were able to balance these knees in extension by doing these 2 steps in a graded fashion. So we are proposing a new workflow known as the enhanced mid-resection workflow, where pre-balance is achieved using 3 cuts. Let us go back to our case. This is a 28-degree varus deformity. Initially, we've removed the osteophytes from the femoral as well as the tibial side. This gives us some correction, and the varus came down from 28 degrees to 19 degrees. Initial gap capture is 1423. Now we move on to the pre-resection workflow where we functionally position the implants. So 3-degree varus in the tibia, 1-degree varus in the femur, and the tibia was raised by 3 mm in order to close this lateral gap to 19. And then the cuts were made because pre-balance was not achieved, so mid-resection workflow was used. But even after the femoral cut and the tibial cut and releases, we were unable to balance this knee. So we move on to our modification of the workflow. Using the software, we move the implant down from 8 mm to 4 mm. So this is depicted by these 2 dark lines. Instead of the regular 8 mm cut, we do a 4 mm cut. Once this is done, the osteophytes are removed, the posterior capsule is released, and you can see here from 1423, after the modification of the workflow, we came to 1419, and then with the enhanced mid-resection, we were able to balance it down to 1718, and then you can see the varus has come down from 11 degrees to 4 degrees. You can see the spacer is going in very easily, and then you're able to get the extension gap. Once the extension gap is balanced, we flex the knee, we capture the gaps to be 11 and 18 mm. And then once this is done, we externally rotate to open the medial side, and with further release on the anterior side of the tibia, we were able to open up the gap to 1920. And then using 11 mm poly, we were able to get the gaps perfect to 2020, both in flexion and extension. So this is the post-operative X-ray of this patient, where you can see that the gaps are well matched, and then we had to use a screw for the bone defect. Similar cases where we used the enhanced mid-resection workflow in order to correct these patients. Another severe varus deformity with bone loss, where we had to use a stem as well as bone graft. And again, you can see the poly thickness is almost 11 mm in this patient. Similarly, we use them for gross valgus deformities. This is an orthopedic surgeon who is a hemophiliac who underwent robotic at our center. And then again, severe varus on the right side. So to summarize the workflow, after your initial capture and removal of the osteophytes, you first use the pre-resection workflow in order to balance. If this does not happen, move on to the mid-resection workflow, where the distal femur, proximal tibia are cut and soft tissue releases are done on the tibial side. If the knee is still not balanced, move on to the enhanced mid-resection workflow, where a provisional posteromedial cut is made. The osteophytes are removed from the femoral side this time. Posterior capsule is released. Balance your extension gap, move on to the flexion side, and then balance your flexion gap. So to summarize, enhanced mid-resection workflow is a new workflow that we are proposing, and it is reliable and reproducible to obtain pre-balance by making 3 bone cuts instead of the standard 2 bone cuts. In almost all gross deformities, we were able to use this. The approach optimizes bone cuts and soft tissue releases. Deformity correction is quantifiable. It is not just a subjective feel like in manual. You can actually correct to a number on the screen. And in almost all cases, we've seen that it decreases the size of poly thickness and the level of constraint. Thank you so much for your attention, and I would be happy to take questions during the discussion time. Thank you. Okay, great. So that brings us to the end of the robotic session, and we have Dr. Toomey with us still. Dr. Toomey, my first question to you, and we have Dr. Kushal also online, so he will be there in place of Dr. Adarsh, who can be here today. My first question to you is, we are at a stage in India where we have very few robots, and in discussions like this, we are facing a lot of stiff resistance from other surgeons in terms of accepting this technology. So when you started off back in the US, did you face a similar situation, and how did you go about countering that?
It's interesting that you say that. I'm having more difficulty more recently. So we were the new adopters to the technology way back in 2010 was our first robot acquisition. At that time, a hospital was on board the whole idea. I was able to champion the concept of introducing robotics to our orthopedic program, and they were quite keen on that. That worked pretty well. We got our second robot, was more difficult to get, and we had to go to our foundation. So outside the capital budget of the hospital, we had to rely on charitable donations at the foundation center in order to pull that off. So that's been my experience when we run up against the budget question, that there's been other ways like grateful donors, prior patients, to have the enough finances to pull it off. So you're now go take it one step further, Suhas, and that's like I just have my third robot now at the physician-owned surgical center, where my surgeon orthopedic colleagues weren't keen on paying any money towards this. So to make this work, we had to come have a creative deal orchestrated with Stryker, which was mostly based on volume. And I don't know if you have that opportunity there, but basically we pay as we go type of thing. And it's a volume-based option, which didn't require my surgeon partners to, to write a check in order to pay to finance this. But to follow that up by saying they have been thoroughly delighted with the patient flow and outcomes that they're seeing at the hands of me and my colleagues that are doing Mako robotic assisted surgery at their center. So it's worked out well for everyone.
Yeah. So I believe the decision making is at 2 levels. One is at the clinical level, where the surgeon has to be convinced about its utility and how superior it is in terms of clinical results. And the second one is it has to make financial sense to the acquisition, which is very subjective. It is based on the surgeon's volume and his ability to negotiate a deal with the company. To the former, I think all 4 surgeons from Sunshine, we can vouch to the fact that we were probably in the middle in terms of the ability of the robot. We were very convinced about the partial knee application and the total knee application. But fast forward to 1 year now, we've seen our results in total knees, and we're far more convinced now than ever before. And we've almost reached to the advocacy phase of the graph that you've shown, that now we can very confidently tell our patients as well as our colleagues that the robot is actually making a difference.
Yeah, that's what it comes down to is you reach a point where you become a believer in the technology. I mean, there's, doing total hips, I have utmost confidence that the place I'm going to put the acetato component is exactly where it's supposed to be according to my plan. It's better than us with our mechanical means of trying to estimate the orientation of implants. And so that's the challenge we face in talking to our surgeon colleagues is to open up the opportunity for improvement for what we do, and I faced the same thing when I traveled to the UK, with the British system there. They feel the same way that the national health system, they'll never be able to afford to have a robot, but and yet they're still placing them there. So there's ways to do it, but it is a bit of a challenge.
Yeah. The second question I had was your take on our modified mid-resection workflow that we've just presented. Do you see that working in everybody else's hands?
Yeah, I mean, I find it very straightforward. The one question I have for you is I watched your workflow and I noticed that you did your femoral rotation 4 degrees off the TEA and 7 degrees off the posterior columnar axis.
Yes.
Which is fine. I just wonder if you and your colleagues that have been pushing the boundaries on this have found any upper limits of levels of varus or external rotation or internal rotation you've had to do to correct varus or valgus knees that you could share with us, since you guys
Yes.
handle a lot more severe deformities than we do.
Yeah, so great question. In terms of alignment in the coronal view, we don't go beyond 4 degrees of varus, 2 degrees or 3 degrees on the tibia, probably a degree on the femur, more on the tibial side. In terms of external rotation, we are always very we acknowledge the relationship between the TE and the PCA, but doesn't matter how much rotation I give, I go back and check the trochlear groove and see whether it is still nicely matching the trochlear groove. As long as I'm doing that, I'm happy, and I'm grateful for you to point out the question of internal rotation. And in gross varus deformities, we've very clearly seen that because of the ability of the robot, we can give some amount of internal rotation to the femur in order to close the flexion gap on the medial side, but still have very good tracking because we are able to do that. So in my experience, I've given around 2 degrees of internal rotation on the femoral side, which is just impossible to do using manual surgery.
Exactly. Right. We're doing things that weren't possible before with mechanical instrumentation. And that's the thing to share, like in meetings like this with our colleagues, is we now have at our set these tools, these instruments that we're changing the game in terms of how we can solve the individual anatomical problems. One of the things in the other paper that wasn't mentioned in the advantage was the juxta-articular hardware. That was the one other key feature that is superior to robotics over using the enhanced imaging. Is a lot of times you have ACL screws or IM nails or whatever, that this platform makes it quite easy. And I can speak freely here. I can't speak in the US about this, but I've done many revision knees or conversions of failed partial knees to totals. And just like you talked about, being able to use that imaging to get just below that resection level on the medial tibial tray, tipping just enough varus and enough slope and whatnot, it makes that conversion exceptionally easy to perform for us surgeons, which is just great. But to answer your question one more time, yes, the workflow that you described to me is quite clear. I mean, it takes me 2 seconds to do your calculation. You're having your cut by 4, allows you access to get your curved Lambert osteotome underneath, so you can remove those posterior osteophytes, which frees up your extension gap, so you can better assess your extension gap by relaxing the soft tissue. I'm following you completely. I think it's brilliant, and it's a brilliant solution to a problem that countries like yours that have more severe deformity can apply that in a straightforward fashion.
Great. Dr. Kushal, I wanted your take on alternate alignment strategies. Just achieving them manually is a challenge. Now that we have the robot, what is your take on alternate alignment strategies in total knee?
Yes, as you've shown in the example and even Dr. Adarsh's video, could see how just giving it what we call a functional alignment. That means our traditional teaching is to go 90 degrees to the mechanical axis on the tibia and the femur. This allows you to measure and quantify the alignment, and you can give it a 1 or 2 degrees, as you said, the upper limit 2+2 of varus on the tibia and femur, and give it a more of a functional alignment, which helps in balancing. So we've seen that once we do this, the necessity for a posterior medial release, especially in varus tight medial knees, comes down because you've played around with the implant placement, and therefore you don't have to go all the way back to your semimembranosus and all the way back even further posterior. So that's been helping us in that sense.
Yeah, and the other question I had is invariably when robots are compared, people put CT as a disadvantage to Mako as compared to other imageless systems. So your take on that?
I've never really understood that argument because this is an image-based system like the Mako, where CT, I mean, the only disadvantage for our setup is probably the cost. But when you have the 100% accuracy of your anatomy, and then you can load it onto the software and track it real time after bone registration, how can that be a disadvantage? So I don't buy that argument.
Yeah, it's sufficiently proven that over imageless, the accuracy, the bony landmark selection, and the input we have during surgery is just far beyond the radiation exposure and the costs that people talk about.
Exactly.
Can I add a comment? Just you know, we mentioned it or alluded to the big data and the connectivity. You know, once 5G comes online worldwide, you know, these robots are going to be able to start talking to each other. And I've had glimpses of the next iterations of software updates for the Mako. You know, in the direction we're headed with this technology is the point where we're going to be able to learn from your cases and my cases are going to be shared data. And we're going to be able to figure out, they're going to be able to compute it. So there's an algorithm, a mathematical algorithm on the computer that helps us solve the solution much more rapidly than you and I can, because we're still doing a little bit trial and error with our surgical hands. But the next level of iteration of this robotic technology is going to make it even easier to do, much like your iOS software update on your cell phone.
Yeah, and then even with that respect, I think Mako is far ahead than any other company right now because of the amount and the wealth of data they have in terms of patient information. I think that brings us to the end of this session. Unless there are any questions in the chat, I can't thank Dr. Sean Toomey enough. I know you have a lot going on professionally, personally, but thank you so much for sparing your time and talking with us today.
It's my pleasure. I enjoy engaging with my surgeon colleagues over there in India, and I hope to see you soon in person someday. My best to you all. Stay safe.
Thank you so much, Dr. Kushal and Dr. Praharsha. And that brings us to the end of this session and back to the TOSACON admin team. Thank you so much.
Thank you so much, sir. That was a great session, sir. Thanks for your valuable time.
Bye.
Let's start with the free papers. I now invite Dr. VBN Prasad Rao Garu.
Okay, we are starting the free session.
And Dr. Kushal sir to look forward with the free paper session.
So very good afternoon to all. Good afternoon, Dr. VBN sir.
Good afternoon, everyone. Good afternoon.
Exhausting session in the morning from 9 a.m. till now. I think we're running 45 minutes behind, but we'll start off immediately with the free paper session if you're okay with that, sir. Yeah. So we'll start with the first free paper, that is by Dr. Biru Sumant. The topic is a retrospective study on functional outcome of posterior cruciate ligament substituted total knee arthroplasty. So can we have that on the screen, please?
My topic, a retrospective study on functional outcome of posterior cruciate ligament substituted total knee arthroplasty. Myself, Dr. Biru Sumant, postgraduate in orthopedics, MNR Medical College Hospital, Sangareddy. Co-author, Dr. K. Vijayabhaskar Reddy, Professor, Department of Orthopedics, MNR Medical College Hospital, Sangareddy. Total knee arthroplasty surgery is considered as treatment of choice in cases of advanced osteoarthritis where the conservative management have been failed. It gives good pain relief, functional improvement of knee, and correction of deformity. Common cause of osteoarthritis of knee in adults includes osteoarthritis, rheumatoid arthritis, post-traumatic arthritis, or secondary osteoarthritis, and other type of inflammatory arthritis. Aims and objectives: to study the clinical and functional outcomes following posterior cruciate ligament substituted total knee replacement. Outcomes are measured using Oxford knee scoring system. Materials and methods: study design, a retrospective study conducted at MNR Medical College and Hospital, Sangareddy. Study size includes 20 patients. Duration from February 2018 to January 2020. Inclusion criteria: study includes cases of primary osteoarthritis, traumatic osteoarthritis, age between 50 to 70 years, both male and female, genu-varus and valgus deformity, patients walking with the help of walking aids or with the help of assistance before surgery. Both bilateral and unilateral cases were included. Exclusion criteria: age less than 50 years, age more than 70 years, patients having gross medial and lateral collateral ligament instability, infective conditions like septic arthritis, previous surgical history to knee including arthroscopy, genu recurvatum, progressive neuromuscular disorders, revision TKR, ankylosed knee, dermatological conditions and infective conditions around knee, patients with fixed flexion deformity more than 40 degrees were excluded. Materials and methods: surgeries performed at Orthopedic Operation Theatre, MNR Medical College, Sangareddy. Total 29 total knee replacements were done on 20 patients. Anesthesia, both epidural and spinal anesthesia were given in supine position with knee 90 degrees of flexion. Approach: a standard midline medial parapatellar approach was used. Follow-up for minimum period of 1 month, that is from 1 month, 3 months, 6 months, and up to 1 year. And functional clinical outcome assessed using Oxford scoring system. Preoperative evaluation: details history of all patients were taken. All patients were assessed clinically and functionally using Oxford scoring system. Preoperative medical evaluation were done. Any potential complications of life-threatening or limb-threatening were evaluated. Out of 20 patients, 12 patients had only varus deformity and 8 patients had both varus and fixed flexion deformity. Radiological assessment done using standard AP and lateral views. Any collateral ligament laxity, subluxation of tibia, presence of osteophytes, any bone defects were evaluated. These are the preoperative X-rays showing severe osteoarthritic changes. Operative technique: using a standard midline medial parapatellar approach with the knee in 90 degrees of flexion. Bone cuts: distal femoral 5 to 7 degrees of valgus cut is made with the help of intramedullary jig, and tibial cut is done perpendicular to the mechanical axis using extramedullary jig. Especially in our surgeries, patella were not resurfaced and circumferential denervation of patella was done. This is an intraoperative picture showing excellent correction of deformity and alignment along the mechanical axis. These are the postoperative X-rays showing maintenance of articular surface and correction of deformities. This is a case of bilateral total knee replacement done 1 week apart and showing excellent correction of deformity. Advantages of PCL substituted over PCL retaining total knee arthroplasty: it gives excellent surgical exposure, increased range of movement, increased post-operative knee flexion, decreased wear and tear, and it gives uniform femoral rollback. Decreased post-operative knee pain and limitations of knee extension were seen in our cases, especially due to patella were not resurfaced and circumferential denervation was done. Results: there was significant improvement in function and we have achieved excellent results in 19 patients, and 1 patient had post-operative suprapatellar fullness which was related with medications for 3 weeks. Unilateral cases were discharged after 1 week and bilateral cases were discharged after 2 weeks. Oxford scoring system consists of 12 questionnaires on the activities of daily based activities. It consists of 12 items, out of which 5 for assessing pain and 7 for assessing function. And weightage from 1 to 5 score ranging total possible score ranging from 12 to 60. Higher score indicates better outcome. In our study, 5 patients were between 50 to 60 years and 10 patients were between 60 to 65 years and 5 patients were between 65 to 68 years. Sex distribution: our study consists of 60% of male and 40% of female distribution. Out of 12 patients had only varus deformity and 8 patients had varus with fixed flexion deformity. Total number of sites affected: 6 were right knees and 5 were left knees and 9 bilateral cases. Total 29 knees were operated. According to Oxford scoring system, we have achieved 18 patients achieved excellent score and one good and 1 fair and 0 poor results. Conclusion: based on our experience and result, we conclude that total knee arthroplasty improves the functional ability of the patients postoperatively. They have pain-free joint movements and with correction of deformity. In patients with advanced osteoarthritis, gross varus deformity and flexion deformity, posterior cruciate ligament sacrificing total knee replacement will give excellent mobility.
Yeah, Dr. Sumant.
Good afternoon, sir.
Yeah, good afternoon, Dr. Sumant. Good presentation. So you talked about Oxford knee score results.
Yes.
What was the timeline? When did you get those results?
During the follow-up period, sir.
Which follow-up?
Follow-up of the patient, sir.
Yeah, which after the surgery?
Yes, sir.
You said excellent in 18, 1 and 1. So at what point of time was that? How long after operation?
Sir, after 6 months of follow-up, sir.
6 months. Okay. Okay. And in your conclusion, there you did not want to compare it to cruciate retaining. You just wanted to see the functional outcome with a PCL substrate. Did you use any ultra-congruent polys? All of them were with a posterior stability. Okay. Any questions, Vibin sir?
I think he has done a good job. Only one thing is any operative photographs and what is range of flexion, because sometimes range of flexion will be different in cruciate retaining and cruciate sacrificing knees. Anything you want to comment on this? Because he studied 20 cases.
Yes, sir. A good range of.
Your voice is breaking, Dr. Sumant.
Yes, sir.
Yeah. Any reason you excluded recurvatum knees? Yeah, Dr. Sumant. Any reason you excluded recurvatum knees?
Yes, sir. We have excluded recurvatum to postoperative for easy evaluation for our range of movements.
Sorry?
We have deliberately excluded the recurvatum case.
Yeah, why? Okay. Okay, Dr. Sumant. Well done. And we'll go on to the next topic. So while I read out the topic, the video can be put up. Supremacy of hydroxyapatite coated femoral stem with uncemented cup in hip replacement, a midterm analysis of functional and radiological outcomes by Dr. Muhammad Ashik.
The supremacy of hydroxy-coated femoral stem with uncemented cup in hip replacement, a radiological and functional outcome. So the primary stability of a stem in cementless hip arthroplasty is based on a tight press fit of the implant into the bone. A definitive or long-term fixation of a cementless hip arthroplasty requires proper osseointegration and a firm and reliable adherence between the bone and the process. Hydroxyapatite is a promising coating material with the potential to achieve biological fixation between the horse bone and process. In terms of this chemical property, it is an osteoconductive calcium phosphate molecule similar to human bone. So it will accelerate and induce the osseointegration of the processes, improving their long-term survival. So hydroxyapatite coated implant fixation lies in its direct attachment of the implant to the horse bone without an interposed fibrous tissue. It has been shown that the interface between the processes and ingrowing bone can remodel with time and maintain stability between the bone and the processes. Hydroxyapatite coating accelerates bone healing and enhances biological fixation of the implant due to its bioavailability and osteoconductive potential. The aim of the study is to evaluate the clinical and radiological outcome of hydroxyapatite stem with unsymptomatic cup in THR. This is a retrospective study. The case is done from 2013 to 2017 of 57 HIP. The study was done in Sri Ramchandra Institute of Higher Education, and the main functional scoring unit was Oxford HIP. So the patients included in the study were patients who are more than 18 years and patients undergoing THR with hydroxyapatite coated femoral stem with unsymptomatic cup for primary and secondary arthritis. Post-traumatic arthritis, AVN of femoral head, neck of femur fracture, and neck of femur fracture. Patient is willing and able to comply with post-operative scheduled clinical and radiological evaluations. So the patients excluded were age less than 18 years with revision THR, patient with an active infection within affected. Methodology. We collected the patient's detailed history, diagnosis, preoperative range of movement, Harris hip score, X-ray of the hip APV of all the patients who underwent primary THR using hydroxy-coated femoral stem with uncemented porous coated press fit cup. All the patients will be undergoing X-ray and Harris hip score at the end of 3 years. All the procedures were done by a solitary arthroplasty expert. Radiologically, we will be assessing the patient X-ray pelvis with both hip AP and lateral view, and post-operative radiograph assessed by Gruen zones for femoral component and Charnley zones for acetabular component. The fixation and stability of the femoral stem were assessed using Young's radiological score. So sample case 1, a 45-year-old male with arthritis of the left hip. The pre-operative Harris hip score had a scoring of 24 with poor, which was 26, and this was the pre-op X-ray, and this was the immediate post-op hydroxyapatite femoral stem with unsymptomatic cup. And this is 3 months post-op X-ray with 1 year and 3 years post-op X-ray. So clinically, the patient had a very good functional outcome with 93 Harris hip score. And there was no acetabular cup migration. Grading showed a presence of spot welt and absence of calcar hypertrophy, which means there is a good bone ingrowth, and Manley classification showed a stable with osseous ingrowth. Case 2 is about a 51-year-old male with chronic neck of femur pre-op X-ray and 1 year and 3 year post-op X-ray. Patient had an excellent functional Harris hip score of about 100, and there was no acetabular cup migration, and Young scoring showed presence of spot welt pedestal formation but an absence of calcar. So radiologically, we can see the Manley classification, which was stable with osseous ingrowth, and Young's grading score showed a bony ingrowth of 18.5. So case 3 is a 52-year-old male with the left neck of femur fracture non-union. Patient's preoperative Harris hip score was poor, 22. The preoperative X-ray, we can see the neck of femur non-union. The immediate post-op X-ray, 3 months post-op and 1 year post-op, and 3 years post-op X-ray. The functional outcome, the patient had an excellent Harris hip score of about 94. Coming to the results, most of the patients of the 52 lie between 41 to 60 years. Distribution, 32 were male and 20 were female. Out of the 57 hip study, 21 were right-sided and 26 were left-sided. 5 were bilateral. On diagnosis, the most common diagnosis was primary hip OA. The 25% was in neck of femur fracture, and the next 17% was in secondary chronic hip arthritis. Coming to the radiological outcome, the spot welt and pedestal showed that out of the 57 patient study, 86% had achieved spot welt formation and 57 achieved pedestal formation. Coming to Young's radiological scoring, all 100% were classified with stable and osseous ingrowth by Young's criteria at the final follow-up. Coming to the functional outcome based on the Harris hip score, the pre-op was 40 and it improved to a mean of 90, 92 and 93 at the end of 6 weeks, 1 year. So at the end of 3 years, it was about 93 out of 100. So coming to the discussion, in our study, 100% survivorship rate of hydroxyapatite coated femoral stem and porous coated acetabular cups were observed. Hydroxyapatite coating generates spot welding of bone and processes which provides long-term stability in uncemented THR. None of the patient had an unstable pedestal formation. All these results confirm that excellent long-term stability of hydroxy-coated processes. Concluding, I state that the hydroxyapatite coated femoral stem yielded excellent to good clinical results in our midterm follow-up. With HA coated stem, there was no clinical significant anterior type pain. The life expectancy of hydroxyapatite coated stem showed 100% survival rate at midterm follow-up. No signs of implant instability such as stem migration, unstable pedestal formation, particle setting, radial lucid lines were noted with the use of hydroxyapatite coated stem. porous coated press fit acetabular cup shows favorable clinical and radiological outcome and excellent survivorship at midterm follow. Thank you. So these are the references for this study.
Yeah, well done, Dr. Ashik. I request VBN sir.
No, very good presentation. He has done a very good study. Only question is, according to DORS classification, have you got anything? All these things belong to DOR A or B or C, anything? Can you comment? Because sometimes these things, DOR C may give some problems. So just I want to know what you have done anything in that line, in that study.
No, sir, we didn't go in deep about DORS classifications. For all the patients who required a THR only were taken into study. So we didn't, we could have done it, but we didn't realize about that.
Reason is sometimes DOR C, it will be more cylindrical. This type of stems may not do well. Maybe cemented stems may be required in some cases. So we should be careful. And second thing is sometimes even DOR A, funnel type, sometimes it requires a reaming, and we have to go for a reaming and metaphysical fit. We have to see peroperatively. These are the extra points which we are learning actually now these years.
Yes, sir.
In some cases make you trouble. Just I'm telling you because you have done a good presentation. These things further details in the especially hydroxy-coated coral stems. These are the anyway, this is a good presentation.
Just the audio, Ashik. Next time, just make sure it's clean throughout. We were breaking the audio is breaking.
Yes, sir. Yes, sir. Thank you.
Is the yours only next one, right?
Yes, sir.
Yeah. So the next one is utilization of hinged knee prosthesis for grossly deformed complex knees. A midterm analysis of functional radiological outcomes. Can we have that, please?
The utilization of hinge knee prosthesis for grossly deformed complex knees, radiological and functional outcome. So we know TKR is the most common procedure in modern orthopedics, but lack of information, fear of surgery, and the lack of motivation usually lead the patient to present late with gross involvement of the ligamentous structures and severe deformities. So for these patients, we have to use a hinge knee system for such cases, which is a constrained knee prosthesis. So usually we use hinge knee system as the last available option for severe bad cases. So this is an example of an endo model hinge knee prosthesis. So indications are that for severely deformed knees, severe ligament laxity or imbalance, when we resect a tumor around the distal femur or proximal tibia, and it is a choice of implant for all revision TKR, and severe end-stage OA or RA, traumatic dislocation of the knee, gross flexion extension gap imbalance, and ankylosing of the knee with intense varus and valgus of the knee. The advantages of that, in all the above condition, there is ligament or soft tissue or bone loss or all which are compromised. So this is substantiated by the device mechanics to distribute the contract stress between the femur and the tibia, leading to the axial rotation of the same. So the loading stress is also reduced in this system, being effective in non-oncological indication at the primary system. So it can be used as an implant of choice for grossly unstable knee. So the disadvantage is that the bone dissection is more than a conventional TKR, and there's an increased stress transmission to the bone processing interface, and it's the last option available. So aim of the study is to evaluate the clinical and radiological outcome of this hinge knee, which is a retrospective study done from 2018 to 2013 to 18 of 9 knees done in SRMC Chennai. And we included the patients with total insufficiency of one of the collateral ligaments, with the large flexion or extension gap, with fixed varus and valgus greater than 20 degree, with severe OA and RA of knee, or traumatic dislocation of the knee joint, or massive bone destruction of the tibial plateau femoral condyle with loss of ligament origin on insertion. We excluded the patients who undergo revision arthroplasty, infected knees, and neuropathic joint. So as the patient presents, we take the complaints and the duration and mode of injury if present and time of presentation from the injury. Then the patient undergoes all clinical examination and X-ray AP and lateral of the knee is taken. Then the patient is selected as per the inclusion-exclusion criteria, and we assess preoperatively and at the end of 4 years with the help of visual analog score, combined knee society score, and Oxford knee score. So all the 8 patients underwent hinge knee arthroplasty done by a single arthroplasty expert, with X-ray taken at POD 2 and dressing was done in POD 2, 5, and 8. So radiologically, the patient was assessed for the component positioning, and it is considered to be neutral if the tibiofemoral angle was within 5 degrees from neutral, and post-operative radiographs were evaluated for signs of loosening and bone loss. So post-operatively, the protocol was up to 3 years, and we assessed the knee society score, OMAC score, and Oxford score, and X-ray, AP, and lateral. So case 1 sample is an end-stage arthritis of the right knee with global instability of an 88-year-old female who had complaints of
bilateral knee pain for the past 20 years with severe pain while walking and climbing stairs. On examination of the right knee, we found the patient had range of motion of up to only 70 degrees with varus, valgus, anterior drawer and posterior drawer test being positive. So this is the pre-op X-ray. We can see how there is ligament laxity, and this is the pre-op X-ray. There's gross subluxation or dislocation of the knee. An intraoperative picture, there was so much of arthritic changes and was gross instability seen. This is the hinge knee implant that we used. So post-op, clinically, the patient had a very good range of movements, no extension lag, up to 0 to 120 degree was the range of movement at the end of 40 months. So the second case example is about a rheumatoid arthritis with right knee subluxation of a 53-year-old female who had pain for the past 12 years, and she's a known case of rheumatoid arthritis on steroids and DMARDs for the past 10 years. On examination of the right knee, she had a range of movements of only up to 20 to 70 degrees with FFT of 20 degrees with varus valgus stress test being positive. So this is a pre-op clinical picture, and the pre-op X-ray we can see a subluxation of the right knee joint. This is the pre-op X-ray, and intraoperatively the process is in place, and this is the post-op X-ray of hinge knee processes. The patient had a very good range of movements, and up to 0 to 100 degrees were recorded at the end of 4 years. So the case 3 is an example of a posterior dislocation of the right knee of a 58-year-old female who had an alleged history of RTA. The patient had a range of movement of only up to 20 to 40 degrees with skin necrosis present of the anterior aspect of the knee. Since the patient had this problem, the first, this is the pre-op X-ray, and since the patient had the problem, the patient underwent a right knee spanning X-fix application and Steeman application on 4th month of 2016. 2 months later, the X-fix was removed, and 3 months later, the patient underwent a right knee hinged total knee replacement. And this is the initial pre-op X-ray, and this is following the hinge knee replacement. So this is a range of movement of the right knee present, and it improved from 20 to 40 up to 0 to 90 degrees. So number of cases done were 8 with 5 female and 3 male patients with 6 right-sided knees and 2 left-sided knees. And the range of movement improved from 60 to 105 at the end of 40 months, and knees society score out of 200 was improved from 71 to 144.7 at the end of 40 months. Oxford knee score improved from 13 to 30.9. And radiologically, the tibiofemoral axis were maintained in all the cases with no loosening of implants were observed. Clinically, none of the patients' knee pain or function worsened, and all patients reported an improved range of movements and pain relief. So on discussion, the most important finding in this report is about the use of hinge knee system as a primary implant of choice in different case scenarios. Most eminently, the 4-year implant survivorship is good and failure and complication free. So the added advantage of using such a rotating hinge knee system is because in cases of global instability, poor bone stock in elderly population, and the patients encounter significant improvement in the function, pain, and range of movement of the operative knee, considering their preoperative knee statuses. Hinge knee continues to be the value of choice as the primary implant of choice in global instability or severe deformity. There is definitely a future for rotating hinge knee system for a primary TCAR as a complex cases. These are the
Yeah, very well done, Dr. Ashik. You're there? You're online?
Yes, sir.
Yeah.
Yes, sir. Thank you, sir.
Yeah, nice one. So a few questions.
Yes, sir.
Whatever the knees were, because most were subluxated and some had just a plain deformity. Did you predetermine that this is going to be a hinge?
Yes, sir. That was the plan, sir. So we didn't want to first fix it as a primary, then go for a revision. We wanted it to be the hinge knee primary as the primary implant of choice, sir. So we selected cases that wanted that had a gross ligamented instability. So we just want to assess whether hinge knee will give us a better result when we are using as a primary implant of choice, because most of the cases that we use for a normal total knee replacement for such a gross instability, gross deformities, ending up as a revision replacement in very early stage, sir. So
because
we thought
there were
that
some young patients that you put up there. Was it not valid to try a primary in them? That was my question, basically.
Because previously we thought that if primary is going in for revision, we just want to give it a try whether this hinge knee might help them in such deformed cases.
Okay. And in these presentations, no, don't put so many, like 5-6 slides of introduction. It is assumed that it's known, so you can directly go to your study. Just one introduction slide is good. Good one, Ashik. VPN, sir?
Kaushik, am I audible?
Yes, sir.
Kaushik, it is a good presentation. Only one thing is, in your first case, for me, it looks a neuropathic joint. Because in certain cases, we should be careful because the very extensive osteoarthritic changes were there. So neuropathic joint, we have to consider a neurology consultation is important because sometimes this will be a progressive neuropathy. In a progressive type of neuropathy, if you do joint replacement, it may fail. Probably some other procedure have to be taken. That is one thing we have to note, especially very gross thing. And as Dr. Kushal told, the life of the hinge joint is probably 10 to 12 years. Am I correct, Kushal? Life of the hinge, probably 10 years or 12 years. So nothing wrong in have a primary setup and trial reduction, everything in the OT. If you are not happy, then go for a hinge. That is what we practice. Just is a suggestion, so that primary can go for a long time and then we can go for a hinge.
Hinge again.
This is only my suggestion. Otherwise, it's a very good presentation and done good.
Last question, Dr. Ashik.
Yes, sir.
Follow up, you said 3 years, no?
Sorry, sir. It was actually 4 years.
The slide, I thought I saw 3 years, and then last May I saw 4 years.
It's actually like almost 40 months, sir.
40 months. So
40 months it was.
Take care when we are using the word midterm. The heading is midterm, no? Midterm is typically around 5.
Right,
Long
sir.
term is more than 10. So before you label, because that's a major heading point, no, for you. So
Yes, sir.
This, whenever you're starting completing, you just follow these up further, no? It is
Yes,
2021, so you can just extend it.
Follow it
And
as my midterm.
5 years and then okay.
Right. Thank you.
Okay. So we'll move on to the next one. Efficacy of tranexamic acid in controlling blood loss in unilateral TK by Dr. Sriharsha. Yeah, admin, can we have the video? Thank you.
Good afternoon, everyone. I am Dr. Sriharsha, final year postgraduate, Department of Orthopedics, Kamlani Institute of Medical Sciences, going to present my study on efficacy of tranexamic acid in controlling the blood loss in unilateral total knee arthroplasty, guided by Dr. Bonreka Madam, Professor and HOD, Orthopedics, KIMS, Marketpalli. TKA is an ideal surgical option for treating severe pain in the arthritic knee. TKA provides significant pain relief and improvement in the quality of life. However, TKA is not without complications. TKA has been shown to have significant blood loss that sometimes requires the blood transfusions. In some studies, transfusion rate after the TKA has been as high as 30%. It is known that blood component administration increases the risk of infections and the immune reactions. TXA, tranexamic acid, is an analog of lysine. It binds to the 5 lysine binding sites on plasminogen, thereby preventing the formation of the complex between plasminogen fibrin and the TPA, thus inhibiting the fibrinolysis. TXA is a synthetic product that is inexpensive and easily available. This study was aimed to ascertain the effectiveness of the tranexamic acid in minimizing the intraoperative and postoperative blood loss in total knee arthroplasty. Coming to the metrics and the methods. This was a prospective randomized case control study. The study period was 6 months from October 2020 to March 2021. A total number of 30 patients who underwent the total knee arthroplasty were enrolled in the study. The patients with the primary OA knee undergoing total knee arthroplasty were included in the study, whereas the patients with the secondary OA knee and those with the past history of the thromboembolic episodes were excluded from the study. The written informed consent was taken from the patients who were included in the study. The patients were grouped as treatment case groups and the control groups. The case and the control groups were selected by the purpose of sampling, and the randomization was done by the rules of the odds and the events. In 15 subjects of the treatment group, injection tranexamic acid 1 gram was administered as a slow bolus over 5 minutes intravenously, 10 minutes before tonic infusion, and it was repeated 3 hours after the surgery. The intraoperative blood loss, preoperative, and the postoperative hemoglobin and the blood collected in the drain for the 2 days were measured in both groups. The number of the blood transfusions required for each patient was also noted. Coming to the results, a total of the 30 patients randomly divided into 2 groups were evaluated. Group 1 having 15 patients with 8 men and 7 women, mean age being 66.4 years, were given IV tranexamic acid, and Group 2 having 15 patients with 6 men and 9 women were taken as control groups. Coming to this table, it shows the average pre-op and the post-op hemoglobin, the difference being 1.4 gram percent in the Group 1 and 2 gram percent in the Group 2, that is control group. P-value being 0.039, indicating that the hemoglobin drop in the control group is significant. This is a bar diagram which shows the preoperative hemoglobin and the postoperative hemoglobin values in case and control groups. The mean preoperative hemoglobin was 11.2 grams in Group 1 and 10.9 grams in Group 2, whereas the mean postoperative hemoglobin was 9.8 grams in Group 1 and 8.9 grams in Group 2. The decrease in the hemoglobin in group 1 was only 12.5%, whereas in group 2 it was 18.3%. The mean intraoperative blood loss was 593.3 ml in group 1 and 825.6 ml in group 2. The mean drain output was 242 ml in group 1 and 385.2 ml in group 2. The mean total amount of the bleeding was measured as 835.3 ml in group 1 and 1210.8 ml in group 2. Mean amount of blood loss was observed to be decreased by 31% in group 1. In this table, we can see the intraoperative blood loss, drain output, and the total blood loss. P value is 0.001, showing that the difference in the blood loss between the case and the controls is significant. In group 1, out of the 15 patients, 5 patients required a single unit of packed red blood cells transfusion, whereas in group 2, 9 patients requiring packed red blood cells transfusion, where 4 patients received the 2 units and the remaining 5 patients received 1 unit each. Tranexamic acid is an antifibrinolytic drug which by competitive inhibition prevents the conversion of the plasminogen to the plasmin, thereby preventing the breakdown of the clot. Both the pro-coagulative factors and the fibrinolysis are activated by the surgical trauma. In major surgical procedures, large amount of the tissues will be exposed to the injury. These tissues will release the enzymes, primarily TPA, activating the fibrinolytic system. The fibrinolytic response is more pronounced intraoperatively and early postoperatively. In this study, it has been found that systemic tranexamic acid administered reduced the amount of the blood loss and decreased the need for the blood transfusion without increasing complication rates after the surgery. A study carried out by Mushizaki et al. With 140 patients found that with clamping of the drain after the tranexamic acid injection, total blood loss and the mean transfusion volume were decreased in comparison with those who were not given tranexamic acid injection. A prospective study by the Article Andrew et al., which evaluated 71 unilateral primary TKA patients, found that as a result of giving tranexamic acid at 10 mg per kg doses through infusion before 50 twice infusion before 15 minutes, the infusion of the tourniquet and 3 hours after the surgery, the transfusion rates fell from 37 to 0. Hence, it can be concluded that tranexamic acid reduces the intraoperative and postoperative blood loss and fall in the HB level in our patients who underwent total knee arthroplasty. Hence, its regular use in TKA can be considered. Here are my references. Thank you.
Yeah, Dr. Harsha, hi.
Hi, sir.
Yeah, good one. A few questions. Intra blood loss you measured. No? How did you measure it?
Sir, we measured it by counting the gauze blood soaked in the gauze pieces and the mops, sir, and also in the suction drain. Based on the as gauze pieces, we have a fully soaked gauze piece was taken as a 40 ml, sir, and a partially soaked gauze piece was taken as 10 to 20 ml, and mop is considered as 80 to 110 ml, sir, and the remaining blood collected in the suction drain is also measured. Based on this, we calculated it as intraoperative blood loss, sir.
So how did you get these values? 20, 40, 100 for gauze piece and
sir, actually, we have collected it from the previous data which was available as from the references. Based on that, we have calculated that, sir.
Okay, and
that is a very good question, Kushal. Actually, how to know the value? The realistic way to do is first we have to take a weighing machine and put that mop and to know the weight. After that, how much soaked mop also put it and know the weight. The difference between these two weights will give roughly the correct weight. That is the way we have to do it. Actually, long back, Dr. Mullaji, 20 years back, Dr. Mullaji has done this study and he standardized something. Probably you might have taken these values from your literature. Am I correct? Have you measured like this? What I told, measuring unmopped and again mopped, so soaked and unsoaked mops weight and taking into consideration. So that is a detailed study already done, but probably you might have taken those values from your this thing. But there is a lot of confusion regarding what is the size and what is the amount. You have to go in a very detail because realistic way you have to do this. That is why we have to do it.
Did you use a tourniquet or no?
Yes, sir. We have used it, sir.
You still got
10 minutes. Sir, actually 10 minutes before the tourniquet inflation, we have given the drug, sir.
No. My question is, despite tourniquet, you got 800 to 900 ml blood loss average?
Yes, sir.
And post-op, you said transfusion requirement also went down. How did you assess one patient requires transfusion, another one doesn't require transfusion?
Actually, we have post-operatively we have checked for the drain amount, sir, and also post-op hemoglobin was measured. When the post-op hemoglobin was less than 10, then we have considered the blood transfusion, sir. So the total number of transfusions given for the patients was calculated, and it was measured in both the control and the case groups.
So pre-op all had more than 10?
Yes, sir. Pre-operatively, it
Suppose
was.
It fell from 14 to 11. You will not transfuse?
No, sir. Actually, when it was less than 10 only, we considered blood transfusion, sir. Otherwise, we have not done.
Okay.
Just one question. During surgical technique, have you taken any measures to control this unnecessary bleeding? Can you stop that bleeding during your surgical dissection of the knee exposure? Have you taken any measures during surgical dissection, surgical exposure?
After surgical exposure, through cauterization and appropriate placement of mops and pads, we have done that, sir.
No, here,
Otherwise,
during surgical technique, actually, there are 2 points where constant bleeders will be there. One is suprapatellar synovial thing. When you are dissecting, you can see the genicular vessels, both superior genicular and middle genicular, both medial side and lateral side. We have to cauterize it. And also after exposure of the tibia, lateral side, we should not go close to the lateral popliteal nerve, but there will be some vessels. This also if you cauterize. If you do this cauterization during your surgical technique, bleeding will be less. This is what we found in Sunshine, and we are doing regularly that one during our surgical exposure. What you are telling is after cutting and everything, that is fine. But before that also we can control the bleeding. So that bleeding will be minimal. Okay, actually we don't use drain because bleeding will be very minimal even in bilateral case. Any good presentation, this is only surgical take I thought. Thank you. Good.
Thank you.
Yeah. So we'll go to Dr. Bhavya Mathur, functional and radiological outcomes in patients undergoing sequential soft tissue release during total hip for chronic arthritis of hip with fixed deformity.
Hello everyone, my title is Functional and Radiological Outcome in Patients Undergoing Sequential Soft Tissue Release During Total Hip Replacement for Chronic Arthritis of the Hip with Fixed Deformities. I am Dr. Bhavya Mathur, Department of Orthopedic Surgery, Sri Ramachandra Institute of Higher Education and Research. An introduction, total hip replacement is one of the most frequent and successful reconstructive procedures, and osteoarthritis of the hip is one of the most common indications for total hip replacement. The hip in chronic arthritis presents with varied deformities. Often it is flexed, externally rotated, and adducted with shortening. Inadequate soft tissue balancing is one of the major yet often underemphasized cause of failure of primary hip replacement, especially in long cases of chronic arthritis of hip. The reduction of postoperative pain and improvement of function after a total hip replacement can be achieved by proper soft tissue balancing, stability, muscle strength, and limb length equality. The aim of our study was to study the functional and radiological outcomes in patients undergoing sequential soft tissue release during total hip replacement for chronic arthritis of the hip with fixed deformities. Our sample size was 27 patients, a total of 32 hips, as 5 patients underwent bilateral THR. We included all patients undergoing THR for chronic arthritis and patients with fixed deformities of the hip. And we had excluded all patients undergoing THR for neck of femur fractures and patients undergoing revision hip replacement. Preoperatively, all patients were evaluated clinically and radiologically. A detailed examination of the affected hip was done. Fixed deformities were noted along with any limb length discrepancy, range of movements, and distal neurovascular status. X-ray pelvis of both hips with AP view was taken, and preoperative Harris hip score was taken for each patient. Operative procedure: on the day of surgery, prophylactic antibiotic third generation cephalosporin was given 30 minutes prior to the surgery. All surgeries were performed under spinal plus epidural anesthesia. Under anesthesia, patients were examined for for fixed deformities, and range of motions was checked, and all the cases were operated using posterior approach. The soft tissue releases: if the complete extension was not possible, any contracted anterior capsule, if present, it was excised. In highly deformed cases, ilios was tended. If it was found to be tight, it was elongated by sequential cutting. One point to be noted here is that it must not be completely released because this leads to post-operative weakness while climbing stairs or getting out of a car. If abduction and external rotation was limited to 20 degrees or there was a limitation of adduction, then the release of tensor fasciolati was done. Flexion of the knee was assessed, and if there was inability to flex beyond 90 degrees, iliotibial band was checked for tightness, and it was released at the Gerdy's tubercle. In long-standing cases of excessive shortening and a difficulty in reduction was anticipated. In such cases, pike crusting of the gluteus medius was done at the musculotendinous junction using an 18-gauge needle. If still shortening persisted, an osteotomy of the greater trochanter was done, and it was later fixed with tension band wiring. A standardized post-op protocol was followed. DVT prophylaxis was given in form of subcutaneous low molecular weight heparin. On POD1, patients were taught in-bed mobilization and pelvic lifting exercises. On POD2, wound inspection was done. Patients were made to walk full weight bearing within the limits of pain. X-ray pelvis of both hip was taken. X-ray pelvis of both hip was taken, and radiologically it was assessed for limb length discrepancy, cup and stem position. POD4 wound inspection was done and patients were discharged with the advice of regular follow-up and physiotherapy. POD12 patients were followed up, sutures were removed, and patients were advised to continue the physiotherapy exercise. On POD90, that is 3 months post-op, again functional evaluation was done using Harris hip score and residual deformities were noted. X-ray pelvis was taken and radiologically it was evaluated for cup inclination, stem positioning, and limb length. Out of the total 27 patients, 8 were female and 19 were male. The age ranged from 20 to 70 years, the mean age being 49.93 years. Of the total 32 hip studies, 14 were left-sided and 28 were on the right side. The fixed deformities, 11 hips had a fixed external rotation deformities, 6 had fixed adduction deformity, 5 had fixed flexion deformity, 10 had a combination of deformities. The soft tissue release procedures, posterior capsule and anterior capsule were released most commonly. Gluteus medius pie crusting was done in 9 hips. Adductor tenotomy was done in 10 hips. Iliopsoas, iliotibial band, and rectus were released in 2 hips, and trochanteric osteotomy was done in 2 hips. The results, preoperative and postoperative Harris hip score, all 27 patients had poor preoperative Harris hip score, that is less than 70. Postoperatively, 6 patients had a good outcome and 21 patients had excellent outcome. None of the patients had poor or a fair outcome. This is a comparison of the preoperative and postoperative Harris hip score. Radiological outcome, cup inclination was found to be within range of 40 to 50 degrees. No radiological limb length discrepancy was noted. Stem positioning was center in 28 and varus in 4 hips, and no valgus positioning was noted. So in conclusion, we would like to suggest that soft tissue balancing is of paramount importance in improving the functional and functional outcome of a deformed hip. Adequate soft tissue release eliminates the post-operative groin pain, knee pain, and limb length discrepancy. The release of thickened capsule corrects most of the deformities. Only in case of deformities more than 20 degrees require additional soft tissue release. Thank you.
Yeah, well done. Vivian sir, you want to ask a question?
Am I audible? Am I audible?
Yes.
I think this is a good presentation. Doing these things nice. Only in our experience, as you told, a gross deformed hip with limited movements, especially in rheumatoid and ankylosing spondylitis, like that cases require soft tissue release. Whereas in intracapsular fracture neck femur, which is normal anatomy, rarely we do all this. Just to go to the only one question is: have you done anything regarding limb length discrimination? What is
Sorry, sir, I couldn't hear the last part, sir.
Limb length measuring, limb length shortening or lengthening?
Yes, sir, we did a limb length measuring preoperatively and postoperatively. And postoperatively, we found no limb length discrepancy, sir, in all of the cases.
All the cases, no limb.
Yes, sir.
That's a good presentation.
Thank you, sir.
Yeah, so we can move on.
Yes, yes.
The next one is by Dr. Avinash. Surgical approach and outcome of soft tissue release in valgus knee in primary TK.
Approach and outcome of soft tissue release in valgus knee in primary total knee arthroplasty. 10 to 15% of the patients requiring a primary total knee arthroplasty have valgus deformity, which is less common. The normal anatomical axis is valgus angle of 6 to 7 degrees. Valgus knee is surgically challenging. The two standard approaches are medial and lateral parapatellar approaches. Aim to study the functional and radiological outcome of medial and lateral parapatellar exposures, to study the soft tissue balancing in valgus knee during primary total knee arthroplasty, and also to validate the present concepts of medial and lateral parapatellar approaches. Material and methods, 76 valgus knees were included in my study from March 2016 to December 2017. Follow-up period was up to 2 years. Inclusion criteria: osteoarthritis knees having fixed and reducible valgus deformities. Exclusion criteria: infectious pathology and revision total knee arthroplasty. Preoperative and postoperative evaluation was done clinically, radiologically, and subjectively. Clinically by radio from range of motion, valgus knee deformity, and its reducibility. Radiologically, plain
standing radiographs, and orthoscanogram subjectively by New Oxford knee score and Womack scoring. Medial parapatellar is commonly used. Arthrotomy is done medially, preserving the blood supply of patella as lateral geniculate arteries undisturbed. In our study, valgus less than 20 degrees, medial approach was followed, 67 cases. Lateral parapatellar approach was done in cases having valgus greater than 20 degrees. While lateral parapatellar approach usually allows good exposure of lateral and posterolateral structures. The sequence of releases followed in our study was osteophytes, iliotibial band, posterior capsule, posterior cruciate ligament, posterolateral corner, popliteus, and followed by lateral collateral ligament. Emphasis should be put on optimal external rotation of the femoral implant for better patellar tracking, and medial MCL laxity should be addressed. These pictures are of lateral arthrotomy done in our cases. The first picture is optimal external rotation. The cutting block pins are put parallel to transepicondylar axis, and the other pictures are showing LCL release, popliteal release, and iliotibial band release. The last picture is showing, in case of MCL laxity, advancement of the medial condyle, osteotomy and advancement of the medial condyle was done. Arthrotomy closure, postoperative radiograph, and postoperative clinical picture results. In most of the cases, PCL was sacrificed and posterior stabilizing implant was done in 53 cases. In 22 cases, cruciate retained implant was used. In one case, condylar constrained knee was used. Range of motion. In our study, the mean preoperative range of motion was 106, and 6 weeks postoperative range of motion reduced to 96.27, which gradually increased to the initial level at 1 year follow-up. Tibiofemoral angle preoperatively was 15.45 degrees, which improved to an angle of 2.44 degrees postoperatively. In our study, one patient was lost for follow-up for the entire study duration. Two patients did not come for 3 months post-op. 3 patients did not come for 6 months post-op. New Oxford knee scores improved preoperatively from 14.82 to 41.92 by 1 year postoperative follow-up. Womack scores improved from a preoperative score of 67.29 to 10.3 at 1.5 years follow. Medial proximal tibial angle and lateral distal femoral angles. MPTA preoperatively was 90.35, which improved to 88.33 postoperatively. LDFA changed from 83.22 preoperatively to 88.27 postoperatively. In our study, peroneal palsy was seen in 4 patients, out of which 3 patients recovered by the end of 6 months. Instability in 3 cases, which were operated again for poly exchange, and heterotopic ossification was found in 2 patients. Infection was found in 1 patient for whom revision TKR was done. Medial parapatellar approach is safe in mild to moderate cases. Lateral parapatellar approach, which consists of coronal Z-plasty of retinaculum, lateral retinaculum, is effective in severe valgus knees. For extension gap balancing, lateral soft tissue release is done. For flexion gap balancing, taking appropriate posterior femur cut gives good gaps. Appropriate external rotation alignment of femoral component based on the transepicondylar axis provides good, better patellar tracking. Thank you.
Yeah, nice one. Dr. Avinash, right? Yeah.
Yes, sir.
Yeah, hi. You said the MPTA and MDFA. How did you measure?
MDFA, sir. Sir, we measured those angles on orthoscanogram, sir.
Okay, post-op also.
Post-op also, sir. Post-op also and preoperative also, sir.
Okay, fine.
The ideal MPTA and LDFA is between 85 and 90, sir. Both the angles fell in 85 to 90 degrees range only, sir.
And you didn't, your external rotation you said is based on the TEA.
Yes, sir. Transepicondylar axis, sir.
The reason? Why not PCA?
Sir, we followed that transepicondylar axis in based on previous studies, sir, and we felt it was right, sir.
Okay. So the answer to that is lateral epicondyle is
hypoplastic. So when we place the cutting block, it will be in internal rotation, sir. So for
Optimal X, sir.
Yeah, good. And peroneal palsy, what did you do?
Sir, we put them on methylcobalamin injections and all, sir. 6 months post-operatively, they were all fine, sir.
Did you give steroids?
No, sir, we did not give, sir.
Post-op, what, any limb position that you took?
No, sir.
Specifically, you didn't put it
No,
in
sir. We
section.
They had tingling sensations and hypo, little less sensations on the region of foot, sir. So we just gave methylcobalamin injections, and then they recovered 6 months later, sir. One patient who did not follow up was the other one who had palsy, sir.
So it's recommended to keep the knee in mild flexion, not
Mild
extension.
flexion, sir.
Good, good. VPN, sir, anything?
Nothing special. I don't. He discussed well and he told all the points.
Yeah. Good, good. All of you presented well. I think there is no, I don't think there is a grading and marking and all that. But I think with the interaction, there would have been some good feedback and some points given by VPN. Can we conclude it, sir?
Yes, sir. Thank you so much.
And all. And
also organize the committee for giving opportunity to share this.
Thank you, sir. Thank you, Dr. Prashant, sir, and Dr. VPN, sir. Thank you so much, sir.
Thank you.
With this, we'll conclude the TOSACON 2021. Kindly, everyone, please follow to Hall A to watch live valedictory ceremony. Thank you.